Cardinal function: the exchange of gases between inspired air and blood. Developmentally, the respiratory system is an outgrowth from the ventral wall of the foregut. The midline trachea develops two lateral outpocketings, the lung buds, which eventually divide into branches called lobar bronchi, 3 on the right and 2 on the left, thus giving rise to 3 lobes on the right and 2 on the left. Lobar bronchi allow air to pass in and out of the lung. They have firm cartilaginous walls that provide mechanical support and are lined by columnar ciliated epithelium with abundant subepithelial glands that produce mucus, which impedes the entry of microbes. The right mainstem bronchus is more vertical and directly in line with the trachea. Consequently, aspirated foreign materials such as vomits, blood, and foreign bodies tend to enter the right lung more often than the left. The right and left lobar bronchi branch to give rise to progressively smaller airways that are accompanied by a dual arterial supply from the pulmonary and bronchial arteries. Stally, the bronchi give way to bronchioles, which are distinguished by the lack of cartilage and the presence of submucosal glands within their walls. Further branching: 476 Repop 51 AT L. A bronchioles leads to the terminal bronchioles, which are less than 2 mm in diameter. Beyond the terminal bronchiole is the acinus, a roughly spherical structure with a diameter of about 7 mm. The sinus is composed of a respiratory bronchiole which gives off several alveoli from its sides, alveolar ducts, and alveolar sacs, the blind ends of the respiratory passages, whose walls are formed entirely of alveoli, the site of gas exchange. A cluster of 3 to 5 terminal bronchioles, each with its appended sinus, is referred to as the pulmonary lobule, except for the true vocal cords, which are covered by stratified squamous epithelium. The entire respiratory tree, including the larynx, trachea, and bronchioles, is normally lined mainly by tall, columnar, pseudostratified, ciliated epithelial cells and a smaller population of non-ciliated cells called club cells that secrete a number of protective substances into the airway. There also are scattered cells called ionocytes that express high levels of the cystic fibrosis transmembrane conductance regulator CFTR and appear to modulate the ion content and viscosity of bronchial secretions. In addition, the bronchial mucosa contains neuroendocrine cells with neurosecretory-type granules that can release a variety of factors including serotonin, calcitonin, and gastrin-releasing peptide bomycin. Numerous mucus-secreting goblet cells and submucosal glands also are dispersed throughout the walls of the trachea and bronchi, but not the bronchioles. The microscopic structure of the alveolar walls or alveolar septa consists of the following: Fig. 15. 1. An intertwining network of anastomoses and capillaries lined with endothelial cells. Basement membrane and surrounding interstitium, which separates the endothelial cells from the alveolar lining epithelial cells. In thin portions of the alveolar septum, the basement membranes of epithelium and endothelium are fused, whereas in thicker portions they are separated by an interstitial space pulmonary interstitium containing fine elastic fibers, small bundles of collagen, a few fibroblast-like interstitial cells, smooth muscle cells, mast cells, and rare lymphocytes and monocytes. Type Roman II pneumocyte, alveolar space. Type I pneumocyte, endothelium interstitial, cell capillary. Lumen, type I pneumocyte, alveolar space, endothelium. Figure 15.1 microscopic structure of the alveolar wall. Note that the basement membrane yellow is thin on one side and white where it is continuous with the interstitial space. Portions of interstitial cells are shown. Alveolar epithelium, a continuous layer of 2 cell types, flat, plate-like type I pneumocytes, covering 95% of the alveolar surface. The rounded type Roman II pneumocytes. Type Roman II cells synthesize surfactant which forms a very thin layer over the alveolar cell membranes and are involved in the repair of alveolar damage through their ability to proliferate and give rise to type I cells. Alveolar walls are perforated by numerous pores of Kohn, which permit the passage of bacteria and exudate between adjacent alveoli. See Fig. 15. 35b. Scattered resident alveolar macrophages also are present, either loosely attached to epithelial cells or lying free within the alveolar spaces. Congenital anomalies. Developmental anomalies of the lung are rare. The most common of these include the following. Pulmonary hypoplasia is a defect in the development of both lungs. One may be more affected than the other that results in decreased lung size. It is caused by abnormalities that compress the lung or impede lung expansion in utero, such as congenital diaphragmatic hernia and oligohydramnios. Severe hypoplasia is fatal in the early neonatal period. Foregut cysts arise from abnormal detachments of primitive foregut and are most often located in the hilum or middle mediastin. Depending on the wall structure, these cysts are classified as bronchogenic, most common, esophageal, or enteric. Bronchogenic cyst is rarely connected to the tracheobronchial tree. It is lined by ciliated pseudostratified columnar epithelium and has a wall containing bronchial glands, cartilage, and smooth muscle. It may come to attention due to symptoms resulting from compression of nearby structures or superimposed infection, or may be incidental findings. Pulmonary sequestration is a discrete area of lung tissue that, one, is not connected to the airways and two, has an abnormal blood supply rising from the aorta or its branches. Extralobar sequestration is external to the lung and most commonly present in infants as a mass lesion. It may be associated with other congenital anomalies. Intralobar sequestration occurs within the lung. It usually presents in older children, often due to recurrent localized infections or bronchitis. Other, less common congenital abnormalities include tracheal and bronchial anomalies, atresia, stenosis, tracheoesophageal fistula, vascular anomalies, congenital pulmonary airway malformation, and congenital lobar overinflation and Pfizer. Atelectasis collapse. Atelectasis refers either to incomplete expansion of the lung's neonatal atelectasis or to the collapse of previously inflated lung, and results in areas of poorly aerated pulmonary parenchyma. The main types of acquired atelectasis, which is encountered principally in adults, are the following: 15. 2. Ammonium 576 pain, pulmonary edema or increased capillary permeability due to microvascular injury, non-cardiogenic pulmonary edema, table 15.1. General consideration of edema is given in Chapter 4, and pulmonary congestion and edema are described briefly in the context of congestive heart failure, Chapter 12. Whatever the clinical setting, pulmonary congestion and edema produce heavy, wet lungs. Therapy and outcome depend on the underlying etiology. Hemodynamic pulmonary edema. Absorption compression. Hemodynamic pulmonary edema is caused by increased hydrostatic pressure and occurs most commonly in left-sided congestive heart failure. Edema accumulates initially in the basal regions of the lower lobes because hydrostatic pressure is greatest in these sites-dependent edema. Histologically, the alveolar capillaries are engorged, and there is an intra-alveolar transudate that appears as finely granular pale pink material. Alveolar microhemorrhages and hemosiderin-laden macrophages heart failure cells may be present. In long-standing pulmonary congestion, for example, as seen in mitral stenosis, hemosiderin-laden macrophages are abundant, and fibrosis and thickening of the alveolar walls cause the soggy lungs to become firm and brown in duration. These changes not only impair respiratory function but also predispose to infection. Contraction. Figure 15.2. Various forms of acquired atelectasis. Dashed lines indicate normal lung volume. Absorption atelectasis stems from obstruction of an airway. Over time, air is resorbed from distal alveoli, which collapse. Since lung volume is diminished, the mediastinum shifts toward the atelectatic line. Airway obstruction is most often caused by excessive secretions, for example, mucus plugs or exudates within smaller bronchi. This may occur in bronchial asthma, chronic bronchitis, bronchitis, and postoperative states. Aspiration of foreign bodies and intrabronchial tumors may also lead to airway obstruction and atelectasis. Compression atelectasis results whenever significant volumes of fluid transudate, exudate, or blood, tumor, or air pneumothorax accumulate within the pleural cavity. With compression atelectasis, the mediastinum shifts away from the affected lung. Contraction atelectasis occurs when focal or generalized pulmonary or pleural fibrosis prevents full lung expansion. Significant atelectasis reduces oxygenation and predisposes to infection. Except in cases caused by fibrosis, atelectasis is a reversible disorder. Pulmonary edema. Pulmonary edema, excessive interstitial fluid in the alveoli can result from hemodynamic disturbances cardiogenic. T15.1 and causes of pulmonary edema of hemodynamic edema, increased hydrostatic pressure, increased pulmonary venous pressure. Left-sided heart failure, common volume overload, pulmonary vein obstruction. Decreased oncotic pressure, less common. Hypoalbuminemia, nephrotic syndrome, liver disease, protein losing enteropathies. Lymphatic obstruction, brain. Edema due to alveolar wall injury, microvascular or epithelial injury. Direct injury. Infections. Bacterial pneumonia, inhaled gases. High concentrations of oxygen. Smoke, liquid aspiration. Gastric contents. Near drowning, radiation, lung trauma. Indirect injury. Systemic inflammatory response syndrome, for example, associated with sepsis, burns, pancreatitis, extensive trauma, blood transfusion, related. Drugs and chemicals, chemotherapeutic agents, bleomycin, medications, methadone, amphotericin B, heroin, cocaine, kerosene, paraquat, edema of undetermined origin. High-altitude neurogenic central nervous system trauma classification, 676, Chapter 15 alone. Edema caused by microvascular alveolar injury. Non-cardiogenic pulmonary edema is caused by injury of the alveolar septum. Primary injury to the vascular endothelium or damage to alveolar epithelial cells with secondary microvascular injury produces an inflammatory exudate that leaks into the interstitial space and, in more severe cases, into the alveoli. Injury-related alveolar edema is an important feature of a serious and often fatal condition, acute respiratory distress syndrome discussed below. Acute lung injury and acute respiratory distress syndrome, diffuse alveolar damage. Acute lung injury ALI is characterized by the abrupt onset of hypoxemia and bilateral pulmonary edema in the absence of cardiac failure. Non-cardiogenic pulmonary edema. Acute respiratory distress syndrome ARDS is a manifestation of severe ALI. Both ARDS and ALI are associated with inflammation-associated increases in pulmonary vascular permeability, edema, and epithelial cell death. The histologic manifestation of these diseases is diffuse alveolar damage. ALI is a well-recognized complication of diverse conditions, including both pulmonary and systemic disorders. Table 15.2. In many cases, several predisposing conditions are present, for example, shock, oxygen therapy, and sepsis. In other uncommon instances, ALI appears acutely in the absence of known triggers and follows a rapidly progressive clinical course, a condition known as acute interstitial pneumonia. Pathogenesis ALI/ARDS is initiated by injury of pneumocytes and pulmonary endothelium, setting in motion a vicious cycle of increasing inflammation and pulmonary damage. Fig. 15.3. Endothelial activation is an important early event. In some instances, endothelial activation is secondary to pneumocyte injury, which is sensed by resident alveolar macrophages. In response, these immune signals secrete mediators such as tumor necrosis factor TNF that act on the neighboring endothelium. Alternatively, circulating inflammatory mediators may activate pulmonary endothelium directly in the setting of severe tissue injury or sepsis. Some of these mediators injure endothelial cells, while others, notably cytokines, induce endothelial cells to express increased levels of adhesion molecules, procoagulant proteins, and chemokines. Adhesion and extravasation of neutrophils. Neutrophils adhere to the activated endothelium and migrate into the interstitium and the alveoli, where they degranulate and release inflammatory mediators including proteases, reactive oxygen species, and cytokines. Experimental evidence suggests that neutrophil extracellular traps nets are released and also contribute directly to lung damage. These injuries and associated pro-inflammatory factors set in motion a vicious cycle of inflammation and endothelial damage that lies at the heart of ALI/ARDS. Associated with DMTOF, Table 1 of them, L12 conditions, respiratory distress syndrome, infection, sepsis and diffuse pulmonary infections, viral, mycoplasma, and pneumocystis pneumonia, miliary tuberculosis, gastric aspiration. Physical/injury, mechanical trauma including head injury, pulmonary contusions, near drowning, fractures with fat embolism, burns, ionizing radiation, inhaled irritants. Oxygen toxicity, smoke, irritant gases, and chemicals. Chemical injury. Heroin or methadone overdose, acetylsalicylic acid, barbiturate overdose, paraquat. Hemorrhagic conditions. Transfusion-associated lung injury, trolley-disseminated intravascular coagulation. Pancreatitis. Uremia. Cardiopulmonary bypass. Hypersensitivity reactions. Organic solvents, drugs. More than 50% of cases of acute respiratory distress syndrome are associated with these four conditions. Acute. Accumulation of intra-alveolar fluid and formation of hyaline membranes. Endothelial activation and injury make pulmonary capillaries leaky, allowing interstitial and intra-alveolar edema fluid to form. Damage and necrosis of type Roman II alveolar pneumocytes lead to surfactant abnormalities, further compromising alveolar gas exchange. Ultimately, they are specific protein-rich edema fluid and debris from dead alveolar epithelial cells organized in the hyaline membranes, a characteristic feature of ALIs/Rs. Resolution of injury is impeded in ALIs/Rs due to epithelial necrosis and inflammatory damage that impairs the ability of remaining cells to assist with edema resorption. Eventually, however, if the inflammatory stimulus lessens, macrophages remove intra-alveolar debris and release fibrogenic cytokines such as transforming growth factor beta, TGF-beta, and platelet-derived growth factor. These factors stimulate fibroblast growth and collagen deposition, leading to fibrosis of alveolar walls. Residual type Roman II pneumocytes proliferate to replace type I pneumocytes, reconstituting the alveolar lining. Endothelial restoration occurs through proliferation of uninjured capillary endothelium. Lung injury and acute respiratory distress syndrome, diffuse alveolar damage 677. Normal alveolus acute lung injury. Bronchial epithelium, slough bronchial epithelium. Basement membrane. Inactivated surfactant necrotic type by cell. Alveolar macrophage ROS. Cytokines, proteases, edema fluid. Surfactant layer, type by cell. Capillary, type Roman II cell. Interstitium, alveolus. TNF-IL1. TNF chemokines, fibrin, hyaline membrane. Fibroblasts, procollagen, cellular debris, neutrophil sequestration and migration into alveolus. Edema, endothelial cell injured, swollen, endothelial cells. Figure 15.3. The normal alveolus left side compared with the injured alveolus in the early phase of acute lung injury and acute respiratory distress syndrome. 1. Interleukin-1, ROS, reactive oxygen species, TNF, tumor necrosis factor, modified with permission from MAFA-MA, or LB, Zimmerman GA. The acute respiratory distress syndrome, J. Clin Invest Tovecor 2731, 2012. Lesions in Rs are not evenly distributed, and as a result there are typically areas that are stiff and poorly aerated and regions that have nearly normal levels of compliance and ventilation. Because poorly aerated regions continue to be perfused, there is a mismatch of ventilation and perfusion, a phenomenon that exacerbates the hypoxemia and cyanosis. Epidemiologic studies have shown that ALI/Rs is more common and has a worse prognosis in chronic alcoholics and in smokers. Genome-wide association studies have identified a number of genetic variants that increase the risk of Rs, some of which map to genes linked to inflammation and coagulation. Organizing stage. Type Roman II pneumocytes proliferate and granulation tissue forms in the alveolar walls and spaces. In most cases, the granulation tissue resolves, leaving minimal functional impairment. Sometimes, however, fibrotic thickening scarring of the alveolar septa ensues late fibrotic stage, acute morphology in the acute exudative stage. The lungs are heavy, firm, red, and body. They exhibit congestion, interstitial and intra-alveolar edema, inflammation, fibrin deposition, and diffuse alveolar damage. The alveolar walls become lined with waxy hyaline membranes. Fate 15. 4 that are morphologically similar to those seen in hyaline membrane disease of neonates chapter 10. Alveolar hyaline membranes consist of fibrin-rich edema fluid mixed with the remnants of necrotic epithelial cells. In the proliferative or Figure 15.4 diffuse alveolar damage acute respiratory distress syndrome. Some of the alveoli are collapsed, while others are distended. Many are lined by hyaline membranes arrows. 678 Chapter 15 The Lung. Clinical features: profound dyspnea and tachypnea herald ALI/Rs, followed by increasing respiratory failure, hypoxemia, cyanosis, and the appearance of diffuse bilateral infiltrates on radiographic examination. Hypoxemia may be refractory to oxygen therapy due to ventilation-perfusion mismatch, and respiratory acidosis can develop. Early in the course, the lungs become stiff due to loss of functional surfactant, leading to the need for intubation and high ventilatory pressures to maintain adequate gas exchange. There are no proven specific treatments for ARS, which is common in acutely ill patients and continues to take a high toll, even in patients receiving state-of-the-art supportive care. In a 2016 study of intensive care units in 50 countries, the incidence of ARS was 4%, and mortality rates were 35% for mild, 40% for moderate, and 46% for severe ARS. The majority of deaths are attributable to sepsis, multi-organ failure, or severe lung injury. Most survivors recover pulmonary function, but in a minority of patients, the lung damage results in interstitial fibrosis and chronic pulmonary disease. The concepts: acute respiratory distress syndrome. ARDS is a clinical syndrome of progressive respiratory insufficiency caused by diffuse alveolar damage in the setting of sepsis, severe trauma, or diffuse pulmonary infection. Damage to endothelial and alveolar epithelial cells and secondary inflammation are the key initiating events and the basis of lung damage. The characteristic histologic finding is hyaline membranes lining alveolar walls, accompanied by edema, scattered neutrophils, and macrophages, and epithelial necrosis. Obstructive and restrictive lung diseases. Obstructive lung diseases are characterized by an increase in resistance to airflow due to diffuse airway disease, which may affect any level of the respiratory tract. These are contrasted with restrictive diseases, which are characterized by reduced expansion of lung parenchyma and decreased total lung capacity. The clinical distinction between these diseases is based primarily on pulmonary function tests. In individuals with diffuse obstructive disorders, pulmonary function tests show decreased maximum airflow rates during forced expiration, usually expressed as forced expiratory volume at 1 second FEV1 over forced ventilatory capacity FVC. FEV1/FVC ratio of less than 0.7 generally indicates obstructive disease. Expiratory airflow obstruction may be caused by a variety of conditions. Table 15. 3. Each with characteristic pathologic changes and different mechanisms of airflow obstruction. As discussed later, however, the divisions between these entities are not clean, and many patients have diseases with overlapping features. By contrast, restrictive diseases are associated with proportionate decreases in both total lung capacity and FEV1, such that the FEV1/FVC ratio remains normal. Restrictive defects occur in two broad kinds of conditions: one, chest wall disorders, for example, severe obesity, pleural diseases, kyphoscoliosis, and neuromuscular diseases such as poliomyelitis, and two, chronic interstitial and infiltrative diseases, such as pneumoconiosis and interstitial fibrosis. Obstructive lung diseases. Common obstructive lung diseases include chronic obstructive pulmonary disease, COPD, asthma, and bronchitis. Table 15.3. COPD has two major clinical pathologic manifestations: emphysema and chronic bronchitis, which are often found together in the same patient, almost certainly because they share the same major etiologic factor: cigarette smoking. While asthma is distinguished from chronic bronchitis and emphysema by the presence of reversible bronchospasm, some patients with otherwise typical asthma also develop an irreversible component. 15.5. Inversely, some patients with otherwise typical COPD have a reversible component. Clinicians commonly label such patients as having COPD/asthma. Chronic obstructive pulmonary disease. COPD, a major public health problem, is defined by the World Health Organization WHO as a common, preventable and treatable disease that is characterized by persistent respiratory symptoms and airflow limitation that is due to airway and/or alveolar abnormalities caused by exposure to noxious particles or gases. It is currently the fourth Table 15.3 Disorders associated with airflow obstruction. The spectrum of chronic obstructive pulmonary disease clinical term anatomic site major pathologic changes etiology signs/symptoms chronic bronchitis bronchus mucus gland hyperplasia tobacco smoke air cough sputum production hypersecretion pollutants bronchitis bronchus airway dilation and scarring persistent or severe cough virulent sputum infections fever asthma bronchus smooth muscle hyperplasia immunologic or undefined episodic wheezing, cough. Excess mucus, inflammation causes dyspnea. Emphysema sinus airspace enlargement, wall tobacco smoke dyspnea, destruction, small airways disease, bronchoinflammatory scarring/obliteration tobacco smoke, air cough, dyspnea bronchiolitis pollutants, miscellaneous. Can be seen with any form of obstructive lung disease or as an isolated finding. Obstructive lung disease is 679. Emphysema alveolar wall destruction. Overinflation. Chronic injury, for example. Smoking. Small airway disease. Asthma reversible obstruction. Bronchial hyperresponsiveness triggered by allergens, infection, etc. Figure 15.5 Schematic representation of overlap between chronic obstructive lung diseases. Leading cause of death in the world and is projected to rank third by 2020 due to increases in cigarette smoking in countries such as China. There is a strong association between heavy cigarette smoking and COP. Overall, 35% to 50% of heavy smokers develop COP. Conversely, about 80% of COP is attributable to smoking. Women and African Americans who smoke heavily are more susceptible than other groups. Additional risk factors include poor lung development early in life, exposure to environmental and occupational pollutants, airway hyperresponsiveness, and certain genetic polymorphisms. Recognizing that emphysema and chronic bronchitis often occur together in patients with COP, it is still useful to discuss these patterns of lung injury and associated functional abnormalities individually to highlight the pathophysiologic basis of different causes of airflow obstruction. We will finish our discussion by returning to the clinical features of COP. Emphysema is defined by irreversible enlargement of the air spaces distal to the terminal bronchiole, accompanied by destruction of their walls. Subtle but functionally important small airway fibrosis distinct from chronic bronchitis is also present and is a significant contributor to airflow obstruction. Emphysema is classified according to its anatomic distribution within the lobule. Recall that the lobule is a cluster of acini, the terminal respiratory units. Based on the segments of the respiratory units that are involved, emphysema is subdivided into 4 major types: 1 centroacinar, 2 panacinar, 3 paraseptal, and 4 regular. Of these, only the first 2 cause clinically significant airflow obstruction fate. 15. 6. Centroacinar centrolobular emphysema. Centroacinar emphysema is the most common form, constituting more than 95% of clinically significant cases. It occurs predominantly in heavy smokers with COP. In this type of emphysema, the central or proximal parts of the acini, formed by respiratory bronchioles, are affected, whereas distal alveoli are spared phase. 15. 6b and 15. 7a. Thus, chronic bronchitis, productive cough, airway inflammation. Both emphysematis and normal air spaces exist within the same acinus and lobule. The lesions are more common and usually more pronounced in the upper lobes, particularly in the apical segments. In severe centroacinar emphysema, the distal acinus may also be involved, making differentiation from panacinar emphysema difficult. Panacinar lobular emphysema. Panacinar emphysema is associated with alpha-1 antitrypsin deficiency chapter 18 and is exacerbated by smoking. In this type, the acini are uniformly enlarged from the level of the respiratory bronchiole to the terminal blind alveoli phase. 15. 6c and 15. 7b. In contrast to centroacinar emphysema, panacinar emphysema tends to occur more commonly in the lower zones and in the anterior margins of the lung, and it is usually most severe at the bases. Distal paraseptal emphysema. Distal emphysema probably underlies many cases of spontaneous pneumothorax in young adults. In this type, the proximal portion of the acinus is normal, and the distal part is predominantly involved. Emphysema is more striking adjacent to the pleura, along the lobular connective tissue sector, and at the margins of the lobules. It occurs adjacent to areas of fibrosis, scarring, or atoptosis, and is usually more severe in the upper half of the lungs. The characteristic finding is multiple enlarged air spaces, ranging from less than 0.5 cm to more than 2.0 cm in diameter, which sometimes form cyst-like structures. Alveolus, normalus sinus, respiratory bronchial alveolar duct, AC alveolus, B respiratory, bronchial alveolar duct, panacinar emphysema, centriacinar emphysema. Figure 15.6 clinically significant patterns of emphysema, the structure of the normalus sinus. B centriacinar emphysema with dilation that initially affects the respiratory bronchioles. C panacinar emphysema with initial distension of the alveolus and alveolar duct. 680 Chapter 15 The lung. EE Figure 15.7 The centriacinar emphysema. Central areas show marked emphysematous damage, each surrounded by relatively spared alveolar spaces. E panacinar emphysema involving the entire pulmonary lobule. Airspace enlargement with fibrosis. Irregular emphysema. Irregular emphysema, so named because their sinus is irregularly involved, is almost invariably associated with scarring. In most instances it occurs in small foci and is clinically insignificant. Pathogenesis. Clinically significant emphysema is largely confined to smokers and to patients with alpha-1 antitrypsin deficiency, highlighting the importance of these two etiologic factors. Mechanisms relating to these factors that contribute to the development of emphysema include the following: 15. A. Toxic injury and inflammation. Inhaled cigarette smoke and other noxious particles damage respiratory epithelium and cause inflammation, which results in variable degrees of parenchymal destruction. A wide variety of inflammatory mediators including leukotriene B4, interleukin IL-8, TNF, and others are increased in the affected parts of the lung. These mediators are released by resident epithelial cells and macrophages and variously attract inflammatory cells from the circulation. Chemotactic factors amplify the inflammatory process. Pro-inflammatory cytokines and induce structural changes. Growth factors. Chronic inflammation also leads to the accumulation of T and B, smoking or air pollutant, plus genetic predisposition, congenital 1 antitrypsin deficiency, oxidative stress, increased apoptosis and senescence, inflammatory cells, release of inflammatory mediators, protease-interprotease imbalance, alveolar wall destruction. Figure 15.8 Pathogenesis of emphysema. See text for details. Cells in affected parts of the lung, but the role of adaptive immunity in emphysema is currently uncertain. Protease-interprotease imbalance. Several proteases are released from the inflammatory cells and epithelial cells that break down connective tissue components. In patients who develop emphysema, there is a relative deficiency of protective antiproteases, which in some instances has a genetic basis discussed later. Oxidative stress. Substances in tobacco smoke, alveolar damage, and inflammatory cells all produce oxidants, which may beget tissue damage, endothelial dysfunction, and inflammation. The role of oxidants is supported by studies of mice in which the NRF4 gene is inactivated. NRF4 is a transcription factor that serves as a sensor for oxidants in many cell types, including alveolar epithelial cells. Intracellular oxidants activate NRF4, which upregulates the expression of genes that protect cells from oxidant damage. Mice without NRF4 are significantly more sensitive to tobacco smoke than normal mice, and genetic variants in NRF4, NRF4 regulators, and NRF4 target genes are all associated with smoking-related lung disease in humans. Infection. Although infection is not thought to play an initiating role in the tissue destruction, bacterial and viral infections may acutely exacerbate existing disease. The idea that proteases are important is based in part on the observation that patients with a genetic deficiency of the antiprotease alpha-1 antitrypsin have a markedly enhanced tendency to develop emphysema that is compounded by smoking. About 1% of all patients with emphysema have this defect. Alpha-1 antitrypsin, normally present in serum, tissue fluids, and macrophages, is a major inhibitor of proteases, particularly elastase secreted by neutrophils during inflammation. It is encoded by the proteinase inhibitor pi locus on chromosome 14. The pi locus is polymorphic, and approximately 0.12% of the U.S. population is homozygous for the Z allele, a genotype associated with very low serum levels of alpha-1 antitrypsin. More than 80% of ZZ individuals develop symptomatic Pannier emphysema, which occurs at an earlier age and is of greater severity if the individual smokes. It is postulated that any injury, for example, that induced by smoking that increases the activation and influx of obstructive lung disease is 681 neutrophils into the lung leads to local release of proteases, which in the absence of alpha-1 antitrypsin activity result in excessive digestion of elastic tissue and, with time, emphysema. Several other genetic variants have also been linked to risk of emphysema. Among these are variants of the nicotinic acetylcholine receptor that are hypothesized to influence the addictiveness of tobacco smoke and thus the behavior of smokers. Not surprisingly, the same variants are also linked to lung cancer risk, emphasizing the importance of smoking in both of these diseases. A number of factors contribute to airway obstruction and emphysema. Small airways are normally held open by the elastic recoil of the lung parenchyma. The loss of elastic tissue in the walls of alveoli that surround respiratory bronchioles reduces radial traction, leading to collapse of respiratory bronchioles during expiration and functional airflow obstruction in the absence of mechanical obstruction. In addition, even young smokers often have changes related to small airway inflammation that also contribute to airway narrowing and obstruction described later. Morphology. Advanced emphysema produces voluminous lungs, often overlapping the heart anteriorly. Generally, in patients with smoking-related disease, the upper two-thirds of the lungs are more severely affected. Large alveoli can easily be seen on the cut surface of fixed lungs. See Fig. 15. 7. Apical blebs or bully characteristic of a regular emphysema may appear in patients with advanced disease. Microscopically, abnormally large alveoli are separated by a thin septum with focal centroacinar fibrosis. There is loss of attachments between alveoli and the outer wall of small airways. The pores of cone are so large that septa appear to be floating, or protrude blindly into alveolar spaces with a club-shaped end. As alveolar walls are destroyed, there is a decrease in the capillary area. With advanced disease, there are even large abnormal air spaces and possibly blebs or bulli, which often deform and compress the respiratory bronchioles and vasculature of the lung. Inflammatory changes in small airways are often superimposed, described next under chronic bronchitis, as are vascular changes related to pulmonary hypertension stemming from local hypoxemia. Loss of capillary beds. Chronic bronchitis is defined clinically as persistent cough with sputum production for at least 3 months and at least 2 consecutive years in the absence of any other identifiable cause. Long-standing chronic bronchitis is associated with progressive lung dysfunction, which may be so severe as to lead to hypoxemia, pulmonary hypertension, and cor pulmonale. Pathogenesis. The primary or initiating factor in the genesis of chronic bronchitis is exposure to noxious or irritating inhaled substances, such as tobacco smoke. 90% of those affected are smokers and dust from grain, cotton, and silica. Several factors contribute to its pathogenesis. Mucus hypersecretion. The earliest feature of chronic bronchitis is hypersecretion of mucus in the large airways, associated with enlargement of the submucosal glands. The trachea and bronchi. The basis for mucus hypersecretion isn't completely understood, but it appears to involve inflammatory mediators such as histamine and IL-13. With time, there is also a marked increase in goblet cells in small airways, small bronchi and bronchioles, leading to excessive mucus production that contributes to airway obstruction. It is thought that both the enlargement of submucosal glands and the increase in numbers of goblet cells are protective reactions against tobacco smoke or other pollutants, for example, sulfur dioxide and nitrogen dioxide. Acquired cystic fibrosis transmembrane conductance regulator, CFTR, dysfunction. There is substantial evidence that smoking leads to acquired CFTR dysfunction, which in turn causes the secretion of abnormal, dehydrated mucus that exacerbates the severity of chronic bronchitis. Inflammation. Inhalants that induce chronic bronchitis cause cellular damage, eliciting both acute and chronic inflammatory responses involving neutrophils, lymphocytes, and macrophages. Long-standing inflammation and accompanying fibrosis involving small airways, small bronchi, and bronchioles, less than 2 to 3 mm in diameter, can also lead to chronic airway obstruction. Infection. Infection does not initiate chronic bronchitis, but is probably significant in maintaining it and may be critical in producing acute exacerbations. Cigarette smoke predisposes to chronic bronchitis in several ways. Not only does it damage airway lining cells, leading to chronic inflammation, but it also interferes with the ciliary action of the respiratory epithelium, preventing the clearance of mucus and increasing the risk of infection. Morphology. Grossly, there is hyperemia, swelling, and edema of the mucous membranes, frequently accompanied by excessive mucinous or mucopurulent secretions. Sometimes, heavy casts of secretions and pus fill the bronchi and bronchioles. The characteristic microscopic features are chronic inflammation of the airways, predominantly lymphocytes and macrophages, thickening of the bronchiolar wall due to smooth muscle hypertrophy, deposition of extracellular matrix in the muscle layer, and parabronchial fibrosis, goblet cell hyperplasia, and enlargement of the mucus-secreting glands of the trachea and bronchi. Of these, the most striking change is an increase in the size of the mucus glands. This increase can be assessed by the ratio of the thickness of the mucus gland layer to the thickness of the wall between the epithelium and the cartilage Reed index. Reed index normally 0. 4 is increased in chronic bronchitis, usually in proportion to the severity and duration of the disease. The mucus plugging, inflammation, and fibrosis may lead to marked narrowing of bronchioles, and in the most severe cases, there may be obliteration of lumen due to fibrosis bronchiolitis obliterans. Bronchial epithelium may also exhibit squamous metaplasia and dysplasia due to the irritating and mutagenic effects of substances in tobacco smoke. Clinical features of COP. Most affected patients have a smoking history of 40 pack years or greater. COP often presents insidiously with slowly. 682 Chapter 15 The lung. 15. MT4 age, years dyspnea, cough, infections, respiratory insufficiency, cor pulmonale, airway resistance, elastic recoil, chest radiograph, appearance, Rankin table itis, features of effacement. Bronchitis 40, 45, mild, late, early, copious sputum, common, early, periodic, common, increased, normal, prominent vessels, large heart size, blue blood, increasing dyspnea on exertion and chronic cough with sputum production, slight at first but increasing over time. Other patients present with exacerbations caused by superimposed infection that can lead to confusion with other disorders, such as asthma due to wheezing. Most important diagnostic test is spirometry, which typically shows a FeVO/FEC ratio of less than 0.7. Once COP appears, symptoms often wax and wane over time and are generally worse in the morning. The clinical picture varies according to the severity of the disease and the relative contributions of emphysematis and bronchitic changes. Table 15.4. One extreme end of the spectrum lie pink puffers, patients in whom emphysema dominates. Classically, the patient is barrel-chested and dyspneic, with obviously prolonged expiration, sits forward in a hunched-over position, and breathes through pursed lips. Cough is often slight, overextension of the lungs is severe, diffusion capacity is low, and blood gas values are relatively normal at rest. Weight loss is common and can be so severe as to suggest an occult cancer. At the other end lie patients with pure chronic bronchitis, ingloriously referred to as blue blowers. Their cardinal symptom is a persistent cough productive of sputum, coupled with hypercapnia, hypoxemia, and mild cyanosis. Most patients are somewhere in the middle, with signs and symptoms stemming from both bronchitic and emphysematic changes. Treatment options include smoking cessation, oxygen therapy, long-acting bronchodilators with inhaled corticosteroids, antibiotics, physical therapy, alectomy, and, in selected patients, lung volume reduction surgery and lung transplantation. Even with intervention, however, COP often progresses and frequently proves fatal. Long-standing COP, particularly in patients with a bronchitic component, commonly leads to pulmonary hypertension, cor pulmonale, and death due to heart failure. Death may also result from acute respiratory failure due to acute infections superimposed on COP. In patients with emphysematous changes, subpleural blebs may rupture, leading to fatal pneumothorax. The best hope for major change in this dire picture is more effective programs aimed at prevention of smoking and other environmental exposures. And emphysema. 50. 75. Severe, early, late, scanty sputum, occasional, end stage, uncommon, end stage, normal or slightly increased, low, hyperinflation, normal heart size, pink puffer. Key concepts: chronic obstructive pulmonary disease. Most common in long-standing tobacco smokers, typically 40-pack years. Air pollutants also contribute. Underlying pulmonary pathology usually includes both chronic bronchitis and emphysema, often fatal due to development of heart failure or respiratory failure due to superimposed infection. Emphysema, and COP, usually follows a centrosynart distribution characterized by permanent enlargement of air spaces distal to terminal bronchioles. Particularly severe in patients with alpha-1 antitrypsin deficiency, in which a panisynart pattern of emphysematous change may be seen. Tissue destruction is caused by elastases and oxidants release from inflammatory cells, particularly neutrophils, which are responding to cellular injury caused by tobacco smoking. Pollutants. Chronic bronchitis, defined as persistent productive cough for at least 3 consecutive months and at least 2 consecutive years. Dominant pathologic features are mucus hypersecretion due to enlargement of mucus-secreting glands and chronic inflammation associated with bronchiolar wall fibrosis. Predominant B chronic. Other forms of emphysema in addition to emphysema occurring in the setting of COP. Several other conditions may be associated with lung overinflation or focal emphysematous change and are mentioned here in brief. Compensatory hyperinflation. This term is used to designate dilation of alveoli in response to loss of lung substance elsewhere, for example, following surgical removal of a lung or lobe with cancer. Obstructive overinflation. In this condition, the lung expands because air is trapped within it. A common cause is subtotal obstruction of an airway by a tumor or foreign object. In infants, it may be caused by congenital lobar overinflation, which most often results from hypoplasia of bronchial cartilage. Overinflation occurs either 1 because of an obstruction that acts as ball valve, allowing air to enter on inspiration while preventing its exodus on expiration, or 2 because collaterals bring in air behind the obstruction. These collaterals consist of the pores of cone and other direct accessory bronchial-alveolar connections, the canals of Lambert. Obstructive overinflation can be life-threatening if the affected portion distends sufficiently to compress the adjacent uninvolved lung. Bullous emphysema. This is a descriptive term for large subpleural blebs or bully spaces greater than 1 cm in diameter in the distended state that can occur in any form of emphysema. Fig. 15.9, often near the apex. Rupture of the bully may give rise to pneumothorax. Interstitial emphysema. Entrance of air into the connective tissue stroma of the lung, mediastinum, or subcutaneous. Obstructive lung disease is 683. Figure 15.9 bullous emphysema. Note the large subpleural bully upper left. Tissue produces interstitial emphysema. In most instances, it is caused by alveolar tears that occur in patients with pulmonary emphysema due to transient increases in intra-alveolar pressure, for example, during coughing. Less commonly, chest wounds or fractured ribs that puncture the lung provide the portal for entrance of air into surrounding soft tissues. Asthma. Asthma is a heterogeneous disease, usually characterized by chronic airway inflammation and variable expiratory airflow obstruction that produces symptoms such as wheezing, shortness of breath, chest tightness, and cough, which vary over time and in intensity. Symptomatic episodes are most likely to occur at night or in the early morning and are produced by bronchoconstriction that is at least partly reversible, either spontaneously or with treatment. Early, an unremitting attack called acute severe asthma, formerly known as status asthmaticus, may prove fatal, usually Such patients have a long history of asthma. Between the attacks, patients may be virtually asymptomatic. Of note, there has been a significant increase in the incidence of asthma in the Western world over the past 40 to 50 years, a trend that has now started to abate. However, the prevalence of asthma continues to increase in lower-income countries and in some ethnic groups in which its prevalence was previously low. Asthma has several distinct clinical phenotypes, each with different underlying pathogenic mechanisms. It may be categorized as atopic evidence of allergen sensitization and immune activation, often in a patient with allergic rhinitis or eczema, or non-atopic no evidence of allergen sensitization, of which several subtypes exist. In all types, episodes of bronchospasm may have diverse triggers, such as respiratory infections, especially viral infections, irritants for example, smoke, fumes, cold air, stress, and exercise. One biologically meaningful and clinically useful way to classify asthma is based on its triggers. We will first briefly describe the various major subtypes of asthma, and then we'll delve more deeply into its pathogenesis. Atopic asthma. This type of asthma is a classic example of an AE-mediated type, a hypersensitivity reaction discussed in Chapter 6. The disease usually begins in childhood and is triggered by environmental allergens, such as dust, pollens, cockroach or animal dander, and foods, which most frequently act in synergy with other pro-inflammatory environmental cofactors, most notably respiratory viral infections. A positive family history of asthma is common, and a skin test with the offending antigen in these patients results in an immediate wheal and flare reaction. Atopic asthma may also be diagnosed based on high total serum AE levels or evidence of allergen sensitization by serum radioallergosorban test RAS, which can detect the presence of AE antibodies that are specific for individual allergens. Non-atopic asthma. Individuals with non-atopic asthma do not have evidence of allergen sensitization, and skin test results are usually negative. A positive family history of asthma is less common in these patients. Respiratory infections due to viruses, for example, rhinovirus, parainfluenza virus, and respiratory syncytial virus are common triggers in non-atopic asthma. Inhaled air pollutants such as tobacco smoke, sulfur dioxide, ozone, and nitrogen dioxide may also contribute to the chronic airway inflammation and hyperactivity in some cases. As already mentioned, in some instances attacks may be triggered by seemingly innocuous events, such as exposure to cold and even exercise. Drug-induced asthma. Several pharmacologic agents provoke asthma. Aspirin-sensitive asthma is an uncommon type, occurring in individuals with recurrent rhinitis and nasal polyps. These individuals are exquisitely sensitive to small doses of aspirin as well as other non-steroidal anti-inflammatory medications, and they experience not only asthmatic attacks but also urticaria. Aspirin and related drugs trigger asthma in these patients by inhibiting the cyclooxygenase pathway of arachidonic acid metabolism, leading to a rapid decrease in prostaglandin EPO. Normally, prostaglandin EPO inhibits enzymes that generate pro-inflammatory mediators such as leukotrienes B4, C4, D4, and EPHA, which are believed to have central roles in aspirin-induced asthma. Occupational asthma. This form of asthma may be triggered by fumes, epoxy resins, plastics, organic and chemical dust, wood, cotton, platinum, gases, toluene, or other chemicals, formaldehyde, penicillin products. Only minute quantities of chemicals are required to induce the attack, which usually occurs after repeated exposure. The 684 Chapter 15 The underlying mechanisms vary according to stimulus and include type I reactions, direct liberation of bronchoconstrictor substances, and hypersensitivity responses of unknown origin. Pathogenesis. Atopic asthma, the most common form of the disease, is caused by a THO-mediated AE response to environmental allergens in genetically predisposed individuals. Airway inflammation is central to the disease pathophysiology and causes airway dysfunction partly through the release of potent inflammatory mediators and partly through remodeling of the airway wall. As the disease becomes more severe, there is increased local secretion of growth factors, which induce mucus gland enlargement, smooth muscle proliferation, angiogenesis, and fibrosis. Varying combinations of these processes help explain the different asthma subtypes, their response to treatment, and their natural history over a person's lifetime. The contributions of the immune response, genetics, and environment are discussed separately below, although they are closely intertwined. THO responses, IgE, and inflammation. Fundamental abnormality in asthma is an exaggerated THO response to normally harmless environmental antigens. 15.10. THO cells secrete cytokines that promote inflammation and stimulate B cells to produce IgE and other antibodies. These cytokines include IL-4, which stimulates the production of IgE, IL-5, which activates locally recruited eosinophils, and IL-13, which stimulates mucus secretion from bronchial submucosal glands and also promotes IgE production by B cells. T cells and epithelial cells secrete chemokines that recruit more T cells than eosinophils, thus exacerbating the reaction. As in other allergic reactions, Chapter 6, IgE binds to the Fc receptors on submucosal mast cells, and repeat exposure to the allergen triggers the mast cells to release granule contents and produce cytokines and other mediators, which collectively induce the early phase immediate hypersensitivity reaction and the late phase reaction. The early phase reaction is dominated by bronchoconstriction, increased mucus production, variable degrees of vasculation, and increased vascular permeability. Bronchoconstriction is triggered by direct stimulation of subepithelial vagal parasympathetic receptors through both central and local reflexes triggered by mediators produced by mast cells and other cells in the reaction. The late phase reaction is dominated by recruitment of leukocytes, notably eosinophils, neutrophils, and more T cells. Although THO cells are the dominant T cell type involved in the disease, other T cells that contribute to the inflammation include Th17 IL-17 producing cells, which recruit neutrophils. Many mediators produced by leukocytes and epithelial cells have been implicated in the asthmatic response. The long list of suspects in acute asthma can be ranked based on the clinical efficacy of pharmacologic intervention with antagonists of specific mediators. Mediators whose role in bronchospasm is clearly supported by efficacy of pharmacologic intervention are 1-leukotriene C4, D4, and F, which cause prolonged bronchoconstriction as well as increased vascular permeability and increased mucus secretion. 2-acetylcholine, released from intrapulmonary parasympathetic nerves, which can cause airway smooth muscle constriction by directly stimulating muscarinic receptors. 3-IL-5, antagonists of which are effective in treating severe forms of asthma that are associated with peripheral blood eosinophilia. And 4-Galactin-10-GAL10, which is released from eosinophils and forms crystals known as Charcot-Leyden crystals. Long recognized as a feature of asthma, recent studies have shown that these crystals are strong inducers of inflammation and mucus production. A second group of agents are present at the scene of the crime but seem to have relatively minor contributions on the basis of lack of efficacy of potent antagonists or synthesis inhibitors. These include 1-histamine, a potent bronchoconstrictor, 2-prostaglandin D4, which elicits bronchoconstriction and vasculation, and 3-platelet activating factor, which causes aggregation of platelets and release of serotonin from their granules. These mediators might yet prove important in certain types of chronic or non-allergic asthma. Finally, a large third group comprises suspects for whom specific antagonists or inhibitors are not available or have been insufficiently studied as yet. These include IL-4, IL-13, TNF, chemokines for example, etaxin, also known as CC11, neurokines, nitric oxide, bradykinin, and endothelins. It is thus clear that multiple mediators contribute to the acute asthmatic response. Moreover, the composition of this mediator soup likely varies among individuals or different types of asthma. The appreciation of the importance of inflammatory cells and mediators in asthma has led to greater emphasis on anti-inflammatory drugs, such as corticosteroids, in its treatment. Genetic susceptibility. Susceptibility to atopic asthma is multigenic and often associated with increased incidence of other allergic disorders, such as allergic rhinitis, hay fever, and eczema. Genetic polymorphisms linked to asthma and other allergic disorders were described in Chapter 6. Suffice it to say here that many of these are likely to influence immune responses and the subsequent inflammatory reaction. Some of the stronger or more interesting genetic variants associated with asthma include the following. The susceptibility locus for asthma located on chromosome 5 near the gene cluster encoding the cytokines IL-3, IL-4, IL-5, IL-9, and IL-13 and the IL-4 receptor. Among the genes in this cluster, polymorphisms in the IL-13 gene have the strongest and most consistent associations with asthma or allergic disease, while IL-4 receptor gene variants are associated with atopy, elevated total serum IgE, and asthma. Particular class Roman II HLA alleles linked to production of IgE antibodies against some antigens, such as ragweed pollen. Variants associated with the genes encoding IL-33, a member of the IL-1 family of cytokines, and its receptor, ST-HOL, which induce the production of TH-HOL cytokines. Variants associated with the gene encoding thymic stromal lymphopoietin TSLP, a cytokine produced by epithelium that may have a role in initiating allergic reactions. Obstructive lung disease is 685. The normal airway C triggering of asthma, epithelium basement membrane, lamina propria, smooth muscle, glands, cartilage, mucous goblet cell. IgE cell, IgE antibody, B, TH-HOL cell, IL-4, TH-HOL, IL-5, T-cell receptor pollen, antigen allergen, dendritic cell, IgE Fc receptor, IL-5, ETEX and mucosal mast cell. Eosinophil recruitment, activation, release of granules, and mediators, goblet cell, the airway in asthma, mucous goblet cell, mucosal antigen mucus. Eosinophil, basement membrane, macrophage, smooth muscle, glands, mast cell eosinophil, lymphocyte, neutrophil, vagal afferent nerve, eosinophil, vagal efferent nerve. Increased vascular permeability and edema, mast cell, TH-HOL smooth muscle, major basic protein eosinophil cationic protein, basophil eosinophil, neutrophil. TH-HOL. E immediate phase minutes, E late phase hours. Figure 15.10 and B comparison of a normal airway and an airway involved by asthma. The asthmatic airway is marked by accumulation of mucus in the bronchial lumen secondary to an increase in the number of mucus-secreting goblet cells in the mucosa and hypertrophy of submucosal glands. Intense chronic inflammation due to recruitment of eosinophils, macrophages, and other inflammatory cells. Thickened basement membrane, and hypertrophy and hyperplasia of smooth muscle cells. D-inhaled allergens antigen elicit a TH-HOL dominated response favoring IgE production and eosinophil recruitment. D on re-exposure to antigen. The immediate reaction is triggered by antigen-induced cross-linking of IgE-bound Fc receptors on mast cells. These cells release perform mediators that directly and via neuronal reflexes induce bronchospasm, increased vascular permeability, mucus production, and recruitment of leukocytes. Leukocytes recruited to the site of reaction neutrophils, eosinophils, and basophils. Lymphocytes and monocytes release additional mediators that initiate several factors released from eosinophils, for example. Major basic protein, eosinophil cationic protein also cause damage to the epithelium. IL-5, interleukin 5. Chapter 15 The lung, morphology. Figure 15.11 bronchus from an asthmatic patient showing goblet cell hyperplasia green arrow. Sub. Basement membrane fibrosis black arrow. Eosinophilic inflammation yellow arrow. And muscle hypertrophy blue arrow. Environmental factors. Asthma is a disease of industrialized societies where the majority of people live in cities. Two ideas, neither wholly satisfying, have been proposed to explain this association. First, industrialized environments contain many airborne pollutants that can serve as allergens to initiate the TH-HOL response. Second, city life tends to limit the exposure of very young children to certain antigens, particularly microbial antigens, and exposure to such antigens may protect children from asthma and atopy. The idea that microbial exposure during early life reduces the later incidence of allergic and some autoimmune diseases has been popularized as the hygiene hypothesis. Although the underlying mechanisms of this protective effect are unclear, it has spurred trials of probiotics and intentional early exposure of children to putative allergens to decrease their risk of later developing allergies. Infections do not cause asthma by themselves, but may be important cofactors. Young children with aeroallergen sensitization who develop lower respiratory tract viral infections, rhinovirus type C, respiratory syncytial virus, have a 10 to 30-fold increased risk of developing persistent and or severe asthma. Both viral and bacterial infections identified by cultures and non-cultured tools are associated with acute exacerbations of the disease. Over time, repeated bouts of allergen exposure and immune reactions result in structural changes in the bronchial wall, referred to as airway remodeling. These changes, described later in greater detail, include hypertrophy and hyperplasia of bronchial smooth muscle, epithelial injury, increased airway vascularity, subepithelial mucus gland enlargement, and subepithelial fibrosis. Small subset of patients with asthma, many of whom have severe disease that is refractory to glucocorticoids, as inflammatory infiltrates that are enriched for neutrophils rather than eosinophils. This form of the disease may be driven by a Th17 T-cell response to chronic bacterial colonization of the lung. In patients dying of acute severe asthma status asthmaticus, the lungs are overinflated and contain small areas of apoptosis. The most striking gross finding is occlusion of bronchi and bronchioles by thick, tenacious mucus plugs, which often contain shed epithelium. A characteristic finding in sputum or bronchoalveolar lavage specimens of patients with atopic asthma is Kirschman's spirals, which may result from extrusion of mucus plugs from subepithelial mucus gland ducts or bronchioles. Also present are numerous eosinophils and Charcot-Leyden crystals composed of the eosinophil-derived protein galectin-10. The other characteristic histologic findings of asthma, collectively called airway remodeling fakes, 15, 10b and 15, 11, include thickening of airway wall, basement membrane fibrosis due to deposition of type I and Roman III collagens, increased vascularity, increase in the size of the submucosal glands and number of airway goblet cells, hypertrophy and or hyperplasia of the bronchial wall muscle, with increased extracellular matrix, while acute airflow obstruction is primarily attributed to muscular bronchoconstriction, acute edema, and mucus plugging. Airway remodeling may contribute to chronic irreversible airway obstruction. 686. Clinical features of classic acute asthmatic attack lasts up to several hours. In some patients, however, the cardinal symptoms of chest tightness, dyspnea, wheezing, and coughing with or without sputum production are present at a low level constantly. In its most severe form, acute severe asthma, the paroxysm persists for days or even weeks, sometimes causing airflow obstruction that is so extreme that marked cyanosis or even death ensues. The diagnosis is based on demonstration of an increase in airflow obstruction from baseline levels, difficulty with exhalation, prolonged expiration, wheeze, and in those with atopic asthma, identification of eosinophilia in the peripheral blood and eosinophils, Kirschman's spirals, and Charcot-Leyden crystals in the sputum. In the usual case with intervals of freedom from respiratory difficulty, the disease is more discouraging and disabling than lethal, and most individuals are able to maintain a productive life. Therapy is based on the severity of the disease. The centerpieces of standard therapy are bronchodilators, glucocorticoids, and leukotriene antagonists. For severe and difficult to treat asthma in adolescents and adults, novel biologic therapies targeting inflammatory mediators such as IL-5 blocking antibodies, which is effective in severe asthma associated with Tho immune responses and peripheral blood eosinophilia, are now available. Up to 50% of childhood asthma remits in adolescence only to return in adulthood in a significant number of patients. In other cases, there is a variable decline in baseline lung function over time. Obstructive lung disease is 687. Key concepts. Asthma. Asthma is characterized by reversible bronchoconstriction caused by airway hyperresponsiveness to a variety of stimuli. Topic asthma is caused by a THO and AE-mediated immunologic reaction to environmental allergens and is characterized by acute phase, immediate, and late phase reactions. The THO, cytokines IL-4, IL-5, and IL-13 are important mediators. Triggers for non-atopic asthma are less clear but include viral infections and inhaled air pollutants, which can also trigger atopic asthma. Eosinophils are key inflammatory cells in atopic asthma. Inflammatory cells implicated in this pathogenesis include mast cells, neutrophils, and T lymphocytes. Airway remodeling basement membrane fibrosis, hypertrophy of bronchial glands, and smooth muscle hyperplasia as an irreversible component to the obstructive disease. Bronchitis is a disorder in which destruction of smooth muscle and elastic tissue by inflammation stemming from persistent or severe infections leads to permanent dilation of bronchi and bronchioles. Because of better control of lung infections, bronchitis is now uncommon, but may still develop in association with the following: congenital or hereditary conditions that predispose to chronic infections, including cystic fibrosis, intralobar sequestration of the lung, immunodeficiency states, primary ciliary dyskinesia, and cardiac syndrome. Severe necrotizing pneumonia caused by bacteria, viruses, or fungi. This may be a single severe episode or recurrent infections. Bronchial obstruction due to tumor, foreign body, or mucus impaction. In each instance, the bronchitis is localized to the obstructed lung segment. Immune disorders, including rheumatoid arthritis, systemic lupus erythematosus, inflammatory bowel disease, and the post-transplant setting chronic rejection after lung transplant and chronic graft versus host disease after hematopoietic stem cell transplantation. Up to 50% of cases are idiopathic, lacking the aforementioned associations, in which there appears to be dysfunctional host immunity to infectious agents leading to chronic inflammation. Pathogenesis, obstruction, and infection are the major conditions associated with bronchitis. The infections that lead to bronchitis are usually the result of a defect in airway clearance. Sometimes this defect stems from airway obstruction, leading to distal pooling of secretions. Both mechanisms are readily apparent in a severe form of bronchitis that is associated with cystic fibrosis, Chapter 10. Cystic fibrosis, the primary defect in ion transport, results in thick viscous secretions that perturb mucociliary clearance and lead to airway obstruction. Assess the stage for chronic bacterial infections, which cause widespread damage to airway walls. With destruction of supporting smooth muscle and elastic tissue, the bronchi become markedly dilated, while smaller bronchioles are progressively obliterated as a result of fibrosis bronchiolitis obliterans. Primary ciliary dyskinesia is an autosomal recessive disease with a frequency of 1 in 10,000 to 20,000 births. The disease-causing mutations result in ciliary dysfunction due to defects in ciliary motor proteins, for example, mutations involving dynein, again preventing mucociliary clearance, setting the stage for recurrent infections that lead to bronchitis. Ciliary function also is necessary during embryogenesis to ensure proper rotation of the developing organs in the chest and abdomen. In its absence, their location becomes a matter of chance. As a result, approximately half of patients with primary ciliary dyskinesia have cardiac syndrome, marked by situs inversus or partial lateralizing abnormality associated with bronchitis and sinusitis. Males with this condition also tend to be infertile as a result of sperm dysmotility. Allergic bronchopulmonary aspergillosis occurs in patients with asthma or cystic fibrosis and frequently leads to the development of bronchitis. It is a hyperimmune response to the fungus Aspergillus fumigatus. Sensitization to Aspergillus leads to activation of THO helper T cells, which release cytokines that recruit eosinophils and other leukocytes. Characteristically, there are high serum AG levels, serum antibodies to Aspergillus, intense airway inflammation with eosinophils, and formation of mucus plugs, which play a primary role in the development of bronchitis. Morphology: bronchitis usually affects the lower lobes bilaterally, particularly air passages that are vertical, and is most severe in the more distal bronchi and bronchioles. When tumor or aspiration of foreign bodies leads to bronchitis, the involvement is localized. The airways are dilated, sometimes up to 4 times normal size. Characteristically, the bronchi and bronchioles are so dilated that they can be followed almost to the pleural surfaces. By contrast, in the normal lung, the bronchioles cannot be followed by I beyond a 0.2 to 3 cm from the pleural surfaces. On the cut surface of the lung, the dilated bronchi appear cystic and are filled with mucopurulent secretions Fig. 15, 12. The histologic findings vary with activity and chronicity of the disease. In the full-blown, active case, there is an intense, acute and chronic inflammatory exudation within the walls of the bronchi and bronchioles, associated with inflammation of lining epithelium and extensive ulceration. There also may be squamous metaplasia of the remaining epithelium in response to chronic inflammation, further diminishing mucociliary clearance. In some instances, necrosis destroys the bronchial or bronchiolar walls and forms a lung abscess. Fibrosis of the bronchial and bronchiolar walls impaired bronchiolar fibrosis developing more chronic cases, leading to varying degrees of subtotal or total obliteration of bronchiolar lumens. Haemophilus influenzae is found in approximately half in Pseudomonas aeruginosa in 12% to 30% of sputum cultures from patients with bronchitis, but 4 other types of bacteria. 688 Chapter 15 The lung. Chronic diffuse interstitial restrictive diseases. Figure 15.12 Bronchitis in a patient with cystic fibrosis who underwent lung transplantation. Cut surface of lung shows markedly distended peripheral bronchi filled with mucopurulent secretions, including non-tuberculous mycobacteria, making up most of the remaining cases in patients from different geographic locations. This observation suggests that the inflamed, mucoid, sometimes anaerobic, bronchitatic microenvironment favors colonization by relatively few microbial species. Allergic bronchopulmonary aspergillosis. Fungal hyphae can be seen on special stains within the mucoinflammatory contents of the dilated segmental bronchi. In late stages, the fungus may infiltrate the bronchial wall. Major clinical features: bronchitis causes severe, persistent cough, expectoration of foul smelling, sometimes bloody sputum, dyspnea and orthopnea in severe cases, and, on occasion, hemoptysis, which may be massive. Symptoms are often episodic and are precipitated by upper respiratory tract infections or the introduction of new pathogenic agents. Paroxysms of cough are particularly frequent when the patient rises in the morning, as the change in position causes collections of pus and secretions to drain into the bronchi. Obstructive respiratory insufficiency can lead to marked dyspnea and cyanosis. However, current treatments with better antibiotics and physical therapy have improved outcomes considerably, and life expectancy has almost doubled. Hence, cor pulmonale, brain abscesses, and amyloidosis are less frequent complications of bronchitis currently than in the past. Restrictive lung disorders fall into 2 general categories: 1 chronic interstitial and infiltrative diseases, such as pneumoconiosis and interstitial fibrosis of unknown etiology, and 2 chest wall disorders, for example, neuromuscular diseases such as poliomyelitis, severe obesity, pleural diseases, and kyphoscoliosis, which are not discussed here. Chronic interstitial pulmonary diseases are a heterogeneous group of disorders characterized predominantly by inflammation and fibrosis of the lung interstitium associated with pulmonary function studies indicative of restrictive lung disease. Diffuse restrictive diseases are categorized based on histology and clinical features. Table 15.5. Many of the entities are of unknown cause and pathogenesis, and some have an intra-alveolar as well as an interstitial component. Patients have dyspnea, tachypnea, and inspiratory crackles, and eventual cyanosis, without wheezing or other evidence of airway obstruction. The classic functional abnormalities are reductions in diffusion capacity, lung volume, and lung compliance. Chest radiographs show bilateral lesions that take the form of small nodules, irregular lines, or ground glass shadows, all corresponding to areas of interstitial fibrosis. Although the entities can often be distinguished in their early stages, advanced forms are hard to differentiate because all result in diffuse scarring of the lung, often referred to as end-stage lung or honeycomb lung. Eventually, secondary pulmonary hypertension and right-sided heart failure pulmonale may result. Fibrosing diseases. Idiopathic pulmonary fibrosis. Idiopathic pulmonary fibrosis IPF refers to a clinical pathologic syndrome marked by progressive interstitial pulmonary fibrosis and respiratory failure. Europe. Categories of C5 lung chronic interstitial fibrotonite (TT) disease. Fibrosing. Usual interstitial pneumonia. Idiopathic pulmonary fibrosis. Non-specific interstitial pneumonia. Cryptogenic organizing pneumonia. Connective tissue disease. Associated pneumoconiosis. Drug reactions. Radiation pneumonitis. Rhabdomyolysis. Sarcoidosis. Hypersensitivity pneumonitis. Eosinophilic. Smoking-related. Desquamative interstitial pneumonia. Respiratory bronchiolitis. Associated interstitial lung disease. Other glandular cell histiocytosis. Pulmonary alveolar proteinosis. Lymphoid interstitial pneumonia. BL. Chronic diffuse interstitial restrictive diseases. 689. Term cryptogenic fibrosing alveolitis is more popular. IPF has characteristic radiologic, pathologic, and clinical features. The histologic pattern of fibrosis is referred to as usual interstitial pneumonia UIP, which can often be diagnosed based on its characteristic appearance on computed tomography scans. The UIP pattern can also be seen in other diseases, notably connective tissue diseases, chronic hypersensitivity pneumonia, and asbestosis. These must be distinguished from IPF based on other clinical, laboratory, and histologic features. Pathogenesis. While the cause of IPF remains unknown, it appears that it arises in genetically predisposed individuals who are prone to aberrant repair of recurrent alveolar epithelial cell injuries caused by environmental exposures. Fate. 15.13. The implicated factors are as follows. Environmental factors. Most important among these is cigarette smoking, which increases the risk of IPF several-fold. IPF incidence is also increased in individuals who are exposed to air pollution, microaspiration, metal fumes, and wood dust, or who work in certain occupations, including farming, hairdressing, and stone polishing. It is hypothesized that exposure to environmental irritants, environmental factors, smoking, occupational exposure, other irritants, toxins, viral infection. Risk epithelium, age, genetics, telomerase mutations, surfactant mutations, MUC5B variant, persistent epithelial injury/activation, innate and adaptive immune response. Pro-fibrogenic factors, abnormal intracellular signaling, proliferation, collagen production, or toxins in each of these contexts causes recurrent alveolar epithelial cell damage. Genetic factors. The vast majority of individuals who smoke or who have other environmental exposures linked to IPF do not develop the disorder, indicating that additional factors are required for its development. Mutations in the TERT, CORN, and RT-LONG genes, all of which are involved with the maintenance of telomeres, are associated with increased risk of IPF. You will recall that maintenance of telomeres, the ends of chromosomes, is necessary to prevent cellular senescence. Up to 15% of familial IPF is associated with inherited defects in genes that maintain telomeres, while up to 25% of sporadic IPF cases are associated with abnormal telomere shortening in peripheral blood lymphocytes, a finding that also points to a problem with telomere maintenance. Other rare familial forms of IPF are associated with mutations in genes encoding components of surfactant. These mutations create folding defects in the affected proteins, leading to activation of the unfolded protein response in type 1 and 2 pneumocytes. This in turn appears to make pneumocytes more sensitive to environmental insults, leading to cellular dysfunction and injury. Finally, roughly 1/3 of IPF cases are associated with a single nucleotide polymorphism in the promoter of the MUC5B gene that greatly increases the secretion of MUC5B, a member of the mucin family. This may in turn alter mucociliary clearance, but precisely how this alteration relates to IPF risk is uncertain. Age. IPF is a disease of older individuals, rarely appearing before the age of 50 years. Whether this association stems from aging-related telomere shortening or from other acquired changes associated with aging is unknown. It is easy to imagine how some of the factors cited herein might combine to exacerbate alveolar epithelial cell damage and senescence, which seems to be the initiating event in IPF. But it must be admitted that the pathogenesis of IPF is complex and poorly understood. For example, it is unknown precisely how alveolar epithelial cell damage translates into interstitial fibrosis. One model holds that the injured epithelial cells are the source of profibrogenic factors such as TGF-beta, whereas the second, non-mutually exclusive model proposes that innate and adaptive immune cells produce such factors as part of the host response to epithelial cell damage. Other work has described abnormalities in the fibroblasts themselves that involve changes in intracellular signaling and features reminiscent of epithelial mesenchymal transition chapter 7, but a causal link between these alterations and fibrosis has not been established. Fibrosis morphology. Figure 15.13 proposed pathogenic mechanisms in idiopathic pulmonary fibrosis. Environmental factors that are potentially injurious to alveolar epithelium interact with genetic or aging-related factors that place epithelium at risk, creating a persistent epithelial injury. Factors secreted from injured/activated epithelium, possibly augmented by factors released from innate and adaptive immune cells responding to danger signals produced by damaged epithelium, activate interstitial fibroblasts. There is some evidence that these activated fibroblasts exhibit signaling abnormalities that lead to increased signaling through the PI3K/AKT pathway. The activated fibroblasts synthesize and deposit collagen, leading to interstitial fibrosis and eventual respiratory failure. Grossly, the pleural surfaces of the lung are cobblestone as a result of the retraction of scars along the interlobular septum. The cut surface shows firm, rubbery white areas of fibrosis, which occurs preferentially in the lower lobes, the subpleural regions, and along the interlobular septum. Microscopically, the hallmark is patchy interstitial fibrosis, which varies in intensity, Fig. 15-14, and age. The earliest lesions contain an exuberant proliferation of fibroblasts, fibroblastic foci. With time, these areas become more fibrotic and less cellular. Quite typical is the 690 chapter 15, the lung. Survival is about 3.8 years after diagnosis. Lung transplantation is the only definitive therapy. However, two drugs, a tyrosine kinase inhibitor and a TGF-beta antagonist, have both been shown to slow disease progression and represent the first effective, albeit modestly so targeted therapies for IPF. Nonspecific interstitial pneumonia. Despite its nonspecific name, this entity is important to recognize, since these patients have a much better prognosis than patients with UIP. Nonspecific interstitial pneumonia is most often associated with connective tissue disease but may also be idiopathic. Morphology. Figure 15.14 usual interstitial pneumonia. Fibrosis is more pronounced in the subpleural region. Courtesy Dr. Nicole Cipriani, Department of Pathology, University of Chicago, Ill. Coexistence of both early and late lesions. Fig. 15. The dense fibrosis causes the destruction of alveolar architecture and the formation of cystic spaces lined by hyperplastic type Roman II pneumocytes or broncholar epithelium honeycomb fibrosis. With accurate sampling, these diagnostic histologic changes, i.e., areas of dense fibrosis and fibroblastic foci, can be identified even in advanced IPF. There is mild to moderate inflammation within the fibrotic areas, consisting of mostly lymphocytes that mix with a few plasma cells, neutrophils, eosinophils, and mast cells. Foci of squamous metaplasia and smooth muscle hyperplasia may be present, along with pulmonary arterial hypertensive changes, intimal fibrosis, and medial thickening. In acute exacerbations, DAD may be superimposed on these chronic changes. Clinical features. IPF begins insidiously with gradually increasing dyspnea on exertion and dry cough. Most patients are 55 to 75 years old at presentation. Hypoxemia, cyanosis, and clubbing occur late in the course. The course in individual patients is unpredictable. Usually there is slowly progressive respiratory failure, but some patients have acute exacerbations and follow a rapid downhill clinical course. The median. Figure 15.15 usual interstitial pneumonia. Fibroblastic focus with fibers running parallel to surface and bluish mites on extracellular matrix. Honeycombing is present on the left. On the basis of its histology, non-specific interstitial pneumonia is divided into cellular and fibrosing patterns. The cellular pattern consists primarily of mild to moderate chronic interstitial inflammation, containing lymphocytes and a few plasma cells, and a uniform or patchy distribution. The fibrosing pattern consists of diffuse or patchy interstitial fibrotic lesions of roughly the same stage of development, an important distinction from UIP. Fibroblastic foci, honeycombing, hyaline membranes, and granulomas are absent. Clinical features: patients present with dyspnea and cough of several months' duration. They are more likely to be female non-smokers in their sixth decade of life. On imaging, the lesions have the appearance of bilateral, symmetric, predominantly lower lobe reticular opacities. Patients having the cellular pattern are somewhat younger than those with the fibrosing pattern and have a better prognosis. Cryptogenic organizing pneumonia. Cryptogenic organizing pneumonia is most often seen as a response to infection or inflammatory injury of the lungs. It has been associated with viral and bacterial pneumonias, inhaled toxins, drugs, connective tissue disease, and graft versus host disease in hematopoietic stem cell transplant recipients. Patients present with cough and dyspnea and have patchy subpleural or parabronchial areas of airspace consolidation radiographically. Histologically, it is characterized by the presence of polypoid plugs of loose organizing connective tissue mass in bodies within alveolar ducts, alveoli, and often bronchioles. Fig. 15.16. The connective tissue is all of the same age, and the underlying lung architecture is normal. There is no interstitial fibrosis or honeycomb lung. Some patients recover spontaneously, but most need treatment with oral steroids for 6 months or longer for complete recovery. The long-term prognosis is dependent on the underlying disorder. Pulmonary involvement in autoimmune diseases. Many autoimmune diseases, also referred to as connective tissue diseases because of their frequent association with arthritis, can involve the lung at some point in their course. Those that are well recognized for producing pulmonary disease include systemic lupus erythematosus, rheumatoid arthritis, progressive systemic sclerosis, scleroderma, and dermatomyositis polymyositis. Pulmonary involvement can take different histologic patterns, not specific interstitial. Chronic diffuse interstitial restrictive disease is 691. B. Figure 15.16. Cryptogenic organizing pneumonia. Some alveolar spaces are filled with balls of fibroblast mass in bodies, while the alveolar walls are relatively normal. A low power, B. High power. Pneumonia, usual interstitial pneumonia, organizing pneumonia, and bronchiolitis are the most common. Rheumatoid arthritis is associated with pulmonary involvement in 30% to 40% of patients as 1 chronic pleuritis, with or without effusion, 2 diffuse interstitial pneumonitis and fibrosis, 3 intrapulmonary rheumatoid nodules, 4 follicular bronchiolitis, or 5 pulmonary hypertension. When lung disease occurs in the setting of rheumatoid arthritis and a pneumoconiosis described next, it is referred to as Kaplan syndrome. Systemic sclerosis, scleroderma, is associated with diffuse interstitial fibrosis, not specific interstitial pattern, more common than usual interstitial pattern and pleural involvement. Lupus erythematosus may cause patchy, transient parenchymal infiltrates or occasionally severe lupus pneumonitis, as well as pleuritis and pleural effusions. Pulmonary involvement in these diseases has a variable prognosis that is determined by the extent and histologic pattern of involvement. Key concepts: chronic interstitial lung diseases. Diffuse interstitial fibrosis of the lung gives rise to restrictive lung diseases characterized by reduced lung compliance and reduced FVC. The ratio of FeV1 to FVC is normal. Idiopathic pulmonary fibrosis is prototypic of restrictive lung diseases. It is characterized by patchy interstitial fibrosis, fibroblastic foci, and formation of cystic spaces, honeycomb lung. This histologic pattern is known as usual interstitial fibrosis. The cause of idiopathic pulmonary fibrosis is unknown, but genetic analyses point to roles for senescence of alveolar epi. Ileum due to telomere shortening, altered mucin production, and abnormal signaling in alveolar fibroblasts. Injury to alveolar Epithelial cells sets in motion events that lead to increased local production of fibrogenic cytokines, such as TGF-beta. Pneumoconiosis. The term pneumoconiosis, originally coined to describe the non-neoplastic lung reaction to inhalation of mineral dust encountered in the workplace, now also includes disease induced by chemical fumes and vapors. Simplified classification is presented in Table 15.6, where implemented regulations limiting worker exposure have resulted in a marked decrease in dust-associated diseases. Pathogenesis-specific factors that influence the development of dust-borne pneumoconiosis include the following. Dust retention, which is determined by the dust concentration in ambient air, the duration of exposure, and the effectiveness of clearance mechanisms. Any influence, such as cigarette smoking, that impairs mucociliary clearance significantly increases the accumulation of dust in the lungs. Particle size. Most dangerous particles are from 1 to 5 µm in diameter because particles of this size can reach the terminal small airways and air sacs and deposit in their linings. Particle solubility and cytotoxicity, which are influenced by particle size. In general, small particles composed of injurious substances of high solubility are more likely to produce rapid onset acute lung injury. By contrast, larger particles are more likely to resist dissolution and may persist within the lung parenchyma for years. These tend to evoke fibrous and collagenous pneumoconiosis, such as is characteristic of silicosis. Particle uptake by epithelial cells will egress across epithelial linings, which allows direct interactions with fibroblasts and interstitial macrophages to occur. Some particles may reach the lymph nodes through lymphatic drainage directly or within migrating macrophages and thereby initiate an adaptive immune response to components of the particulates or to self-proteins modified by the particles or both. Activation of the inflammasome Chapter 3, which occurs following the phagocytosis of certain particles by macrophages. This innate immune response amplifies the intensity and the duration of the local reaction. Tobacco smoking, which worsens the effects of all inhaled mineral dust, but particularly those caused by asbestos. 692 Chapter 15 The lung. Table 15.6 Lung diseases caused by air pollutants. Agent disease, mineral dust, coal dust anthracosis, macular progressive massive fibrosis Kaplan syndrome, silica-silicosis Kaplan syndrome, asbestos asbestosis pleural plaques Kaplan syndrome, mesothelioma carcinoma of the lung, larynx, stomach, colon. Beryllium acute berylliosis, beryllium granulomatosis, lung carcinoma, iron oxide siderosis, barium sulfate baritosis, tin oxide stenosis, organic dust that induce hypersensitivity pneumonitis. Obie hay farmer's lung, Bagus bagasosis, bird droppings, bird breeder's lung, organic dust that induce asthma, cotton, flax, hemp bisonosis, red cedar dust asthma. Chemical fumes and vapors, nitrous oxide, sulfur dioxide, ammonia, bronchitis, asthma, benzene, insecticides, pulmonary edema, ARDS, mucosal injury, fulminant poisoning. ARDS, acute respiratory distress syndrome, exposure, coal mining, particularly hard coal, metal casting work, sandblasting, hard rock mining, stone cutting, others. Mining, milling, manufacturing, and installation and removal of insulation, mining, manufacturing, welding, mining, farming, manufacturing, wallboard, paper, bird handling, textile manufacturing, lumbering, carpentry, occupational and accidental exposure, morphology. In general, only a small percentage of exposed people develop occupational respiratory diseases, implying a genetic predisposition to their development. Many of the diseases listed in Table 15.6 are quite uncommon, hence only a select few that cause pulmonary fibrosis are presented next. Carbon deposits are dark black in color and are readily visible grossly and microscopically. Anthracosis is the most innocuous. Coal-induced pulmonary lesion in coal miners and is also seen to some degree in urban dwellers and tobacco smokers. Inhale. Carbon pigment is engulfed by alveolar or interstitial macrophages, which accumulate in the connective tissue adjacent to the lymphatics and in organized lymphoid tissue adjacent to the bronchi or in the lung hills. Simple cold workers pneumoconiosis is characterized by cold macules 1 to 2 mm in diameter and somewhat larger cold nodules. Cold macules consist of carbon-laden macrophages. Nodules also contain a delicate network of collagen fibers. Although these lesions are scattered throughout the lung, the upper lobes and upper zones of the lower lobes are more heavily involved. They are located primarily adjacent to respiratory bronchioles, the site of initial dust accumulation. In due course, dilation of adjacent alveoli occurs, sometimes giving rise to centrolobular emphysema. Complicated cold workers pneumoconiosis progressive. Massive fibrosis occurs on a background of simple disease and generally requires many years to develop. It is characterized by cold workers pneumoconiosis. Cold workers pneumoconiosis is lung disease caused by inhalation of cold particles and other mixed forms of dust. Dust reduction measures in coal mines around the globe have drastically reduced its incidence. The spectrum of lung findings in cold workers is wide, varying from asymptomatic emphycosis to simple cold workers pneumoconiosis with little to no pulmonary dysfunction, to complicated cold workers pneumoconiosis or progressive massive fibrosis, in which lung function is compromised. Contaminating silica in the coal dust favors the development of progressive disease. In most cases, carbon dust itself is the major culprit, and studies have shown that complicated lesions contain much more dust than simple lesions. Coal workers may also develop emphysema and chronic bronchitis independent of smoking. Chronic diffuse interstitial restrictive disease is 693. Figure 15.17 progressive massive fibrosis in a coal worker. A large amount of black pigment is associated with dense interstitial fibrosis. From Clatty C. Robbins and Cotran Atlas of Pathology, into Philadelphia, 2010, Saunders, P121. Intensely blackened scars 1 cm or larger, sometimes up to 10 cm in greatest diameter. They are usually multiple. Microscopically, the lesions consist of dense collagen and pigment fade. 15, 17. The center of the lesion is often necrotic, most likely due to local ischemia. African Americans are at higher risk than Caucasians. As shown in Table 15.6, workers in a large number of occupations are at risk, including individuals involved with the repair, rehabilitation, or demolition of concrete structures such as buildings and roads. The disease also occurs in workers producing stressed denim by sandblasting, stone carvers, and jewelers using chalk molds. Occasionally, heavy exposure over months to a few years can result in acute silicosis, a disorder characterized by the accumulation of abundant lipoproteinaceous material within alveoli identical morphologically to alveolar proteinosis. Discussed later. Pathogenesis. Phagocytosis of inhaled silica crystals by macrophages activates the inflammasome and stimulates the release of inflammatory mediators, particularly IL-1 and IL-18. This in turn leads to the recruitment of additional inflammatory cells and activates interstitial fibroblasts, leading to collagen deposition. Silica occurs in both crystalline and amorphous forms, but crystalline forms including quartz, cristobalite, and trimite are much more fibrogenic. Of these, quartz is most commonly implicated. The lack of severe responses to silica in coal and hematite miners is thought to be due to coating of silica with other minerals, especially clay components, which render the silica less toxic. Although amorphous silicates are biologically less active than crystalline silica, heavy lung burdens of these minerals may also produce lesions. Morphology. Silicosis is characterized grossly in its early stages by tiny, barely palpable, discrete pale to black, and if coal dust is also present, nodules in the hill of lymph nodes and upper zones of the lungs. As the disease progresses, these nodules coalesce into hard, collagenous scars fade. 15, 18. Some nodules may undergo central. Clinical features. Coal workers pneumoconiosis is usually benign, causing little decrement in lung function. Even mild forms of complicated coal workers pneumoconiosis do not affect lung function significantly. In a minority of cases, fewer than 10%, progressive massive fibrosis develops, leading to increasing pulmonary dysfunction, pulmonary hypertension, and cor pulmonale. Once progressive massive fibrosis develops, it may continue to worsen even if further exposure to dust is prevented. Unlike silicosis discussed next, There is no convincing evidence that co-workers' pneumoconiosis increases susceptibility to tuberculosis, nor does it predispose to cancer in the absence of smoking. However, domestic indoor use of smoky coal bituminous for cooking and heating, a common practice in lower-income parts of the world, is associated with an increased risk of lung cancer death, even in those who do not smoke. Silicosis. Silicosis is a common lung disease caused by inhalation of pro-inflammatory crystalline silicon dioxide silica. It usually presents after decades of exposure as slowly progressing, nodular, fibrosing pneumoconiosis. Currently, silicosis is the most prevalent chronic occupational disease in the world. Both dose and race are important in developing silicosis. Figure 15.18 Advanced silicosis. Scarring has contracted the upper lobe into a small dark mass arrow. Note the dense pleural thickening. Courtesy Dr. John Godowski, Brigham and Women's Hospital, Boston, Mass. Chapter 15 The Lung. Figure 15.19 Several coalescent collagenous silicotic nodules. Courtesy Dr. John Godowski, Brigham and Women's Hospital, Boston, Mass. Softening and cavitation due to superimposed tuberculosis or to ischemia. Fibrotic lesions may also occur in the hilar lymph nodes and pleura. Sometimes, thin sheets of calcification occur in the lymph nodes and are seen radiographically as axial calcification, i.e., calcium surrounding a zone lacking calcification. If the disease continues to progress, expansion and coalescence of lesions may produce progressive massive fibrosis. Histologic examination reveals the hallmark lesion characterized by a central area or collagen fibers with a more peripheral zone of desiccated macrophages fit. 15. 19. Examination of the nodules by polarized microscopy reveals weakly birefringent silicate particles. 694. Clinical features. The onset of silicosis may be slow and insidious 10 to 30 years after exposure. This is most common, accelerated within 10 years of exposure, or rapid weeks or months after intense exposure to fine dust high in silica. This is rare. Chest radiographs typically show a fine nodularity in the upper zones of the lung. Pulmonary function is either normal or only moderately affected early in the course. And most patients do not develop shortness of breath until progressive massive fibrosis supervenes. The disease may continue to worsen even if the patient is no longer exposed. It is slow to kill, but impaired pulmonary function may severely limit activity. Silicosis also is associated with an increased susceptibility to tuberculosis and a twofold increased risk of lung cancer. The former may be because crystalline silica inhibits the ability of pulmonary macrophages to kill phagocytose mycobacteria. The link to cancer is not fully understood, but it is but one of many chronic inflammatory conditions that increase the risk of carcinoma and involve tissues. Chapter 7. Asbestos-related diseases. Asbestos is a family of pro-inflammatory crystalline hydrated silicates that are associated with pulmonary fibrosis and various forms of cancer. Use of asbestos is tightly restricted in many higher-income countries. However, there is little, if any, control in lower-income parts of the world. Asbestos-related diseases include localized fibrous plaques or, rarely, diffuse pleural fibrosis, pleural effusions, recurrent, parenchymal interstitial fibrosis, asbestosis, lung carcinoma, mesothelioma, laryngeal, ovarian, and perhaps other extrapulmonary neoplasms, including colon carcinoma. Increased risks for systemic autoimmune diseases and cardiovascular disease also have been proposed. Increased incidence of asbestos-related cancers in family members of asbestos workers has alerted the general public to the potential hazards of even low-level exposure to asbestos. However, the necessity of expensive asbestos abatement programs for environments such as schools with low but measurable airborne asbestos fiber counts remains a matter of contention. Pathogenesis. The disease-causing capabilities of the different forms of asbestos depend on concentration, size, shape, and solubility. Asbestos occurs in two distinct geometric forms, serpentine and amphibole. The serpentine chrysotile form accounts for 90% of the asbestos used in industry. Amphiboles, even though less prevalent, are more pathogenic than chrysotiles, particularly with respect to induction of mesothelioma. a malignant tumor derived from the lining cells of pleural surfaces described later. The greater pathogenicity of amphiboles is apparently related to their aerodynamic properties and solubility. Crystals, with their more flexible, curl structure, are likely to become impacted in the upper respiratory passages and removed by the mucociliary elevator. Furthermore, once trapped in the lungs, crystals are gradually leached from the tissues because they are more soluble than amphiboles. In contrast, the straight, stiff amphiboles may align themselves with the airstream and thus be delivered deeper into the lungs, where they can penetrate epithelial cells and reach the interstitium. Both amphiboles and serpentines are fibrogenic, and increasing doses are associated with a higher incidence of asbestos-related diseases. In contrast to other inorganic dusts, asbestos acts as a tumor initiator and a tumor promoter. Chapter 7. Some of its oncogenic effects are mediated by reactive free radicals generated by asbestos fibers, which preferentially localize in the distal lung, close to the mesothelial cells of the pleuron. Toxic chemicals absorbed onto the asbestos fibers also likely contribute to the oncogenicity of the fibers. For example, the absorption of carcinogens and tobacco smoke onto asbestos fibers may be the basis for the remarkable synergy between tobacco smoking and the development of lung carcinoma in asbestos workers. Smoking also enhances the effect of asbestos by interfering with the mucociliary clearance of fibers. One study of asbestos workers found a 5-fold increase of lung carcinoma with asbestos exposure alone, while asbestos exposure in smoking together led to a 55-fold increase in the risk. Once phagocytosed by macrophages, asbestos fibers activate the inflammasome and stimulate the release of pro-inflammatory factors and fibrogenic mediators. The initial injury occurs at bifurcations of small airways and ducts, where asbestos fibers land, penetrate, and are directly toxic to pulmonary parenchymal cells. Macrophages, both. Diffuse interstitial restrictive disease is 695, alveolar and interstitial. Attempt to ingest and clear the fibers. Long-term deposition of fibers and persistent release of mediators, for example, reactive oxygen species, proteases, cytokines, and growth factors eventually lead to generalized interstitial pulmonary inflammation and fibrosis. Morphology. Asbestosis is marked by diffuse pulmonary interstitial fibrosis, which is distinguished from diffuse interstitial fibrosis resulting from other causes only by the presence of asbestos bodies. Asbestos bodies are golden brown, fusiform or beaded rods with a translucent center that consist of asbestos fibers coated with an iron-containing proteinaceous material Fig. 15.20. They arise when macrophages phagocytose asbestos fibers. The iron is presumably derived from phagocyte ferritin. Other inorganic particulates may become coated with similar iron protein complexes and are called ferruginous bodies. Asbestosis begins as fibrosis around respiratory bronchioles and alveolar ducts and extends to involve adjacent alveolar sacs and alveoli. The fibrosis distorts the architecture, creating enlarged air spaces enclosed by thick fibrous walls. Eventually, the affected regions become honeycomb. The pattern of fibrosis is histologically similar to that seen in usual interstitial fibrosis, with fibroblastic foci and varying degrees of fibrosis. In contrast to co-workers pneumoconiosis and silicosis, asbestosis begins in the lower lobes and subplurally, with the middle and upper lobes becoming affected as fibrosis progresses. Scarring may trap and narrow pulmonary arteries and arterioles, causing pulmonary hypertension and cor pulmonale. Pleural plaques, the most common manifestation of asbestos exposure, are well-circumscribed plaques of dense collagen that are often calcified. Fig. 15.21. They develop most frequently on the anterior and posterolateral aspects of the parietal pleura and over the domes of the diaphragm. The size and number of pleural plaques do not correlate with the level of exposure to asbestos or the time since exposure. They also do not contain identifiable asbestos bodies. However, only rarely do they occur in individuals without a history or evidence of asbestos exposure. Commonly, asbestos exposure induces pleural effusions, which are usually serous but may be bloody. Rarely, diffuse visceral pleural fibrosis may occur in advanced cases, bind the lung to the thoracic wall. Figure 15.21 Asbestos-related pleural plaques. Large, discrete fibrocalcific plaques are seen on the pleural surface of the diaphragm. Courtesy Dr. John Godowski, Brigham and Women's Hospital, Boston, Mass. Both lung carcinomas and mesotheliomas pleural and peritoneal develop in workers exposed to asbestos. See sections on carcinomas and pleural tumors. Clinical features. The clinical findings in asbestosis are very similar to those caused by other diffuse interstitial lung diseases discussed earlier. They rarely appear fewer than 10 years after first exposure and are more common after 20 to 30 years. Dyspnea is usually the first manifestation. At first, it is provoked by exertion, but later is present even at rest. Cough associated with production of sputum, when present, is likely to be due to smoking rather than asbestosis. Chest X-ray studies reveal irregular linear densities, particularly in both lower lobes. With advancement of the pneumoconiosis, a honeycomb pattern develops. The disease may remain static or progress to respiratory failure, cor pulmonale, and death. Pleural plaques are usually asymptomatic and are detected on radiographs as circumscribed densities. Asbestosis complicated by lung or pleural cancer is associated with a particularly grim prognosis. Key concepts. Pneumoconiosis. Pneumoconiosis encompasses a group of chronic fibrosing diseases of the lung resulting from exposure to organic and inorganic particulates, most commonly mineral dust. Pulmonary alveolar macrophages play a central role in the pathogenesis of lung injury by promoting inflammation and producing fibrogenic cytokines. Coal dust-induced disease varies from asymptomatic anthocosis to simple cold workers' pneumoconiosis, cold macules or nodules, and centrilobular emphysema, to progressive massive fibrosis, manifested by increasing pulmonary dysfunction, pulmonary hypertension, and cor pulmonale. Silicosis is the most common pneumoconiosis in the world. In crystalline silica, for example, quartz is the usual culprit. The lung disease is progressive even after exposure stops. Chronic. Figure 15.20 high-power detail of an asbestos body, revealing the typical beating and knob ends error. 696 Chapter 15 The lung. The manifestations of silicosis range from asymptomatic silicotic nodules to large areas of dense fibrosis. Persons with silicosis also have an increased susceptibility to tuberculosis. There is twofold increased risk of lung cancer. Asbestos fibers come in two forms. The stiffened fibrils have a greater fibrogenic and carcinogenic potential than the cert. Anticristals. Asbestos exposure is linked with 6 disease processes. 1. Parenchymal interstitial fibrosis asbestosis. 2. Localized pleural. Plaques asymptomatic or rarely diffuse pleural fibrosis. 3. Recurrent pleural effusions. 4. Lung carcinoma. 5. Malignant pleural and peritoneal mesotheliomas. And 6. Laryngeal cancer. Cigarette smoking increases the risk of lung cancer in the setting of asbestos exposure. Even family members of workers exposed to asbestos are at increased risk for lung carcinoma. Mesothelioma, complications of therapies. Drug-induced lung diseases. An increasing number of prescription drugs have been found to cause a variety of acute and chronic alterations in lung structure and function. Interstitial fibrosis, bronchiolitis obliterans, and eosinophilic pneumonia. For example, cytotoxic drugs used in cancer therapy, for example, bleomycin cause pulmonary damage and fibrosis as a result of direct toxicity and by stimulating the influx of inflammatory cells into the alveoli. Amiodarone, the drug used to treat cardiac arrhythmias, is preferentially concentrated in the lung and causes significant pneumonitis in 5% to 15% of patients receiving it. Cough induced by angiotensin-converting enzyme inhibitors is very common. Illicit intravenous drug abuse most often causes lung infections. In addition, particulate matter used to cut drugs may lodge in the lung microvasculature, producing granulomatous inflammation and fibrosis. Radiation-induced lung diseases. Radiation pneumonitis is a well-known complication of radiotherapy for thoracic tumors, lung, esophageal, breast, mediastinal. Most often involves the lung within the radiation field and occurs in acute and chronic forms. Acute radiation pneumonitis, lymphocytic alveolitis, or hypersensitivity pneumonitis occurs 1 to 6 months after irradiation in 3% to 44% of patients, depending on dose and age. manifests with fever, dyspnea out of proportion to the volume of lung-irradiated pleural effusion, and pulmonary infiltrates. Morphologic changes are those of diffuse alveolar damage associated with atypia of hyperplastic type Roman II pneumocytes and fibroblasts. Epithelial cell atypia and foam cells within vessel walls are also characteristic of radiation damage. With steroid therapy, these symptoms may resolve completely, but other cases progress to chronic radiation pneumonitis pulmonary fibrosis, which also may occur without antecedent, clinically apparent, acute radiation pneumonitis. In its most severe form, chronic radiation pneumonitis and associated progressive fibrosis can lead to cyanosis, pulmonary hypertension, and cor pulmonale. Granulomatous diseases. Sarcoidosis is a systemic granulomatous disease of unknown cause that may involve many tissues and organs. Its various clinical presentations are proteinic, but the most common are bilateral hilar lymphadenopathy or parenchymal lung involvement, occurring in 90% of cases. Eye and skin lesions are next in frequency. 6 other diseases, including mycobacterial and fungal infections and borreliosis, can also produce non-case-hitting granulomas. The diagnosis is one of exclusion. Sarcoidosis usually occurs in adults younger than 40 years of age but can affect any age group. The prevalence is higher in women but varies widely in different countries and populations. In the United States, the rates are highest in the Southeast and are 10 times higher in African Americans than in Caucasians. In contrast, the disease is rare among the Chinese and Southeast Asians. Patterns of organ involvement also vary with race. Pathogenesis. Although several lines of evidence suggest that sarcoidosis is a disease of disordered immune regulation in genetically predisposed individuals, its etiology is unknown. There are several immunologic abnormalities in the local milieu of sarcoid granulomas that suggest a cell-mediated immune response to an unidentified antigen. These abnormalities include intraalveolar and interstitial accumulation of CD4 plus T cells, resulting in CD4/CD8 T cell ratios ranging from 5:1 to 15:1, suggesting pathogenic involvement of CD4 plus helper T cells. There is oligoclonal expansion of T cell subsets as determined by analysis of T cell receptor rearrangement, consistent with an antigen-driven proliferation. Increased levels of T cell-derived cytokines such as IL-2 and interferon IFN-gamma, which may be responsible for T cell expansion and macrophage activation, respectively. Increased levels of several cytokines in the local environment IL-8, TNF, macrophage inflammatory protein 1-alpha that favor recruitment of additional T cells and monocytes and contribute to the formation of granulomas. TNF in particular is released at high levels by activated alveolar macrophages, and the TNF concentration in the bronchoalveolar fluid is a marker of disease activity. Impaired dendritic cell function. Additionally, there are systemic immunologic abnormalities in individuals with sarcoidosis. Both antigen-common skin test antigens, such as Candida or tuberculosis purified protein derivative PPD, and polyclonal hyperhemoglobulinemia, another manifestation of helper T cell dysregulation, are frequently observed. Evidence of genetic influences includes familial and racial clustering of cases and their association with certain human leukocyte antigen HLA genotypes, for example, HLA-A and HLA-B. Morphology. Virtually every organ in the body has been described as being affected by sarcoidosis, at least on rare occasions. Involved tissues contain well-formed non-necrotizing granulomas Fig. 15.22. Composed of aggregates of tightly clustered epithelioid macrophages, often with giant cells. Central necrosis is unusual. With chronicity, the granulomas may become enclosed within fibrous rims or may eventually be replaced by high-line fibrous scars. Diffuse interstitial restrictive disease is 697, slightly braided in scaling, resembling those of systemic lupus erythematosus. Lesions may also appear on the mucous membranes of the oral cavity, larynx, and upper respiratory tract. Other patients present with erythema nodosum, painful erythematous nodules on the shins that stem from septal paniculitis. Ocular involvement, seen in 25% of cases, takes the form of iritis or iridocyclitis and may be bilateral or unilateral. Consequently, corneal opacities, glaucoma, and total loss of vision may occur. These ocular lesions are frequently accompanied by inflammation of the lacrimal glands and suppression of lacrimation-Sicca syndrome. Bilateral sarcoidosis of the parotid, submaxillary, and sublingual glands constitutes the combined uveitic involvement designated as maculic syndrome chapter 16. Muscle involvement is underdiagnosed, since it may be asymptomatic. Muscle weakness, aches, tenderness, and fatigue should prompt consideration of occult sarcoid myositis, which can be diagnosed by muscle biopsy. Sarcoid granulomas occasionally occur in the heart, kidneys, central nervous system neurosarcoidosis, seen in 5% to 15% of cases, in endocrine glands, particularly in the pituitary, as well as in other body tissues. Figure 15.22 bronchus with characteristic non-casating sarcoidal granulomas asterisks with many multinucleated giant cells arrowheads. Note subepithelial location of granulomas. Laminated concretions composed of calcium and proteins known as Schulman bodies and stellate inclusions known as asteroid bodies are found within giant cells in approximately 60% of the granulomas. Characteristic. These microscopic features are not pathognomonic of sarcoidosis because asteroid and Schulman bodies may be encountered in other granulomatous diseases, for example, tuberculosis. The lung is a common site of involvement. Macroscopically, there is usually no demonstrable alteration, although in advanced cases coalescence of granulomas produces small nodules that are palpable or visible as 1 to 2 cm, non-casating, non-cavitated consolidations. Lesions are distributed primarily along the lymphatics around bronchi and blood vessels, although alveolar lesions and pleural involvement are also seen. The relatively high frequency of granulomas in the bronchial submucosa accounts for the high diagnostic yield of bronchoscopic biopsies. There seems to be a strong tendency for lesions to heal in the lungs, so varying stages of fibrosis and hyalinization are often found. Lymph nodes are involved in almost all cases, particularly the hilar and mediastinal nodes, but any node in the body may be affected. Nodes are characteristically enlarged, discrete, and sometimes calcified. Consular granulomas are seen in about 1/4 to 1/3 of cases. The spleen is involved in about 75% of cases, but overt splenomegaly is seen in only 20% of cases. On occasion, granulomas may coalesce to form small nodules that are visible macroscopically. The liver is affected slightly less often than the spleen. It may be moderately enlarged and typically contains scattered granulomas, more in portal trias than in the lobular parenchyma. The bone marrow is involved in about 20% of cases. Radiologically, visible bone lesions have a particular tendency to involve phalangeal bones of the hands and feet, creating small circumscribed areas of bone resorption within the marrow cavity and a diffuse reticulated pattern throughout the cavity, with widening of the bony shafts or new bone formation on the outer surfaces. Skin lesions, encountered in 25% of cases, assume a variety of appearances, including discrete subcutaneous nodules, focal, slightly elevated, erythematous plaques, or flat lesions that are clinical features because of its varying severity and inconstant tissue distribution. Sarcoidosis may present with diverse features. It may be discovered unexpectedly on routine chest films as bilateral hilar adenopathy or may present with peripheral lymphadenopathy, cutaneous lesions, eye involvement, splenomegaly, or hepatomegaly. In the great majority of cases, however, individuals seek medical attention because of the insidious onset of respiratory abnormalities, shortness of breath, cough, chest pain, hemoptysis, or constitutional signs and symptoms, fever, fatigue, weight loss, anorexia, night sweats. Sarcoidosis follows an unpredictable course. It may be inexorably progressive or marked by periods of activity interspersed with remissions, sometimes permanent, that may be spontaneous or induced by steroid therapy. Overall, 65% to 70% of affected patients recover with minimal or no residual manifestations. 20% have permanent loss of some lung function or some permanent visual impairment. The remaining 10% to 15%, some die of cardiac or central nervous system damage, but most succumb to progressive pulmonary fibrosis and cor pulmonale. Key concepts: sarcoidosis. Sarcoidosis is a multisystem disease of unknown etiology. The diagnostic histopathologic feature is the presence of non-caseating granulomas in various tissues. Immunologic abnormalities include high levels of CD4 plus T cells in the lung that secrete phone-dependent cytokines such as IL gamma and IL-2 locally. Clinical manifestations include lymph node enlargement, eye involvement, Sicca syndrome, dry eyes, neuritis, or iridocyclitis. Skin lesions, for example, erythema nodosum, and visceral liver. Skin, marrow involvement. Lung involvement occurs in 90% of cases, with formation of granulomas and interstitial fibrosis. Chronic. 698 Chapter 15 The lung. Hypersensitivity pneumonitis. The term hypersensitivity pneumonitis describes a spectrum of immunologically mediated, predominantly interstitial lung disorders caused by intense, often prolonged exposure to inhaled organic antigens. Affected individuals have an abnormal sensitivity or heightened reactivity to the causative antigen, which, in contrast to asthma, leads to pathologic changes that primarily involve the alveolar walls, thus the synonym extrinsic allergic alveolitis. It is important to recognize these diseases early in their course because progression to serious chronic fibrotic lung disease can be prevented by removal of the environmental agent. Most commonly, hypersensitivity results from the inhalation of organic dust-containing antigens made up of the spores of thermophilic bacteria, fungi, animal proteins, or bacterial products. Numerous syndromes are described, depending on the occupation or exposure of the individual. Farmers' lung results from exposure to dust generated from humid, warm, newly harvested hay that permits the rapid proliferation of the spores of thermophilic actinomycetes. Pigeon breeders' lung bird fancier's disease is provoked by proteins from serum, excreta, or feathers of birds. Humidifier or air conditioner lung is caused by thermophilic bacteria in heated water reservoirs. Dead birds and moldy basements are easily missed unless asked about specifically. Several lines of evidence suggest that hypersensitivity pneumonitis is an immunologically mediated disease. Bronchoalveolar lavage specimens from the acute phase show increased levels of pro-inflammatory chemokines such as macrophage inflammatory protein 1 alpha and IL-8. Bronchoalveolar lavage specimens also consistently demonstrate increased numbers of both CD4 plus and CD8 plus T lymphocytes. Most patients have specific antibodies against the causative antigen in their serum. Complement and immunoglobulins have been demonstrated within vessel walls by immunofluorescence. The presence of non-necrotizing granulomas in 2/3 of the patients suggests that T-cell mediated type Roman 4 hypersensitivity reactions against the implicated antigens have a pathogenic role. Morphology. Histologic changes depend on the phase of the disease. Acute alveolar damage is seen in the first hours and few days after antigen exposure, while subacute changes are characteristically centered on bronchioles. They include interstitial pneumonitis, consisting primarily of lymphocytes, plasma cells, and macrophages. Eosinophils are rare, as well as non-necrotizing granulomas fate. 15.23. Interstitial fibrosis with fibroblastic foci, honeycombing, and obliterative bronchiolitis together with granulomas is seen in the chronic phase. Clinical features. The clinical manifestations are varied. Acute attacks, which follow inhalation of antigenic dust in sensitized patients, consist of episodes of fever, dyspnea, cough, and leukocytosis. Micronodular interstitial infiltrates may appear in the chest radiograph, and pulmonary function tests show an acute restrictive disorder. Symptoms usually appear 4 to 6. Figure 15.23 Hypersensitivity pneumonitis. Loosely formed interstitial granulomas and chronic inflammation are characteristic. Hours after exposure, it may last for 12 hours to several days. They recur with re-exposure. If exposure is continuous and protracted, a chronic form of the disease supervenes, leading to progressive fibrosis, dyspnea, and cyanosis, a picture similar to that seen in other forms of chronic interstitial disease. Pulmonary eosinophilia. Although relatively rare, there are several clinical and pathologic pulmonary entities that are characterized by an infiltration of eosinophils, recruited in part by elevated alveolar levels of eosinophil attractants such as IL-5. Pulmonary eosinophilia is divided into the following categories: Acute eosinophilic pneumonia with respiratory failure. This is an acute illness of unknown cause. It has a rapid onset with fever, dyspnea, and hypoxemic respiratory failure. The chest radiograph shows diffuse infiltrates. The bronchoalveolar lavage fluid contains more than 25% eosinophils. Histology shows diffuse alveolar damage and many eosinophils. There is a prompt response to corticosteroids. Secondary eosinophilia, which occurs in a number of parasitic, fungal, and bacterial infections, and hypersensitivity pneumonitis, and drug allergies, and in association with asthma, allergic bronchopulmonary aspergillosis, or Church-Strauss syndrome, a form of vasculitis. Idiopathic chronic eosinophilic pneumonia, characterized by focal areas of cellular consolidation of the lung substance distributed chiefly in the periphery of the lung fields. Prominent in these lesions are aggregates of lymphocytes and eosinophils within the septal walls and the alveolar spaces. Interstitial fibrosis and organizing pneumonia are often present. These patients have cough, fever, night sweats, dyspnea, and weight loss, all of which respond to corticosteroid therapy. Chronic eosinophilic pneumonia is diagnosed when other causes of pulmonary eosinophilia are excluded. Smoking-related interstitial diseases. Smoking-related diseases can be grouped into obstructive diseases, emphysema, and chronic bronchitis, already. Chronic diffuse interstitial restrictive disease is 699. Discussed and restrictive or interstitial diseases. A majority of individuals with idiopathic pulmonary fibrosis are smokers. However, the role of cigarette smoking and its pathogenesis has not been clarified yet. Squamative interstitial pneumonia and respiratory bronchiolitis. Associated interstitial lung disease are two others. Smoking-associated interstitial lung disease is worthy of brief mention. Squamative interstitial pneumonia. Squamative interstitial pneumonia is characterized by large collections of macrophages in the air spaces of a current or former smoker. Macrophages were originally thought to be desquamated pneumocytes. Thus the misnomer desquamative interstitial pneumonia, respiratory bronchiolitis, associated interstitial lung disease. Respiratory bronchiolitis, associated interstitial lung disease is marked by chronic inflammation and bronchial fibrosis. It is a common histologic lesion in cigarette smokers. It is characterized by the presence of pigmented intraluminal macrophages within first and second-order respiratory bronchioles. In its mildest form, it is most often an incidental finding in the lungs of smokers or ex-smokers. The term respiratory bronchiolitis, associated interstitial lung disease, is used for patients who develop significant pulmonary symptoms, abnormal pulmonary function, and imaging abnormalities. Morphology. Morphology: the changes are patchy or low magnification and have a bronchiolocentric distribution. Respiratory bronchioles, alveolar ducts, and parabroncholar spaces contain aggregates of dusty brown macrophages. Smokers' macrophages similar to those seen. Desquamative interstitial pneumonia. There is a patchy submucosal and parabroncholar infiltrate of lymphocytes and histocytes. Mild parabroncholar fibrosis is also seen, which expands contiguous alveolar septum. Centrolobular emphysema is common but not severe. Desquamative interstitial pneumonia is often found in different parts of the same lung. The most striking finding is the accumulation of a large number of macrophages with abundant cytoplasm containing dusty brown pigment. Smokers' macrophages in the airspace is Fig. 15.24. Some of the macrophages contain lamellar bodies composed of surfactant within phagocytic vacuoles, presumably derived from necrotic-type Roman II pneumocytes. The alveolar septa are thickened by a sparse inflammatory infiltrate of lymphocytes, plasma cells, and occasional eosinophils. The septa are lined by plump, cuboidal pneumocytes. Interstitial fibrosis, when present, is mild. Emphysema is often present. Desquamative interstitial pneumonia usually presents in the 4th or 5th decade of life and is now equally common in men and women. Virtually all patients are cigarette smokers. Presenting symptoms include an insidious onset of dyspnea and dry cough over weeks or months, often associated with clubbing of digits. Pulmonary function tests usually show a mild restrictive abnormality and moderately decreased diffusing capacity. Patients with desquamative interstitial pneumonia typically have an excellent response to steroid therapy and cessation of smoking, but occasionally patients progress to interstitial fibrosis. Figure 15.24 Desquamative interstitial pneumonia. Medium power detail of lung demonstrates the accumulation of large numbers of macrophages within the alveolar spaces and only mild fibrous thickening of the alveolar walls. Symptoms are usually mild, consisting of gradual onset of dyspnea and cough in patients who are typically current cigarette smokers with exposures of over 30 pack years in the fourth or fifth decade of life. Cessation of smoking usually results in improvement. Pulmonary Langerhans cell histiocytosis. Pulmonary Langerhans cell histiocytosis is a rare disease characterized by focal collections of Langerhans cells often accompanied by eosinophils. As these lesions progress, scarring occurs, leading to airway destruction and alveolar damage that result in the appearance of irregular cystic spaces. Imaging of the chest shows characteristic cystic and nodular abnormalities. Langerhans cells are immature dendritic cells with grooved, indented nuclei and abundant cytoplasm. They are positive for SON100, C-donia, and 207 Langerhans and are negative for CD68. More than 90% of affected patients are relatively young adult smokers or ex-smokers. Among smokers, about half improve after smoking cessation, suggesting that in some cases the lesions are a reactive inflammatory process. However, in other cases the Langerhans cells have activating mutations in the serine/threonine kinase BRAF, a feature consistent with a neoplastic process that is also commonly seen in Langerhans cell histiocytosis involving other tissues. Chapter 13. Neoplastic basis may explain why the disease progresses in some patients, sometimes even necessitating lung transplantation. Pulmonary alveolar proteinosis. Pulmonary alveolar proteinosis (PAP) is a rare disease caused by defects in pulmonary macrophage function. Bill 700, Chapter 15. The lung. To deficient granulocyte macrophage colony stimulating factor GM-CSF signaling, which results in the accumulation of surfactant in the intra-alveolar and broncholar spaces. PAP is characterized radiologically by bilateral patchy asymmetric pulmonary ossifications. There are three distinct classes of disease: autoimmune, formerly called acquired, secondary, and congenital, each with a similar spectrum of histologic changes. Autoimmune PAP is caused by autoantibodies that bind and neutralize the function of GM-CSF. It occurs primarily in adults, represents 90% of all cases of PAP, and lacks any familial predisposition. Knockout of the GM-CSF gene in mice induces PAP, and these mice are cured by treatment with GM-CSF. Loss of GM-CSF signaling blocks the terminal differentiation of alveolar macrophages, impairing their ability to catabolize surfactant. Secondary PAP is uncommon and is associated with diverse diseases, including hematopoietic disorders, malignancies, immunodeficiency disorders, lysine protein intolerance and inborn error of amino acid metabolism, and acute silicosis and other inhalational syndromes. It is speculated that these diseases somehow impair GM-CSF, dependent signaling or downstream events involved in macrophage maturation or function, again leading to inadequate clearance of surfactant from alveolar spaces. Hereditary PAP is extremely rare, occurs in neonates, and is caused by loss of function mutations in the genes that encode GM-CSF or the GM-CSF receptor. Morphology. The disease is characterized by the accumulation of intra-alveolar precipitates containing surfactant proteins, causing focal talk and fluid consolidation of large areas of the lungs with minimal inflammatory reaction. Fate 15.25. As a consequence, there is a marked increase in the size and weight of the lung. The alveolar precipitate is pink, homogeneous, and periodic acid, SCIF, positive and contains cholesterol clefts and surfactant proteins which can be demonstrated by immunohistochemical stains. Ultrastructurally, the surfactant lamelli and type Roman II pneumocytes are normal, in contrast to surfactant dysfunction disorders described next. Clinical features: adult patients, for the most part, present with cough and abundant sputum that often contains chunks of gelatinous material. Some have symptoms lasting for years, often with intermittent febrile illnesses caused by secondary pulmonary infections with a variety of organisms. Progressive dyspnea, cyanosis, and respiratory insufficiency may occur, but other patients follow a benign course with eventual resolution of the lesions. Whole lung lavage is the standard of care and provides benefit regardless of the underlying defect. GM-CSF therapy is safe and effective in more than half of patients with autoimmune PAP, and therapy directed at the underlying disorder may also be helpful. Primary disease is treated with GM-CSF replacement therapy, sometimes followed by allogeneic hematopoietic stem cell transplantation, which can be curative. Surfactant dysfunction disorders. Surfactant dysfunction disorders are diseases caused by diverse mutations in genes encoding proteins involved in surfactant trafficking or secretion. Clinical manifestations range from neonatal respiratory failure to adult-onset interstitial lung disease. The most commonly mutated genes are the following. ATP-binding cassette protein member 3 ABCA3 is the most frequently mutated gene in surfactant dysfunction disorders. Mutations in ABCA3 are associated with an autosomal recessive disorder that usually presents in the first few months of life with rapidly progressive respiratory failure followed by death. Less commonly, it comes to attention in older children and in adults with chronic interstitial lung disease. The second most commonly mutated gene in surfactant dysfunction disorders encodes surfactant protein C. This form has an autosomal dominant mode of inheritance and has a highly variable course. The third most commonly mutated gene in surfactant dysfunction disorders encodes surfactant protein B. This form has an autosomal recessive mode of inheritance. Typically, the infant is full-term and develops progressive respiratory distress shortly after birth. Death ensues between 3 and 6 months of age unless lung transplantation is performed. Morphology. There is a variable amount of intra-alveolar pain granular material, type Roman II pneumocyte hyperplasia, interstitial fibrosis, and alveolar simplification. Immunohistochemical stains show the lack of surfactant proteins C and B and their respective deficiencies. Ultrastructurally, abnormalities in lamellar bodies and type Roman II pneumocytes can be seen in all three. Small lamellar bodies with electron-dense cores are diagnostic for ABCA3 mutation Fig. 15.26. Diseases of vascular origin. Figure 15.25 Pulmonary alveolar prognosis. The alveoli are filled with a dense, amorphous, protein-lipid granular precipitate, while the alveolar walls are normal. Pulmonary embolism and infarction. Pulmonary embolism is an important cause of morbidity and mortality, particularly in patients who are bedridden. Diseases of vascular origin 701. Hemodynamic compromise due to increased resistance to pulmonary blood flow caused by the embolic obstruction. Sudden death often ensues, largely as a result of a blockage of blood flow through the lungs. Death may also be caused by acute right-sided heart failure, acute cor pulmonale. Morphology. Figure 15.26 Pulmonary alveolar prognosis associated with mutation of the ABCA3 gene. An electron micrograph shows type II pneumocytes containing small surfactant lamellae with electron-dense cores, an appearance that is characteristic of cases associated with ABCA3 mutations, but also in a wide range of conditions that are associated with hypercoagulability. Blood clots that occlude the large pulmonary arteries are almost always embolic in origin. Usual source: thrombi in the deep veins of the leg. 95% of cases, and the magnitude of the clinical problem were discussed in Chapter 4. Pulmonary embolism causes more than 50,000 deaths in the United States each year. Incidence and autopsy has varied from 1% in the general population of hospital patients to 30% in patients dying after severe burns, trauma, or fractures. It is the sole or major contributing cause of death in about 10% of adults who die acutely in hospitals. By contrast, large vessel pulmonary thromboses are rare and develop only in the presence of pulmonary hypertension and heart failure. Pathogenesis. Pulmonary embolism usually occurs in patients with a predisposing condition that produces an increased tendency to clot thrombophilia. Patients often have cardiac disease or cancer or have been immobilized for several days or weeks prior to the appearance of the symptomatic embolism. Patients with hip fractures are at particularly high risk, hypercoagulable states, either primary, for example, factor V latent, prothrombin mutations, an antiphospholipid syndrome or secondary, for example, obesity, recent surgery, cancer, or contraceptive use, pregnancy, are important risk factors. Dwelling central venous lines can be a nidus for formation of right atrial thrombi, which can embolize to the lungs. Rarely, pulmonary embolism may consist of fat, air, or tumor. Small bone marrow emboli are often seen in patients who die after chest compressions performed during resuscitative efforts. The pathophysiologic response and clinical significance of pulmonary embolism depend on the extent to which pulmonary artery blood flow is obstructed, the size of the occluded vessels, the number of emboli, and the cardiovascular health of the patient. Emboli have two deleterious pathophysiologic consequences: respiratory compromise due to the non-perfused, although ventilated, segment, and large emboli lodge in the main pulmonary artery or its major branches or at the bifurcation as a saddle embolus fate. 15.27. Smaller emboli travel out into the more peripheral vessels, or they may cause hemorrhage or infarction. In patients with adequate cardiovascular function, the bronchial arterial supply sustains the lung parenchyma. In this instance, hemorrhage may occur, but there is no infarction. Those in whom cardiovascular function is already compromised, such as patients with heart or lung disease, infarction is more likely. Overall, about 10% of emboli cause infarction. About 75% of infarcts affect the lower lobes, and in more than half, multiple lesions occur. They vary in size from barely visible to massive lesions involving large parts of the lobe. Typically, they extend to the periphery of the lung as a wedge with the apex pointing toward the hilus of the lung. In many cases, the occluded vessel is identified near the apex of the infarct. Pulmonary embolus can be distinguished from a postmortem clot by the presence of the lines of Zahn in the thrombus. Chapter 4. The pulmonary infarct is classically hemorrhagic and appears as a raised, red-blue area in the early stages. Fig. 15.28. Often, the postpleural surface is covered by a fibrinous exudate. The red cells begin to lyse within 48 hours, and the infarct becomes paler and eventually red-brown as hemosiderin is produced. With the passage of time, fibrous replacement begins at the margins, as a gray-white peripheral zone and eventually converts the infarct into a contracted score. Histologically, the hemorrhagic area shows ischemic necrosis of the alveolar walls, bronchioles, and vessels. If the infarct is caused by an infected embolus, the neutrophilic inflammatory reaction can be intense. Such lesions are referred to as septic infarcts, some of which turn into abscesses. Clinical features of large pulmonary embolus is one of the few causes of virtually instantaneous death. During cardiopulmonary resuscitation in such instances, the patient frequently is sent. Figure 15.27 large saddle embolus from the femoral vein lying astride the main left and right pulmonary arteries. From the teaching collection of the Department of Pathology, University of Texas Southwestern Medical School, Dallas, Texas. Chapter 15. The lung. Anticoagulation is contraindicated. May be fitted with an inferior vena cava filter and umbrella that catches clots before they reach the lungs. Figure 15.28 acute hemorrhagic pulmonary infarct. To have electromechanical dissociation, in which the electrocardiogram has a rhythm, but no pulses are palpated because no blood is entering the pulmonary arterial circulation. The patient survives after a sizable pulmonary embolus. However, the clinical syndrome may mimic myocardial infarction, with severe chest pain, dyspnea, and shock. Small emboli are silent or induce only transient chest pain and cough. In the remaining group of patients with symptomatic pulmonary embolism, the most common presenting symptoms in descending order are dyspnea, pleuritic pain, and cough, accompanied in about half of cases by calf or thigh swelling or pain. Emboli that lead to pulmonary infarction may additionally produce fever and hemoptysis. An overlying fibrinous pleuritis may produce a pleural friction rub. In hemodynamically stable patients with a low to moderate risk of pulmonary embolism, D-dimer measurement is a useful screening test, as a normal D-dimer level excludes pulmonary embolism. Definitive diagnosis is usually made by computed tomographic pulmonary angiogram, which identifies obstructed pulmonary arteries. Rarely, Other diagnostic methods, such as ventilation perfusion scanning, are required. Deep vein thrombosis can be diagnosed with duplex ultrasonography. Chest radiography may be normal or disclose a pulmonary infarct, usually 12 to 36 hours after it has occurred, as a wedge-shaped infiltrate. After the initial acute insult, emboli often resolve via contraction and fibrinolysis, particularly in relatively young patients. If unresolved, with time multiple small emboli may lead to pulmonary hypertension and chronic cor pulmonale. Perhaps most important is that a small embolus may presage a larger one. In the presence of an underlying predisposing condition, patients with a pulmonary embolus have a 30% chance of suffering a second embolus. Prevention of pulmonary embolism is a major clinical challenge for which there is no easy solution. Prophylactic therapy includes early ambulation in postoperative and postpartum patients, elastic stockings and graduated compression stockings for bedridden patients, and anticoagulation in high-risk individuals. Treatment of pulmonary embolism includes anticoagulation and supportive measures. Thrombolysis may have some benefit in patients with severe complications, for example, shock, but carries a high risk of bleeding. Those at risk of recurrent pulmonary embolism in home. Key concepts: pulmonary embolism. Almost all large pulmonary artery thrombi are embolic in origin, usually arising from the deep veins of the lower leg. Risk factors include prolonged bed rest, leg surgery, severe trauma, congestive heart failure, use of oral contraceptives, especially those with high estrogen content, disseminated cancer, and inherited forms of hypercoagulability. The vast majority, 60% to 80% of emboli, are clinically silent. A minority, 5%, cause acute cor pulmonale, shock, or death, typically from large saddle emboli, and the remainder cause symptoms related to ventilation perfusion mismatch and or pulmonary infarction, particularly dyspnea and pleuritic chest. Pain. Risk of recurrence is high, and recurrent embolism may eventually lead to pulmonary hypertension and cor pulmonale. Pulmonary hypertension. Pulmonary hypertension is defined as a mean pulmonary artery pressure greater than or equal to 25 mmHg at rest. Based on underlying mechanisms, the WHO has classified pulmonary hypertension into 5 groups. 1. Pulmonary arterial hypertension, a diverse collection of disorders that all primarily impact small pulmonary muscular arteries. 2. Pulmonary hypertension due to left heart failure. 3. Pulmonary hypertension due to lung diseases and / or hypoxia. 4. Chronic thromboembolic pulmonary hypertension and other obstructions. And 5. Pulmonary hypertension with unclear and / or multifactorial mechanisms. Pathogenesis, as can be gathered from the above classification, pulmonary hypertension has diverse causes even within each group. It is most frequently associated with structural cardiopulmonary conditions that increase either pulmonary blood flow, pulmonary vascular resistance, or left heart resistance to blood flow. Some of the more common causes are the following. Chronic obstructive or interstitial lung diseases, Group 3. These diseases obliterate alveolar capillaries, increasing pulmonary resistance to blood flow and, secondarily, pulmonary blood pressure. Antecedent congenital or acquired heart disease, Group 2. Mitral stenosis, for example, causes an increase in left atrial pressure and pulmonary venous pressure that is eventually transmitted to the arterial side of the pulmonary vasculature, leading to hypertension. Recurrent thromboemboli, Group 4. Recurrent pulmonary emboli may cause pulmonary hypertension by reducing the functional cross-sectional area of the pulmonary vascular bed, which in turn leads to an increase in pulmonary vascular resistance. Autoimmune diseases, Group 1. Several of these diseases, most notably systemic sclerosis, involve the pulmonary vasculature and / or the interstitium, leading to increased vascular resistance and pulmonary hypertension. 702. Vascular origin, 703. Obstructive sleep apnea, Group 3, is a common disorder that is associated with obesity and hypoxemia. It is now recognized to be a significant contributor to the development of pulmonary hypertension and cor pulmonale. Commonly, pulmonary hypertension is encountered in patients in whom all known causes are excluded. This is referred to as idiopathic pulmonary arterial hypertension and also falls into Group 1 disease. However, Idiopathic is a bit of a misnomer, as up to 80% of idiopathic cases, sometimes referred to as primary pulmonary hypertension, have a genetic basis, sometimes being inherited in families as an autosomal dominant trait. Within these families, there is incomplete penetrance, and only 10% to 20% of the family members actually develop overt disease. As is often the case, much has been learned about the pathogenesis of pulmonary hypertension by investigating the molecular basis of the uncommon familial form of the disease. The first mutation to be discovered in familial pulmonary arterial hypertension was in the gene encoding bone morphogenetic protein receptor type 2 BMP-ARPO. Activating germline mutations in the BMP-ARPO gene are found in 75% of the familial cases of pulmonary hypertension and 25% of sporadic cases. Subsequently, other mutations have been discovered that also converge on the BMP-ARPO pathway and affect intracellular signaling. It has also been demonstrated that BMP-ARPO is downregulated in lungs from some patients with idiopathic pulmonary arterial hypertension without BMP-ARPO mutations. BMP-ARPO is a cell surface protein belonging to the TGF-beta receptor superfamily, which binds a variety of cytokines, including TGF-beta, bone morphogenetic protein BMP, activin, and inhibin. Originally described as a pathway that regulates bone growth, BMP-ARPO signaling is now known to be important for embryogenesis, apoptosis, and cell proliferation and differentiation. Details remain to be worked out, but it appears that haploinsufficiency for BMP-ARPO leads to dysfunction and proliferation of endothelial cells and vascular smooth muscle cells. Because only 10% to 20% of individuals with BMP-ARPO mutations develop disease, it is likely that modified genes and/or environmental triggers also contribute to the pathogenesis of the disorder. A two-hit model has been proposed whereby a genetically susceptible individual with a BMP-ARPO mutation requires additional genetic or environmental insults to develop the disease fate. 15.29. Morphology. All forms of pulmonary hypertension are associated with medial hypertrophy of the pulmonary muscular and elastic arteries and right ventricular hypertrophy. The presence of many organizing or recanalyzed thrombi favors recurrent pulmonary embolia as the cause, and the coexistence of diffuse pulmonary fibrosis or severe emphysema and chronic bronchitis. Points to chronic hypoxia and loss of capillary beds as initiating events. The vessel changes can involve the entire arterial tree, from the main pulmonary arteries down to the arterioles fade. 15.30. In the most severe cases, the thickening of the walls of the pulmonary artery and its major branches take on some features of systemic atherosclerosis, with classic atherosclerotic changes are not seen. Instead, the arterioles and small arteries 42, 233, modified genes, BMP-ARPO locus, mutations, pulmonary vascular thickening and occlusion, primary pulmonary hypertension. Figure 15.29 Pathogenesis of primary idiopathic pulmonary hypertension. See text for details. 300 mm in diameter are prominently affected by striking medial hypertrophy and intimal fibrosis, sometimes narrowing the lumens. Pinpoint channels. One extreme in the spectrum of pathology. Changes is the plexiform lesion, so called because a tuft of capillary formations is present, producing a network, or web, that spans. Lumens of dilated thin wall, small arteries and may extend outside the vessel. Plexiform lesions are most prominent in idiopathic and familial pulmonary hypertension group 1, unrepaired. General heart disease with left to right shunts group 2, and pulmonary hypertension associated with human immunodeficiency. Virus, HIV infection, and drugs also group 1 diseases. Clinical features. Idiopathic, often inherited forms of pulmonary hypertension are most common in women who are 20 to 40 years of age, but may occasionally present in childhood. Clinical signs and symptoms in all types become evident only in advanced disease. In cases of idiopathic disease, the presenting features are usually dyspnea and fatigue, but some patients have chest pain of the anginal type. Over time, severe respiratory distress, cyanosis, and right ventricular hypertrophy occur, and death from decompensated cor pulmonale, often with superimposed thromboembolism and pneumonia, ensues within 2 to 5 years in 80% of patients. Treatment choices depend on the underlying cause. For patients with secondary disease, therapy is directed at the trigger, for example, thromboembolic disease or hypoxemia. A variety of vasodilators have been used with varying success in those with group 1 or refractory disease belonging to other groups. Lung transplantation provides definitive treatment for selected patients. Diffuse pulmonary hemorrhage syndromes. Pulmonary hemorrhage is a dramatic complication of some interstitial lung disorders. Pulmonary hemorrhage syndromes. Environmental triggers. 704 Chapter 15 The lung, AB, has been reported in adults as well. It usually presents with an insidious onset of productive cough, hemoptysis, and anemia associated with diffuse pulmonary infiltrates. The cause and pathogenesis are unknown, and anti-basement membrane antibodies, the cause of Goodpasture syndrome, are undetectable. However, favorable response to long-term immunosuppression with prednisone and or azathioprine indicates that an immunologic mechanism may be involved in the pulmonary capillary damage underlying alveolar bleeding. In addition, long-term follow-up shows that some affected patients develop other immune disorders. Goodpasture syndrome, anti-glomerular basement membrane antibody disease with pulmonary involvement. Goodpasture syndrome is an uncommon autoimmune disease in which kidney and lung injury are caused by circulating autoantibodies against the non-collagenous domain of the alpha-3 chain of collagen Roman 4. When only renal disease is caused by this antibody, it is called anti-glomerular basement membrane disease. The term Goodpasture syndrome applies to the 40% to 60% of patients who develop pulmonary hemorrhage in addition to renal disease. Although any age can be affected, most cases occur in the teens or 20 and in contrast to many other autoimmune diseases, there is a male preponderance. The majority of patients are active smokers. Pathogenesis, the immunopathogenesis of the syndrome, and the nature of the Goodpasture antigens are described in Chapter 20. Pathogenic antibodies initiate inflammatory destruction of the basement membrane and renal glomeruli and pulmonary alveoli, giving rise to rapidly progressive glomerulonephritis and a necrotizing hemorrhagic interstitial pneumonitis. The trigger that initiates the production of anti-basement. See Figure 15.30. Vascular changes in pulmonary arterial hypertension. Atheroma-like changes, a finding usually limited to large vessels. Marked medial hypertrophy. See plexiform lesion of small arteries that is characteristic of advanced pulmonary hypertension. Fig. 15.31. Include 1 Goodpasture syndrome, 2 idiopathic pulmonary hemosiderosis, and 3 vasculitis-associated hemorrhage. The latter encompasses conditions such as hypersensitivity angiitis, polyangiitis with granulomatosis, and systemic lupus erythematosus. Chapter 11. Idiopathic pulmonary hemosiderosis. Idiopathic pulmonary hemosiderosis is a rare disorder characterized by intermittent, diffuse alveolar hemorrhage. Most cases occur in young children, although the disease. Figure 15.31. Diffuse pulmonary hemorrhage syndrome. There is acute intra-alveolar hemorrhage in hemosiderin-laden macrophages, reflecting previous hemorrhage Prussian blue iron stain. Infection 705. Membrane antibodies is unknown. In addition to autoreactive B cells, some experimental evidence suggests that T cells also contribute, both by enhancing B cell function and by participating directly in glomerular damage and crescent formation. As with other autoimmune disorders, there is an association with certain HLA subtypes. For example, HLA-DR-151 and HLA-DR-152. Pulmonary morphology. In the classic case, the lungs are heavy, with areas of red-brown consolidation. Histologically, there is focal necrosis of alveolar walls associated with intra-alveolar hemorrhages. Often the alveoli contain hemosiderin-laden macrophages. See Fig. 15.31. In later stages there may be fibrous thickening of the septum, hyperplasia of type Roman 2 pneumocytes, and organization of blood in alveolar spaces. In many cases, immunofluorescence studies reveal linear deposits of immunoglobulins along the basement membranes of the septal walls. The kidneys have the characteristic findings of focal proliferative glomerulonephritis in early cases or crescentic glomerulonephritis in patients with rapidly progressive glomerulonephritis. Diagnostic linear deposits of immunoglobulins and complement are seen by immunofluorescence studies along the glomerular basement membranes, even in a few patients without renal disease. Clinical features: most cases begin with respiratory symptoms, principally hemoptysis, and radiographic evidence of focal pulmonary consolidations. Soon, manifestations of glomerulonephritis appear, leading to rapidly progressive renal failure. The most common cause of death is uremia. The once dismal prognosis for this disease has been markedly improved by intensive plasmapheresis. This procedure is thought to be beneficial by removing basement membrane antibodies and possibly other mediators of immunologic injury. Simultaneous immunosuppressive therapy inhibits further antibody production, ameliorating both lung hemorrhage and glomerulonephritis. Polyangiitis with granulomatosis, previously called Wegener granulomatosis. This autoimmune disease most often involves the upper respiratory tract and or the lungs, with hemoptysis being the common presenting symptom. Its features are discussed in Chapter 11. Here, it suffices to emphasize that a transbronchial lung biopsy might provide the only tissue available for diagnosis. Since the amount of tissue is small, necrosis and granulomatous vasculitis might not be present. Rather, the diagnostically important histologic features are capillaritis and scattered, poorly formed granulomas unlike those of sarcoidosis, which are rounded and well-defined. Pulmonary infections. Respiratory tract infections are more frequent than infections of any other organ and account for the largest number of workdays lost in the general population. The vast majority consist of upper respiratory tract infections caused by viruses, common cold, pharyngitis, the bacterial, viral, mycoplasmal, and fungal infections of the lung. Pneumonia account for an enormous amount of morbidity and are responsible for 2–3% of all deaths in the United States. Pneumonia can be very broadly defined as any infection of the lung parenchyma. Pulmonary antimicrobial defense mechanisms are described in Chapter 8. Pneumonia can result whenever these local defense mechanisms are impaired or the systemic resistance of the host is lower. Factors that impair resistance include chronic diseases, immunologic deficiencies, treatment with immunosuppressive agents, and leukopenia. Local pulmonary defense mechanisms may also be compromised by many factors, including loss or suppression of the cough reflex as a result of altered sensorium, for example, coma, anesthesia, neuromuscular disorders, drugs, or chest pain, any of which may lead to aspiration of gastric contents. Dysfunction of the mucociliary apparatus, which can be caused by cigarette smoke, inhalation of hot or corrosive gases, viral diseases, or genetic defects of ciliary function, for example, hematoileus syndrome. Accumulation of secretions in conditions such as cystic fibrosis and bronchial obstruction. Interference with the phagocytic and bactericidal activities of alveolar macrophages by alcohol, tobacco smoke, anoxia, or oxygen intoxication. Pulmonary congestion and edema. Defects in innate immunity, including neutrophil and complement defects and humoral immunodeficiency, typically lead to an increased incidence of infections with pyogenic bacteria. Germline mutations in MyData8, an adapter for several toll-like receptors TLRs that is important for activation of the transcription factor nuclear factor kappa B, NF kappa B, are also associated with destructive bacterial pneumococcal pneumonias. On the other hand, some immediate immune defects, congenital and acquired, lead to increased infections with intracellular microbes such as mycobacteria and herpes viruses, as well as with microorganisms of very low virulence, such as the fungus Pneumocystis gyrosa. Several other points should be emphasized. First, to paraphrase the French physician Louis Cuvelier in 1919 during the Spanish flu epidemic, flu condemns, an additional infection executes. The most common cause of death in viral influenza epidemics is superimposed bacterial pneumonia. Second, although the portal of entry for most bacterial pneumonias is the respiratory tract, hematogenous seeding of the lungs from another organ may occur and may be difficult to distinguish from primary pneumonia. Finally, Many patients with chronic diseases acquire terminal pneumonia while hospitalized nosocomial infection because of several factors. Bacteria common to the hospital environment may have acquired resistance to antibiotics. Opportunities for spread are increased. Invasive procedures, such as intubations and injections, are common, and bacteria may contaminate equipment used in respiratory care units. Pneumonia is classified based on the etiologic agent or, if no pathogen can be isolated, which occurs in about 50% of cases, by the clinical setting in which the infection occurs. 706 Chapter 15 The Lung 15 Syndrome 7 Community-acquired acute pneumonia. Streptococcus pneumonia, Haemophilus influenzae, Moraxella catarrhalis, Staphylococcus aureus, Legionella pneumophila, Enterobacteriaceae, Klebsiella pneumonia, and Pseudomonas spp. Mycoplasma pneumonia, Chlamydia spp. C. Pneumonia. C. Syncytial. C. Trachomatis, Coxiella burnetii, Q fever viruses, respiratory syncytial virus, parainfluenza virus, and human papillomavirus, children, influenza, and B adults, adenovirus, military recruits, healthcare, associated pneumonia, Staphylococcus aureus, methicillin-sensitive Staphylococcus aureus, methicillin-resistant Pseudomonas aeruginosa, Streptococcus pneumonia. Hospital-acquired pneumonia, gram-negative RAS, Enterobacteriaceae, Klebsiella spp. Serratia marcescens, Escherichia coli, and Pseudomonas spp. Staphylococcus aureus, usually methicillin-resistant. Aspiration pneumonia, anaerobic oral flora bacteroides, Prevotella, Fusobacterium, Peptostreptococcus, and mixed with aerobic bacteria Streptococcus, pneumonia, Staphylococcus aureus, Haemophilus influenzae. Pseudomonas aeruginosa, chronic pneumonia, Nocardia actinomyces granulomatis, Mycobacterium tuberculosis, and atypical Mycobacteria, Histoplasma capsulatum, Coccidioides, Blastomyces dermatitis. Necrotizing pneumonia and lung abscess, anaerobic bacteria extremely common, although without mixed, aerobic infection, Staphylococcus aureus, Klebsiella pneumonia, Streptococcus pyogenes. Type 3 pneumococcus uncommon, pneumonia in the immunocompromised host. Cytomegalovirus, Pneumocystis gyrosa, Mycobacterium avium, intracellular complex, invasive aspergillosis, invasive candidiasis, usual bacterial, viral, and fungal organisms listed herein. T. Pneumonia. The latter considerably narrows the list of suspected pathogens, providing a guide for empirical antimicrobial therapy. As Table 15.7 indicates, pneumonia can arise in 7 distinct clinical settings, pneumonia syndromes, and the implicated pathogens are fairly specific to each category. Community-acquired bacterial pneumonias. Community-acquired acute pneumonia refers to lung infection in otherwise healthy individuals that is acquired from the normal environment in contrast to hospital-acquired pneumonia. It may be bacterial or viral. Clinical and radiologic features are usually insensitive in differentiating between viral and bacterial infections. One marker of inflammation, procalcitonin, an acute phase reactant produced primarily in the liver, is more significantly elevated in bacterial than viral infections and has some predictive value, but is not specific, as it is also markedly elevated in other severe inflammatory disorders, such as systemic inflammatory response syndrome, SIRS Chapter 4. Often, a bacterial infection follows an upper respiratory tract viral infection. Bacterial invasion of the lung parenchyma causes the alveoli to be filled with an inflammatory exudate, thus causing consolidation, solidification of the pulmonary tissue. Many variables, such as the specific etiologic agent, the host reaction, and the extent of involvement, determine the precise form of pneumonia. Predisposing conditions include extremes of age, chronic diseases, congestive heart failure, COP, and diabetes, congenital or acquired immune deficiencies, and decreased or absent splenic function. The latter puts the patient at risk for infection with encapsulated bacteria such as pneumococcus. Streptococcus pneumoniae, or pneumococcus, is the most common cause of community-acquired acute pneumonia. Examination of gram-stained sputum is an important step in the diagnosis of acute pneumonia. The presence of numerous neutrophils containing the typical gram-positive, lancet-shaped diplococci supports the diagnosis of pneumococcal pneumonia, But it must be remembered that as pneumonia is a part of the endogenous flora in 20% of adults, and therefore false positive results may be obtained. Isolation of pneumococci from blood cultures is more specific but less sensitive in the early phase of illness. Only 20% to 30% of patients have positive blood cultures. Pneumococcal vaccines containing capsular polysaccharides from the common serotypes are used in individuals at high risk for pneumococcal sepsis. Haemophilus influenzae. Haemophilus influenzae is a plymorphic, gram-negative organism that occurs in encapsulated and non-encapsulated forms. There are 6 serotypes of the encapsulated form, types A to F, of which type B is the most virulent. Antibodies against the capsule protect the host from H. influenza infection. Hence, the capsular polysaccharide B is incorporated in the widely used vaccine against H. influenza. With routine use of H. influenza vaccines, the incidence of disease caused by the B serotype has declined significantly. By contrast, infections with non-encapsulated forms, also called non-typable forms, are increasing. These are less virulent and tend to spread along the surface of the upper respiratory tract, producing otitis media infection of the middle ear, sinusitis, and bronchopneumonia. Neonates and children with comorbidities such as prematurity, malignancy, and immunodeficiency are at high risk for development of invasive infection. H. influenza pneumonia, which may follow a viral respiratory infection, is a pediatric emergency and has a high mortality rate. Ascending laryngotracheal bronchitis results in airway obstruction as the smaller bronchi are plugged by dense, fibrin-rich exudates containing neutrophils, similar to that seen in pneumococcal pneumonias. Pulmonary consolidation is usually lobular and patchy but may be confluent and involve the entire lung lobe. Before a vaccine became widely available, H. influenza was a common cause of suppurative meningitis in children up to pulmonary infections 707, 5 years of age. H. influenza also causes an acute, purulent conjunctivitis pink eye in children and, in predisposed older patients, may cause septicemia, endocarditis, pyelonephritis, cholecystitis, and suppurative arthritis. Finally, H. influenza is the most common bacterial cause of acute exacerbations of cough. Moraxella catarrhalis is recognized as a cause of bacterial pneumonia, especially in the elderly. It is the second most common bacterial cause of acute exacerbation of cough, along with S. pneumonia and H. influenza. Catarrhalis is one of the 3 most common causes of otitis media in children. Staphylococcus aureus. Staphylococcus aureus is an important cause of secondary bacterial pneumonia in children and healthy adults following viral respiratory illnesses, for example, measles in children and influenza in both children and adults. Staphylococcal pneumonia is associated with a high incidence of complications, such as lung abscess and emphysema. Intravenous drug users are at high risk for development of staphylococcal pneumonia in association with endocarditis. It is also an important cause of hospital-acquired pneumonia. Klebsiella pneumonia. Klebsiella pneumonia is the most frequent cause of gram-negative bacterial pneumonia. It commonly afflicts debilitated and malnourished people, particularly chronic alcoholics. Thick, mucoid, often blood-tinged sputum is characteristic because the organism produces an abundant viscid capsular polysaccharide, which the patient may have difficulty expectorating. Pseudomonas aeruginosa. Although Pseudomonas aeruginosa most commonly causes hospital-acquired infections, it is mentioned here because of its occurrence in cystic fibrosis and immunocompromised patients. It is common in patients who are neutropenic, and it has a propensity to invade blood vessels with consequent extrapulmonary spread. Pseudomonas septicemia is a very fulminant disease. Legionella pneumophila. Legionella pneumophila is the agent of Legionnaire's disease, a form of pneumonia caused by this organism. It also causes Pontiac fever, a related self-limited upper respiratory tract infection. This organism flourishes in artificial aquatic environments, such as water cooling towers and the tubing systems of domestic potable water supplies. It is transmitted by either inhalation of aerosolized organisms or aspiration of contaminated drinking water. Legionella pneumonia is common in individuals with predisposing conditions such as cardiac, renal, immunologic, or hematologic disease. Organ transplant recipients are particularly susceptible. It can be quite severe, frequently requiring hospitalization, and immune-suppressed patients have fatality rates of up to 50%. The diagnosis can be made rapidly by detecting Legionella DNA in sputum using a polymerase chain reaction PCR-based test or by identification of Legionella antigens in the urine. Culture remains the diagnostic gold standard, but takes 3 to 5 days. Bronchopneumonia Figure 15.32 Comparison of bronchopneumonia and lobar pneumonia. Mycoplasma pneumonia. Mycoplasma infections are particularly common among children and young adults. They occur sporadically or as local epidemics in closed community schools, military camps, and prisons. Morphology. Bacterial pneumonia has 2 patterns of anatomic distribution: lobular bronchopneumonia and lobar pneumonia. Fig. 15.32. Patchy consolidation of the lung is the dominant characteristic of bronchopneumonia. Fig. 15.33. While consolidation of a large portion of a lobe or of an entire lobe defines lobar. Figure 15.33 Bronchopneumonia. Section of lung showing patches of consolidation arrows. Lobar pneumonia. 708 Chapter 15 The lung. Granular, gray red to yellow, and poorly delimited at their margins. See Fig. 15.33. Histologically, the reaction usually elicits a neutrophil-rich exudate that fills the bronchi, bronchioles, and adjacent alveolar spaces. See Fig. 15.35a. Complications of pneumonia include 1. Tissue destruction and necrosis, causing abscess formation particularly common with pneumococcal or Klebsiella infections. 2. Spread of infection. Figure 15.34 Lobar pneumonia. Gray hepatization. The lower lobe is uniformly consolidated. 8. Pneumonia. Fig. 15.34. These anatomic categorizations may be difficult to apply in individual cases because patterns overlap. Patchy involvement may become confluent, producing lobar consolidation. Moreover, the same organisms may produce either pattern depending on patient susceptibility. Most important from the clinical standpoint are identification of the causative agent and determination of the extent of disease. In lobar pneumonia, 4 stages of the inflammatory response have classically been described: congestion, red hepatization, gray hepatization, and resolution. In the first stage of congestion, the lung is heavy, boggy, and red. It is characterized by vascular engorgement, intra-alveolar edema fluid containing a few neutrophils, and the presence of bacteria, which may be numerous. In the next stage of red hepatization, there is massive confluent exudation, as neutrophils, red cells, and fibrin fill the alveolar spaces. Fig. 15.35a. On gross examination, the lobe is red, firm, and airless, with a liver-like consistency, hence the name hepatization. The third stage of gray hepatization is marked by progressive disintegration of red cells and the persistence of a fibrin-aspirative exudate. Fig. 15.35b, resulting in a color change to grayish-brown. In the final stage of resolution, the exudate within the alveolar spaces is broken down by enzymatic digestion to produce granular, semifluid debris that is resorbed, ingested by macrophages, expectorated, or organized by fibroblasts growing into a Fig. 15.35c. Pleural fibrinous reaction to the underlying inflammation, often present in the early stages if the consolidation extends to the lung surface. Pleuritis may similarly resolve. More often it undergoes organization, leaving fibrous thickening or permanent adhesions. Foci of bronchopneumonia are consolidated areas of acute suppurative inflammation. The consolidation may be confined to one lobe but is more often multilobar and frequently bilateral and basal because of the tendency of secretions to gravitate to the lower lobes. Blood-developed lesions are slightly elevated, dry. See Figure 15.35 Stages of bacterial pneumonia. Acute pneumonia. The congested septal capillaries and numerous intra-alveolar neutrophils are characteristic of early red hepatization. Fibrin nests have not yet formed. The early organization of intra-alveolar exudate, seen focally to be streaming through the pores of cone arrow. See advanced organizing pneumonia. Exudates have been converted to fibromyxoid masses rich in macrophages and fibroblasts. Infections 709 to the pleural cavity, causing an intrapleural fibrinocyturative reaction known as impairment, and 3 bacteremic dissemination to the heart valves, pericardium, brain, kidneys, spleen, joints, causing abscesses, endocarditis, meningitis, or suppurative, arthritis, pulmonary. Clinical features. The major symptoms of community-acquired acute bacterial pneumonia are abrupt onset of high fever, shaking chills, and cough-producing mucopurulent sputum and occasionally hemoptysis. When pleuritis is present, it is accompanied by pleuritic pain and pleural friction rub. The whole lobe is radiopaque in lobar pneumonia, whereas there are focal opacities in bronchopneumonia. The clinical picture is markedly modified by the administration of effective antibiotics. Appropriately treated patients may become febrile with few clinical signs 48 to 72 hours after the initiation of antibiotics. Identification of the organism and the determination of its antibiotic sensitivity are the keystones of therapy. Fewer than 10% of patients with pneumonia severe enough to merit hospitalization now succumb, and in most instances death results from a complication, such as impairment, meningitis, endocarditis, or pericarditis, or is attributable to some predisposing influence, such as debility or chronic alcoholism. Community-acquired viral pneumonia. Common viral infections include influenza virus types of MB, respiratory syncytial viruses, human pneumovirus, adenovirus, rhinoviruses, rubiola, and varicella viruses. Any of these agents can cause a relatively mild upper respiratory tract infection, recognized as the common cold, or a more severe lower respiratory tract infection. Factors that favor extension of the infection to the lung include extremes of age, malnutrition, alcoholism, and underlying debilitating illnesses. Although the molecular details vary, all of the viruses that cause pneumonia produce disease through similar general mechanisms. These viruses have tropisms that allow them to attach to and enter respiratory lining cells. Viral replication and gene expression leads to cytopathic changes, inducing cell death and secondary inflammation. The resulting damage and impairment of local pulmonary defenses, such as mucociliary clearance, may predispose to bacterial superinfections, which are often more serious than the viral infection itself. Influenza viruses of type infect humans, pigs, horses, and birds, and are the major cause of pandemic and epidemic influenza infections. The influenza genome encodes several proteins, but the most important from the vantage point of viral virulence are the hemagglutinin and neuraminidase proteins. Hemagglutinin has 3 major subtypes HOME, H-O, H3, while neuraminidase has 2 none, N12. Both proteins are embedded in a lipid bilayer, which constitutes the influenza virus envelope. Hemagglutinin is particularly important, as it serves to attach the virus to its cellular target via sialic acid residues on surface polysaccharides, following uptake of the virus into endosomal vesicles, acidification. The endosome triggers a conformation change in hemagglutinin that allows the viral envelope to fuse with the whole cell membrane, releasing the viral genomic RNAs into the cytoplasm of the cell. Neuraminidase in turn facilitates the release of newly formed virions that are budding from infected cells by cleaving sialic acid residues. Neutralizing host antibodies against viral hemagglutinin and neuraminidase prevent and ameliorate, respectively, infection with influenza virus. The viral genome is composed of 8 single-stranded RNAs, each encoding 1 or more proteins. The RNAs are packaged in the helices by nucleoproteins that determine the influenza virus type A, B, or C. Single subtype of influenza virus that predominates throughout the world at a given time. Epidemics of influenza are caused by spontaneous mutations that alter antigenic epitopes on the viral hemagglutinin and neuraminidase proteins. These antigenic changes, antigenic drift, result in new viral strains that are sufficiently different to elude, at least in part, anti-influenza antibodies produced in members of the population in response to prior exposures to other flu strains. Usually, however, these new strains bear sufficient resemblance to prior strains that some members of the population are at least partially resistant to infection. By contrast, pandemics, which are longer and more widespread than epidemics, occur when both the hemagglutinin and the neuraminidase genes are replaced through recombination with animal influenza virus's antigenic shift. In this instance, essentially all individuals are susceptible to the new influenza virus. If the host lacks protective antibodies, the virus infects pneumocytes and elicits several cytopathic changes. Shortly after entry into pneumocytes, the viral infection inhibits sodium channels, producing electrolyte and water shifts that lead to fluid accumulation in the alveolar lumen. This is followed by the death of the infected cells through several mechanisms, including inhibition of host cell messenger RNA translation and activation of caspases leading to apoptosis. The death of epithelial cells exacerbates the fluid accumulation and releases dangerous signals that activate resident macrophages. In addition, prior to their death, infected epithelial cells release a variety of inflammatory mediators, including several chemokines and cytokines, adding fuel to the inflammatory fire. In addition, mediators released from epithelial cells and macrophages activate the nearby pulmonary endothelium and serve as chemoattractants for neutrophils, which migrate into the interstitium within the first day or two of infection. In some cases, viral infection may cause sufficient lung injury to produce RS, but more often severe pulmonary disease stems from a superimposed bacterial pneumonia. These secondary pneumonias caused by S. aureus are particularly common and often life-threatening. Control of the infection relies on several host mechanisms. The presence of viral products induces innate immune responses in infected cells, such as the production of alpha and beta interferon. These mediators upregulate the expression of the M-zone gene, which encodes a guanosine triphosphatase that interferes with viral gene transcription and viral replication. As with other viral infections, natural killer cells and cytotoxic T cells can recognize and kill infected host cells, limiting viral replication and viral spread to adjacent pneumocytes. Cellular immune response is eventually 710 chapter 15 the lung, augmented by development of antibody responses to the viral hemagglutinin and neuraminidase proteins. Insight into future pandemics has come from studying past pandemics. DNA analysis of viral genomes retrieved from the lungs of a soldier who died in the Great 1918 influenza pandemic that killed between 20 million and 40 million people worldwide identifies swine influenza sequences, consistent with this virus having its origin in a antigenic shift. The first flu pandemic of this century, in 2009, was also caused by an antigenic shift involving a virus of swine origin. It caused particularly severe infections in young adults, apparently because older adults had antibodies against past influenza strains that conveyed at least partial protection. Comorbidities such as diabetes, heart disease, lung disease, and immunosuppression were also associated with a higher risk of severe infection. What then might be the source of the next great pandemic? There is no certainty, but one concern is centered on avian influenza, which normally infects birds. One such strain, type H5N1, has spread throughout the world in wild and domestic birds. Fortunately, the transmission of the current H5N1 avian virus is inefficient. However, if H5N1 influenza recombines with an influenza that is highly infectious for humans, the strain might result that is capable of sustained human-to-human transmission and thus of causing the next great pandemic. Human metapneumovirus, a paramyx virus discovered in 2001, is found worldwide and is associated with upper and lower respiratory tract infections. Infections can occur in any age group but are most common in young children, elderly adults, and immunocompromised patients. Some infections, such as bronchiolitis and pneumonia, are severe. Overall, metapneumovirus is responsible for 5% to 10% of hospitalizations and 12% to 20% of outpatient visits of children suffering from acute respiratory tract infections. Such infections are clinically indistinguishable from those caused by human respiratory syncytial virus and are often mistaken for influenza. The first human metapneumovirus infection occurs during early childhood, but reinfections are common throughout life, especially in older subjects. Diagnostic methods include PCR tests for viral RNA. Treatment generally focuses on supportive measures. Although work is ongoing, a clinically effective and safe vaccine has yet to be developed. Human coronaviruses are enveloped, positive sense RNA viruses that infect humans and several other vertebrate species. Weakly pathogenic coronaviruses cause mild cold-like upper respiratory tract infections, while highly pathogenic ones may cause severe, often fatal pneumonia. An example of a highly pathogenic type is SARS-CoV-2, a strain that emerged in late 2019 in China that is producing a still evolving pandemic as of early 2020 discussed in Chapter 8. Highly pathogenic coronaviruses like SARS-CoV-2 bind the ACE2 protein on the surface of pulmonary alveolar epithelial cells, explaining the tropism of these viruses for the lung. With highly pathogenic forms and susceptible hosts, typically older individuals with comorbid conditions, the host immune response and locally released cytokines often produce acute lung injury and ARS. Morphology: all viral infections produce similar morphologic changes. Upper respiratory infections are marked by mucosal hyperemia and swelling, infiltration of the submucosa by mononuclear cells, mainly lymphocytes and monocytes, and overproduction of mucus secretions. Swollen mucosa and viscous exudate may plug the nasal channels, sinuses, or the eustachian tubes, leading to suppurative secondary bacterial infection, virus-induced. Tonsillitis causing hyperplasia of the lymphoid tissue within the wall-layer ring is frequent in children, and viral laryngotracheal bronchitis and bronchiolitis there. Vocal cord swelling and abundant mucus production, impairment of bronchociliary function and vice bacterial superinfection with more marked suppuration. Plugging of small airways may give rise to focal lung atelectasis with more severe broncholar involvement, widespread plugging of secondary and terminal airways by cell. Fibrin, an inflammatory exudate may, if prolonged, lead to organization and fibrosis, resulting in obliterative bronchiolitis and permanent lung damage. Lung involvement may be quite patchy or may involve whole lobes bilaterally or unilaterally. The affected areas are red, blue, and congested. Pleuritis or pleural effusions are infrequent. The histologic pattern depends on the severity of the disease. Predominant is an interstitial inflammatory reaction involving the walls of the alveoli. The alveolar septa are widened in edematous and usually contain a mononuclear inflammatory infiltrate of lymphocytes, macrophages, and occasionally plasma cells. In severe cases, neutrophils may also be present. The alveoli may be free of exudate, but in many patients there is intra-alveolar proteinaceous material in a cellular exudate. Uncomplicated by ARS, pink hyaline membranes line the alveolar wall. See Fig. 15.4. Eradication of the infection is followed by reconstitution of the normal lung architecture. Superimposed bacterial infection modifies this picture by causing ulcerative bronchitis, bronchiolitis, and bacterial pneumonia. Some viruses, such as herpes simplex, varicella, and adenovirus, may be associated with necrosis of bronchial and alveolar epithelium and acute inflammation. Characteristic viral cytopathic changes are described in Chapter 8. Clinical features: the clinical course of viral pneumonia is extremely varied. Many cases masquerade as severe upper respiratory tract infections or as chest colds. Even individuals with well-developed atypical pneumonia have few localizing symptoms. Cough may be absent, and the major manifestations may consist only of fever, headache, and myalgia. Edema and exudation often cause ventilation-perfusion mismatch, leading to hypoxemia and thus evoke symptoms out of proportion to the scant physical findings. Viral pneumonias are usually mild and resolve spontaneously without any lasting sequelae. However, interstitial viral pneumonias may assume epidemic proportions, and in such instances even a low rate of complications can lead to significant morbidity and mortality, as is typically true of influenza epidemics. Healthcare-associated pneumonia. Healthcare-associated pneumonia was recently described as a distinct clinical entity associated with several risk factors. These are hospitalization of at least 2 days within the recent pulmonary infections, 711, past, presentation from a nursing home or long-term care facility, attending a hospital or hemodialysis clinic, and recent intravenous antibiotic therapy, chemotherapy, or won't care. Most common organisms isolated are methicillin-resistant S. aureus and P. aeruginosa. These patients have a higher mortality than those with community-acquired pneumonia. Hospital-acquired pneumonia. Hospital-acquired pneumonias are defined as pulmonary infections acquired in the course of a hospital stay. They are common in patients with severe underlying disease, immunosuppression, prolonged antibiotic therapy, or invasive access devices such as intravascular catheters. Patients on mechanical ventilation are at particularly high risk, superimposed on an underlying disease that caused hospitalization. Hospital-acquired infections are serious and often life-threatening. Gram-positive cocci, mainly S. aureus, and gram-negative rods, Enterobacteriaceae and Pseudomonas species are the most common isolates. The same organisms predominate in ventilator-associated pneumonia, with gram-negative bacilli being somewhat more common in this setting. Key concepts: acute pneumonia. S. Pneumonia. The pneumococcus is the most common cause of community-acquired acute pneumonia. The distribution of inflammation is usually lobar. Lobar pneumonias evolve through 4 stages: congestion, red, hepatization, gray hepatization, and resolution. Other common causes of acute bacterial pneumonias in the community include H. influenzae and M. catarrhalis, both associated with acute exacerbations of colic. S. aureus usually secondary to viral respiratory infections. K. pneumonia observed in patients who are chronic alcoholics. P. aeruginosa seen in persons with cystic fibrosis and in those with neutropenia. And L. pneumophila seen particularly in individuals with comorbid conditions, for example, heart or lung disease and an organ transplant recipients. Important causes of community-acquired viral pneumonia include influenza virus, milk pneumonia virus, and coronavirus COVID-19. The latter a newly emerging pathogen. Bacterial pneumonias are characterized by predominantly intraalveolar neutrophilic inflammation, while viral pneumonia shows interstitial lymphocytic inflammation. Aspiration pneumonia. Aspiration pneumonia occurs in markedly debilitated patients or those who aspirate gastric contents either while unconscious, for example, after a stroke or during repeated vomiting. These patients have abnormal gag and swallowing reflexes that predispose to aspiration. The resulting pneumonia is partly chemical due to the irritating effects of gastric acid and partly bacterial from the oral flora. Typically, more than one organism is recovered on culture, aerobes being more common than anaerobes. This type of pneumonia is often necrotizing, pursues a fulminant clinical course, and is a frequent cause of death. In patients who survive, lung abscess is a common complication. Microaspiration, in contrast, occurs frequently in almost all people, especially those with gastroesophageal reflux disease. It usually results in small, poorly formed non-necrotizing granulomas with multinucleated foreign body giant cell reaction. It is usually inconsequential, but may exacerbate other pre-existing lung diseases such as asthma, interstitial fibrosis, and lung rejection. Lung abscess. The term pulmonary abscess describes a local suppurative process that produces necrosis of lung tissue. Oropharyngeal surgical or dental procedures, pseudobronchial infections, and bronchitis play important roles in their development. Etiology and pathogenesis. Under appropriate circumstances, any bacterial pathogen can produce an abscess. Those that do so most commonly include aerobic and anaerobic streptococci, S. aureus, and a host of gram-negative organisms. Mixed infections often occur because of the important causal role played by inhalation of foreign material. Anaerobic organisms normally found in the oral cavity, including members of the Bacteroides, Fusobacterium, and Peptococcus genera, are the exclusive isolates in about 60% of cases. Causative organisms are introduced by the following mechanisms. Aspiration of infected material, the most frequent cause. Risk factors include suppressed cough reflexes, for example, acute alcohol intoxication, opioid abuse, coma, anesthesia, seizure disorders, severe dysphagia, for example, neurologic deficits, esophageal disease, protracted vomiting, and poor dental hygiene. Aspiration first causes pneumonia, which progresses to tissue necrosis and formation of lung abscess, antecedent primary lung infection. Post-pneumonic abscess formations are usually associated with S. aureus, K. pneumonia, and pneumococcus. Post-transplant or otherwise immune-suppressed individuals are at special risk. Septic embolism. Infected emboli may arise from thrombophlebitis in any portion of the systemic venous circulation or from the vegetations of infected bacterial endocarditis on the right side of the heart and lodge in the lung. Neoplasia. Secondary infection is particularly common in bronchopulmonary segments obstructed by a primary or secondary malignancy post-obstructive pneumonia. Miscellaneous. Traumatic penetrations of the lungs, direct extension of suppurative infections from the esophagus, spine, subphrenic space, or pleural cavity, and hematogenous seeding of the lung by pyogenic organisms all may lead to lung abscess formation. When all these causes are excluded, there are still cases in which no discernible basis for the abscess formation can be identified. These are referred to as primary cryptogenic lung abscesses. Morphology. Abscesses vary in diameter from a few millimeters to large cavities of 5 to 6 cm thick, 15, 36. They may affect any part of the lung and may be single or multiple. Pulmonary abscesses due to aspiration are more common on the right because of the more vertical right main bronchus and are most often single. Abscesses then. 712 Chapter 15 The lung. Figure 15.36 cut surface of lung showing 2 abscesses. Courtesy Dr. M. Cameron Mercer, University of Chicago, Ill. Develop in the course of pneumonia or bronchiectasis are usually multiple, basal, and diffusely scattered. Septic emboli and pyemic abscesses are multiple and may affect any region of the lungs. The cardinal histologic change in all abscesses is curative destruction of the lung parenchyma within them. Central area of cavitation. The abscess cavity may be filled with suppurative debris or, if there is communication with an air passage, may be partially drained to create an air-containing cavity. Superimposed saprophytic infections are prone to develop within the necrotic debris. Continued infection leads to large, poorly demarcated, fetid, green-black, multilocular cavities designated gangrene of the lung. In chronic cases, considerable fibroblastic proliferation produces the fibrous wall. Clinical features. The manifestations of pulmonary abscesses are much like those of bronchiectasis and characteristically include cough, fever, and copious amounts of foul-smelling purulent or sanguineous sputum. Fever, chest pain, and weight loss are common. Clubbing of the fingers and toes may appear. The diagnosis can be only suspected from the clinical findings and must be confirmed radiologically. Whenever an abscess is discovered in older individuals, it is important to rule out an underlying carcinoma, which is present in 10% to 15% of cases. The course of abscesses is variable. With antimicrobial therapy, most resolve, leaving behind a scar. Complications include extension of the infection into the pleural cavity, hemorrhage, the development of brain abscesses or meningitis from septic emboli, and rarely secondary amyloidosis type A. Chronic pneumonia. Chronic pneumonia is most often a localized lesion in the immunocompetent patient, although without regional lymph node involvement. Typically, the inflammatory reaction is granulomatous and is caused by bacteria, for example, Mycobacterium tuberculosis, or fungi, for example, Histoplasma capsulatum. Tuberculosis of the lung and other organs is described in Chapter 8. Chronic pneumonia is caused by fungi are discussed here. Histoplasmosis H. Capsulatum infection is acquired by inhalation of dust particles from soil contaminated with bird or bat droppings that contain small spores microconidia, the infectious form of the fungus. It is endemic along the Ohio and Mississippi rivers and in the Caribbean. It is also found in Mexico, Central and South America, parts of Eastern and Southern Europe, Africa, Eastern Asia, and Australia. Like tuberculosis, H. capsulatum is an intracellular pathogen that is found mainly in phagocytes. The clinical presentations and morphologic lesions of histoplasmosis bear a striking resemblance to those of tuberculosis, including one of self-limited and often latent primary pulmonary involvement, which may result in coin lesions on chest radiography. 2. Chronic, progressive, secondary lung disease, which is localized to the lung apices and causes cough, fever, and night sweats. 3. Spread to extrapulmonary sites, including mediastinum, adrenal glands, liver, or meninges, and 4. Widely disseminated disease in immunocompromised patients. Histoplasmosis can occur in immunocompetent individuals, but as per usual is more severe in those with depressed cell-mediated immunity. The pathogenesis of histoplasmosis is incompletely understood. The portal of entry is virtually always the lung. Macrophages ingest but cannot kill the organism without T-cell help, and this allows the organism to multiply within phagocytomes and disseminate prior to the development of T-cell immunity, which takes 1 to 2 weeks. In individuals with adequate cell-mediated immunity, the infection is controlled by phone helper T cells that recognize fungal antigens and subsequently secrete IFN gamma, which activates macrophages and enables them to kill intracellular yeasts. In addition, histoplasma induces macrophages to secrete TNF, which recruits and stimulates other macrophages to kill histoplasma. Morphology. In the lungs of otherwise healthy adults, histoplasma infections produce granulomas, which usually become necrotic in May, or less to produce areas of consolidation. With spontaneous resolution or effective treatment, these lesions undergo fibrosis, and concentric calcification tree bark appearance fade. 1537A. Histologic differentiation from tuberculosis, sarcoidosis, and coccidioidomycosis requires identification of the 3 to 5 million thin-walled yeast forms, which may persist in tissues for years. In fulminant disseminated histoplasmosis, which occurs in immunosuppressed individuals, granulomas do not form. Instead, there are focal accumulations of mononuclear phagocytes filled. Fungal yeast throughout the body fate. 1537B. The diagnosis of histoplasmosis may be established by serologic tests for antibodies and fungal antigens, culture, or identification of the fungus in tissue biopsies. The majority of cases resolve spontaneously. Progressive disease or disease in immunocompromised patients is treated with antifungal agents. Blastomycosis blastomyces dermatitis is a soil-inhabiting dimorphic fungus. It causes disease in the central and southeastern United States. Infection also occurs in Canada, Mexico, the Middle East, Africa, and India. There are 3 clinical forms: pulmonary infections 713, a B figure 15.37 histoplasmosis, a laminated histoplasmic granuloma of the lung. The histoplasmic capsulatum yeast forms fill phagocytes in the lung of a patient with disseminated histoplasmosis. As it shows high-powered detail of pear-shaped, thin base budding yeast silver stain. Blastomycosis, disseminated blastomycosis, and a rare primary cutaneous form that results from direct inoculation of organisms into the skin. The pneumonia most often resolves spontaneously, but it may persist or progress to a chronic lesion. Morphology. In the normal host, the lung lesions of blastomycosis are suppurative granulomas. Macrophages have a limited ability to ingest and kill B. dermatitis, and the persistence of the yeast cells leads to the recruitment of neutrophils. Tissue. B. dermatitis is a round, 5 to 15 million yeast cell that divides by broad base budding. It has a thick, double-contour cell wall and visible nuclear fate. 15.38. Involvement of the skin and larynx is associated with more epithelial hyperplasia, which may be mistaken for squamous cell carcinoma. Coccidioidomycosis. Almost everyone who inhales the spores of coccidioidomycosis becomes infected and develops a delayed type hypersensitivity reaction to the fungus, but most remain asymptomatic. D. More than 80% of people in endemic areas of the southwestern and western United States and in Mexico have a positive skin test reaction. One reason for the infectivity of C. mitis is that infective arthrochlamydia, when ingested by alveolar macrophages, block fusion of the phagosome and lysosome and so resist intracellular killing. Approximately 10% of infected people develop lung lesions, and less than 1% of people develop disseminated C. mitis infection, which frequently involves the skin and meninges. Certain ethnic groups, for example, Filipinos and African Americans, and the immunosuppressed are at high risk for disseminated disease. Morphology. Within macrophages or giant cells, C. mitis is present as thick-walled, non-budding spherules 20 to 60 mm in diameter, often filled with small endospores. Pyogenic reaction is superimposed when the spherules rupture to release the endospores fate. 1539. Rare progressive C. Midas disease involves the lungs, meninges, skin, bones, adrenals, lymph nodes, spleen, or liver. At all these sites, the inflammatory response may be purely granular mass, pyrogenic, or mixed. B figure 15.38 blastomycosis. Rounded budding yeasts, larger than neutrophils, are present, not the characteristic thick wall and nuclei not seen in other fungi. B silver stain. 714 Chapter 15 The lung. Pulmonary disease and human immunodeficiency virus infection. Figure 15.39 Coccidioidomycosis. Intact and ruptured spherules are seen. Pneumonia and the immunocompromised host the appearance of a pulmonary infiltrate, although without signs of infection, for example, fever, is one of the most common and serious complications in patients whose immune defenses are suppressed by disease. Immunosuppressive therapy for organ or hematopoietic stem cell transplants, chemotherapy for tumors, or irradiation. In addition to the usual pathogens, a wide variety of so-called opportunistic infectious agents, many of which rarely cause infection in normal hosts, can cause pneumonia, and often more than one agent is involved. Mortality from these opportunistic infections is high. Table 15.8 lists some of the opportunistic agents according to their prevalence and whether they cause local or diffuse pulmonary infiltrates. The differential diagnosis of such infiltrates includes drug reactions and involvement of the lung by tumor. The specific infections are discussed in Chapter 8. Of these, the ones that commonly involve the lung can be classified according to the etiologic agent: 1. Bacteria P. aeruginosa, Mycobacterium species, L. pneumophila, and Listeria monocytogenes; 2. Viruses cytomegalovirus, CMV, and herpes virus; and 3. Fungi P. Girosi, Candida species, Aspergillus species, the Phycomycetes, and Cryptococcus neoformans. Causes. Pulmonary disease accounts for 30% to 40% of hospitalizations in HIV-infected individuals. Although the use of potent antiretroviral agents and effective chemoprophylaxis has markedly altered the incidence and outcome of pulmonary disease in HIV-infected persons, the plethora of infectious agents and other pulmonary lesions make diagnosis and treatment a distinct challenge. Some of the individual microbial agents afflicting HIV-infected individuals have already been discussed. This section focuses only on the general principles of HIV-associated pulmonary disease. Despite the emphasis on opportunistic infections, it must be remembered that bacterial lower respiratory tract infections caused by the usual pathogens are among the most serious pulmonary disorders in HIV infection. Implicated organisms include S. pneumoniae, S. aureus, H. influenzae, and gram-negative RAS. Bacterial pneumonias in HIV-infected persons are more common, more severe, and more often associated with bacteremia than in those without HIV infection. Not all pulmonary infiltrates in HIV-infected individuals are infectious in etiology. A host of non-infectious diseases, including Kaposi sarcoma Chapter 6 and 11, non-Hodgkin lymphoma Chapter 13, and lung cancer, occur with increased frequency and must be excluded. CD4 plus T cell count determines the risk of infection with specific organisms. As a rule of thumb, bacterial and tubercular infections are more likely at higher CD4 plus counts 200 cells/mm3. Pneumocystis pneumoniae usually strikes at CD4 plus counts less than 200 cells/mm3, while CMV, fungal, and Mycobacterium avium intracellular complex infections are uncommon until the disease is very advanced. CD4 plus counts less than 50 cells/mm3. Finally, pulmonary disease in HIV-infected persons may result from more than one cause, and even common pathogens may present with atypical manifestations. Therefore, the diagnostic workup of these patients may be more extensive and expensive than would be necessary in an immunocompetent individual. Lung transplantation. PM immunocompromise, diffuse infiltrates, common. Cytomegalovirus pneumocystis girosi drug reaction. Table 1 Yeomanry, host, 8, uncommon. Bacterial pneumonia Aspergillus cryptococcus malignancy. Trap of H. Sesson, focal infiltrates. Gram-negative bacterial infection Staphylococcus aureus Aspergillus candida malignancy. Cryptococcus mucorpneumocystis girosi legionella pneumophila. Indications for transplantation may include almost all non-neoplastic terminal lung diseases, provided that the patient does not have any other serious disease that would preclude lifelong immunosuppressive therapy. Most common indications are end-stage COP, idiopathic pulmonary fibrosis, cystic fibrosis, and idiopathic/familial pulmonary arterial hypertension. Although bilateral lung transplantation offers better survival as compared to single lung, the latter may be performed to benefit two recipients from a single and all too scarce donor. When bilateral chronic infection is present, for example, cystic fibrosis, bronchitis, both lungs of the recipient must be replaced to remove the reservoir of infection. With improving surgical and organ preservation techniques, postoperative complications, for example, anastomotic, 715, dehiscence, vascular thrombosis, primary graft dysfunction are becoming rare. The transplanted lung is subject to two major complications, infection and rejection. Pulmonary infections in lung transplant patients are essentially those of any immunocompromised host, discussed earlier. In the early post-transplant period, the first few weeks, bacterial infections are most common, with ganciclovir prophylaxis and matching of donor-recipient CMV status. CMV pneumonia occurs less frequently and is less severe, although some resistant strains are emerging. Most infections occur in the 3rd to 12th month after transplantation. Geroside pneumonia is rare, since almost all patients receive adequate prophylaxis, usually with trimethoprim sulfamethoxazobacterium. Fungal infections are mostly due to Aspergillus and Candida species, and they may involve the bronchial anastomotic site and slasher of the lung. Acute lung allograft rejection occurs to some degree in all patients despite routine immunosuppression. Most often appears several weeks to months after surgery, but also may present years later or whenever immunosuppression is decreased. Patients present with fever, dyspnea, cough, and radiologic infiltrates. Since these are similar to the picture of infections, diagnosis often relies on transbronchial biopsy. Chronic lung allograft rejection is a significant problem in at least half of all patients by 3 to 5 years post-transplant. It is manifested by cough, dyspnea, and an irreversible decrease in lung function due to pulmonary fibrosis. Morphology. The morphologic features of acute rejection are primarily those of inflammatory infiltrates, lymphocytes, plasma cells, diffuse neutrophils, and eosinophils around small vessels, and the submucosa of airways, or both. A major morphologic correlate of chronic rejection is bronchiolitis obliterans, the partial or complete occlusion of small airways by fibrosis, although without active inflammation. Fig. 15.40. Bronchiolitis obliterans is patchy and therefore difficult to diagnose via transbronchial biopsy. Bronchitis and pulmonary fibrosis may also develop with long-standing chronic rejection. Acute cellular airway rejection, the presumed foreigner of later, fibrous obliteration of these airways is generally responsive to therapy, but the treatment of established bronchiolitis obliterans has been disappointing. Its progress may be slowed or even halted for some time, but it cannot be reversed. Infrequent complications of lung transplantation include Epstein-Barr virus (EBV), associated B-cell lymphoma, which most often arises within the lung allograft. With continuing improvement in surgical, immunosuppressive, and antimicrobial therapies, the outcome of lung transplantation has improved considerably. Overall median survival is 6 years, with younger patients and those undergoing bilateral lung transplantation having better outcomes. Tumors. Figure 15.40. Chronic rejection of lung allograft associated with bronchiolitis obliterans. Adjacent pulmonary artery is normal. Courtesy Dr. Thomas Cross, Department of Pathology, the University of Chicago, Pritzker School of Medicine, Chicago, Ill. Tumors. Of the wide variety of benign and malignant tumors that may arise in the lung, 90% to 95% are carcinomas, about 5% are carcinoid tumors, and 2% to 5% are mesenchymal and other miscellaneous neoplasms. Carcinomas. Lung cancer is currently the most frequently diagnosed major cancer and the most common cause of cancer mortality worldwide. Globally, In 2018, there were an estimated 2.1 million new cases and 1.8 million lung cancer deaths. The number of new cases of lung cancer in 2018 in the United States is expected to number approximately 230,000. Note that in 1950 it was 18,000, accounting for about 14% of cancer diagnoses and taking more than 150,000 lives, which amounts to roughly 28% of all cancer-related deaths. Each year, lung cancer kills more people than colon, breast, and prostate cancer combined. It is generally a disease of older adults, occurring most often between ages 55 and 84 years, with a peak incidence between 65 and 74 years. Only 2% of all cases occur before the age of 40. Because lung cancer is strongly linked to cigarette smoking, changes in smoking habits greatly influence lung cancer incidence and mortality as well as the prevalence of the various histologic types of lung cancer. Since the early 1990s, lung cancer incidence and mortality rates have been decreasing in men due to a decrease in male smoking over the past 35 years. However, the decrease in smoking among women has lagged behind that of men. Since 1987, more women have died each year of lung cancer than of breast cancer, which for more than 40 years had been the leading cause of cancer death in women. Etiology and pathogenesis. Most but not all lung cancers are associated with a well-known carcinogen, cigarette smoke. In addition, there are other genetic and environmental factors. Lung cancers are 760 in Chapter 15 alone, broadly classified into small cell and non-small cell types, with the latter group including adenocarcinoma and squamous cell carcinoma. The driver mutations that cause lung cancer vary among these histologic subtypes, as will be described later. Tobacco smoking. About 80% of lung cancers occur in active smokers or those who stopped recently, and there is a nearly linear correlation between the frequency of lung cancer and pack years of cigarette smoking. Increased risk is 60 times greater in habitual heavy smokers 2 packs a day for 20 years than in non-smokers. However, since lung cancer develops in only 10% to 15% of smokers, there are likely to be other factors that interact with smoking to predispose individuals to this deadly disease. For unclear reasons, it appears that women are more susceptible to carcinogens and tobacco than men. Although cessation of smoking decreases the risk for lung cancer over time, it may never return to baseline levels. In fact, genetic changes that predate lung cancer can persist for many years in the bronchial epithelium of former smokers. Pipe and cigar smokers also incur an elevated risk, albeit only modestly. Chewing tobacco is not a safe substitute for smoking cigarettes or cigars, as these products spare the lung but cause oral cancers and can lead to nicotine addiction. The long-term effects of electronic cigarette aerosols are not known, as vaping is a relatively recent phenomenon in Chapter 9. Unfortunately, the carcinogenic effects of tobacco smoke extend to those who live and work with smokers. Secondhand smoke, or environmental tobacco smoke, contains numerous human carcinogens for which there is no safe level of exposure. It is estimated that each year about 3,000 non-smoking adults die of lung cancer as a result of breathing secondhand smoke. What of heavy smokers who never develop cancer? While some of this may be a matter of chance, the mutagenic effect of carcinogens in smoke is modified by genetic variants. Recall that many chemicals pro-carcinogens are converted into carcinogens via activation by the highly polymorphic P450 monooxygenase enzyme system. Chapter 9. Specific P450 variants have an increased capacity to activate pro-carcinogens in cigarette smoke, and smokers with these variants incur a greater risk of lung cancer. Similarly, individuals whose peripheral blood lymphocytes show more numerous chromosomal breakages after exposure to tobacco-related carcinogens mutagen sensitivity genotype have a greater than 10-fold higher risk of developing lung cancer as compared with controls, presumably because of genetic variation in genes involved in DNA repair. The histologic changes that correlate with steps along the path to neoplastic transformation are best documented for squamous cell carcinoma and are described in more detail later. There is a linear correlation between the intensity of exposure to cigarette smoke and the appearance of ever more worrisome epithelial changes. These begin with rather innocuous appearing basal cell hyperplasia and squamous metaplasia and progress to squamous dysplasia and carcinoma in situ, the last stage before progression to invasive cancer. Industrial hazards. Certain industrial exposures, such as asbestos, arsenic, chromium, uranium, nickel, vinyl chloride, and mustard gas, increase the risk of developing lung cancer. High-dose ionizing radiation is carcinogenic. There was an increased incidence of lung cancer amongst survivors of the Hiroshima and Nagasaki atomic bomb blasts, as well as in workers heavily involved in cleanup after the Chernobyl disaster. Uranium is weakly radioactive. The lung cancer rates among non-smoking uranium miners are 4 times higher than those in the general population, and among smoking miners they are about 10 times higher. Asbestos exposure also increases the risk for lung cancer development. The latent period before the development of lung cancer is 10 to 30 years. Lung cancer is the most frequent malignancy in individuals exposed to asbestos, particularly when coupled with smoking. Asbestos workers who do not smoke have a 5-fold greater risk of developing lung cancer than do non-smoking controlled subjects, whereas those who smoke have a 55-fold greater risk. Air pollution. It is uncertain whether air pollution, by itself, increases the risk of lung cancer, but it likely adds to the risk in those who smoke or are exposed to secondhand smoke. It may do so through several different mechanisms. Chronic exposure to air particulates and smog may cause lung irritation, inflammation, and repair, and you will recall that chronic inflammation and repair increases the risk of a variety of cancers. Chapter 7. Specific form of air pollution that may contribute to an increased risk of lung cancer is radon gas. Radon is a ubiquitous radioactive gas that has been linked epidemiologically to increased lung cancer in uranium miners. Other underground miners and workers in locations below ground, such as subways, tunnels, and basements, are at increased risk for radon exposure. This has generated concern that low-level exposure, for example, in well-insulated homes in areas with naturally high levels of radon in soil may also increase the incidence of lung cancer. Acquired mutations. As with other cancers, Chapter 7, smoking-related carcinomas of the lung arise by a stepwise accumulation of oncogenic driver mutations that result in the neoplastic transformation of pulmonary epithelial cells. Some of the genetic changes associated with cancers can be found in the benign bronchial epithelium of smokers without lung cancers, suggesting that large areas of the respiratory mucosa are mutagenized by exposure to carcinogens and tobacco smoke field effect. On this fertile soil, cells that accumulate just the wrong panoply of complementary driver mutations to acquire all of the hallmarks of cancer develop into carcinomas. Major histologic subtypes of lung cancer each have distinctive molecular features, as follows. Adenocarcinoma is associated with tobacco smoking, but less so than other histologic subtypes. As a result, it is the most common subtype in never smokers described below. About 1/3 of adenocarcinomas have oncogenic gain-of-function mutations involving components of growth factor receptor signaling pathways. These are important to recognize because they often can be targeted with specific inhibitors discussed later. These include gain-of-function mutations in genes encoding several different receptor tyrosine kinases, such as EGFR, in 10% to 15% of tumors in Caucasians and a higher percentage of non-smoking Asian women, ALK, and 3% to 5% of tumors. Tumor 717, Ralston, in 1% of tumors, MET, in 2% to 5% of tumors, and RET, in 1% to 2% of tumors. Other tumors have gain-of-function mutations in serine/threonine kinases BRAF, 2% of tumors, and PI3K, 2% of tumors, or in the CROS gene roughly 30% of tumors, all of which encode signaling molecules that lie downstream of receptor tyrosine kinases and growth factor signaling pathways. Squamous cell carcinoma is highly associated with exposure to tobacco smoke and harbors diverse genetic aberrations, many of which are chromosome deletions involving tumor suppressor loci. These losses, especially those involving 9th site of the CDK-NTOA gene and 17th site of the T53 gene, are early events in tumor evolution, being detected at an appreciable frequency in the histologically normal respiratory mucosal cells of smokers. Most tumors have mutations in T53, the 53 protein overexpression that's seen by immunohistochemical staining. A marker of T53 mutations is an early event, being reported in 10% to 50% of squamous dysplasias and 60% to 90% of squamous cell carcinoma in situ. The CDKN4 tumor suppressor gene, which encodes the cyclin-dependent kinase inhibitor 16, is mutated in 65% of tumors. Many squamous cell carcinomas also have amplification of FGFR, a gene encoding the fibroblast growth factor receptor tyrosine kinase. Small cell carcinoma is virtually always smoking-related and has the highest mutational burden among lung cancers. There is almost universal inactivation of both T53 and RB, and unusual transformations of non-small cell carcinoma to small cell carcinoma are often associated with a position of RB loss of function mutations, emphasizing the importance of RB inactivation in this lung cancer subtype. Loss of chromosome 3 also occurs in nearly all of these tumors and is seen even in histologically normal lung epithelium, suggesting that this also is a critical early event. The subtype is also commonly associated with amplification of genes of the MYC family. Lung cancer in never smokers. The WHO estimates that 25% of lung cancer worldwide occurs in never smokers. This percentage is probably closer to 10% to 15% in Western countries. These cancers occur more commonly in women, and most are adenocarcinomas, often with targetable mutations/co-mutations. Cancers in non-smokers are more likely to have EGFR mutations and almost never have CRAS mutations. T53 mutations are not uncommon, but occur less frequently than in smoking-related cancers. Precursor pre-invasive lesions. 4 types of morphologic precursor epithelial lesions are recognized. 1. Atypical adenomatous hyperplasia. 2. Adenocarcinoma in situ. 3. Squamous dysplasia and carcinoma in situ. And 4. Diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. It should be remembered that the term precursor does not imply that progression to cancer is inevitable. Currently, it is not possible to distinguish between precursor lesions that progress and those that remain localized or regress. Classification. Tumor classification is important for consistency in patient treatment and provides a uniform basis for epidemiologic and biologic studies. Most recent classification of lung, TBR 90. Histologic classification al. Tumors. Tumor classification. Adenocarcinoma. Lipidic. Acinar. Mycopapillary. Papillary. Solid according to predominant pattern. Invasive mucinous adenocarcinoma. Minimally invasive adenocarcinoma non-mucinous. Mucinous. Squamous cell carcinoma. Keratinizing. Non-keratinizing. Basaloid. Neuroendocrine tumors. Small cell carcinoma combined small cell carcinoma large cell neuroendocrine carcinoma combined large cell neuroendocrine carcinoma carcinoid tumor. Typical, atypical, other uncommon types. Large cell carcinoma adenosquamous carcinoma sarcomatic carcinoma. Polymorphic, spindle cell, giant cell carcinoma, carcinosarcoma. Pulmonary blastoma. Others such as lymphoepithelioma-like carcinoma and NUT carcinoma. Salivary gland, type tumors, of malignant epithet. Cancer is given in Table 15.9. Several histologic variants of each type of lung cancer are described. However, their clinical significance is still undetermined except as mentioned herein. The relative proportions of the major categories are adenocarcinoma 50%, squamous cell carcinoma 20%, small cell carcinoma 15%, large cell carcinoma 2%. Other 13%. There may be mixtures of histologic patterns, even in the same cancer. Thus, combinations of squamous cell carcinoma and adenocarcinoma or small cell and squamous cell carcinoma occur in about 14% and 5% of patients, respectively. The incidence of adenocarcinoma has increased significantly in the last 2 decades, and it is now the most common form of lung cancer in women and men. The basis for this change is unclear. One possible factor is the increase in women smokers, but this only highlights our ignorance about why women develop adenocarcinoma more frequently. Another possibility is that changes in cigarettes alter filter tips and decreased tar and nicotine may have caused smokers to inhale more deeply. increasing the exposure of peripheral airways and cells with a predilection to give rise to adenocarcinoma to carcinogens. Morphology. Lung carcinomas may arise in the peripheral lung more often, adenocarcinomas, or in the central/hilar region more often, squamous cell carcinomas, sometimes in association with recognizable precursor lesions. Lung. 718 Chapter 15 The lung. Figure 15.41 Atypical adenomatous hyperplasia. The epithelium is cuboidal, and there is mild interstitial fibrosis. Atypical adenomatous hyperplasia is a small precursor lesion 5 mm characterized by dysplastic pneumocytes lining alveolar walls that are mildly fibrotic. Fig. 15.41. It can be single or multiple and can be in the lung adjacent to invasive tumor or away from it. Adenocarcinoma in situ, formerly called bronchoalveolar carcinoma, is a lesion that is less than 3 cm in size and is composed entirely of dysplastic cells growing along pre-existing alveolar septum. The cells have more dysplasia than atypical adenomatous hyperplasia and may or may not have intracellular mucin. Fig. 15.42. Adenocarcinoma is an invasive malignant epithelial tumor with glandular differentiation or mucin production by the tumor cells. Adenocarcinomas grow in various patterns, including acinar, lipidic, papillary, glycopapillary, and solid. Compared with squamous cell cancers, these lesions are usually more peripherally located and tend to be smaller. They vary histologically from Figure 15.42 adenocarcinoma in situ, mucinous subtype. Characteristic growth along pre-existing alveolar septum is evident, without invasion. Well-differentiated tumors with obvious glandular elements. Fig. 15.43 to papillary lesions resembling other papillary carcinomas, to solid masses with only occasional mucin-producing glands and cells. The majority express thyroid transcription factor 1 TTF1. Fig. 15.43 INSIT, a protein first identified in the thyroid that is required for normal lung development. At the periphery of the tumor there is often a lipidic pattern of spread, in which the tumor cells crawl along normal-appearing alveolar septum. Tumors 3 cm with a small invasive component 5 mm associated with scarring and a peripheral lipidic growth pattern are called microinvasive adenocarcinoma. These have a far better prognosis than invasive carcinomas of the same size. Mucinous adenocarcinomas tend to spread erogenously, forming satellite tumors. Thus, these are less likely to be cured by surgery. They may present as a solitary nodule or as multiple nodules, or an entire lobe may be consolidated by tumor, mimicking lobar pneumonia. Squamous cell carcinoma is more common in men and is strongly associated with smoking. Precursor lesions that give rise to invasive squamous cell carcinoma are well characterized. Squamous cell carcinomas are often antedated by squamous metaplasia or dysplasia in the bronchial epithelium, which then transforms to carcinoma in situ, a phase that may last for years. Fig. 15.44. By this time, atypical cells may be identified in cytologic smears of sputum or in bronchial lavage fluids or brushings. Fig. 15.45. But the lesion is asymptomatic and undetectable on radiographs. Eventually, an invasive squamous cell carcinoma appears. The tumor may then follow a variety of paths. It may grow exophytically into the bronchial lumen, producing an intraluminal mass. With further enlargement, the bronchus becomes obstructed, leading to distal apoptosis and infection. The tumor may also penetrate the wall of the bronchus and infiltrate along the parabronchial tissue. Fig. 15.46 into the adjacent carina or mediastinum. In other instances, the tumor grows along the broad front to produce a cauliflower-like intraparenchymal mass that compresses the surrounding lung. As in almost all types of lung cancer, the neoplastic tissue is gray-white and firm to hold. Especially when the tumors are bulky, focal areas of hemorrhage or necrosis may appear to produce red or yellow-white mottling and softening. Sometimes these necrotic foci cavitate. Histologically, squamous cell carcinoma is characterized by the presence of keratinization and slash or intercellular bridges. Keratinization may take the form of squamous pearls or individual cells with markedly eosinophilic cytoplasm. See Fig. 15.43b. These features are prominent in well-differentiated tumors, are easily seen but not extensive in moderately differentiated tumors, and are focally seen in poorly differentiated tumors. Mitotic activity is higher in poorly differentiated tumors. In the past, most squamous cell carcinomas arose centrally from the segmental or subsegmental bronchi, but the incidence of squamous cell carcinoma of the peripheral lung is increasing. Squamous metaplasia, epithelial dysplasia, and foci of frank carcinoma in situ may be seen in bronchial epithelium adjacent to the tumor mass. See Fig. 15.44. Small cell carcinoma is a highly malignant tumor with a strong relationship to cigarette smoking. Only about 1% occurs in non-smokers. Tumors may arise in major bronchi or in the periphery of the lung. There is no known pre-invasive phase. They are the most aggressive of lung tumors, metastasizing widely and virtually always proving to be fatal. Small cell carcinoma is comprised of relatively small cells with scant cytoplasm, ill-defined cell borders, finely granular nuclear. Tumor 719, a B, C, D, figure 15.43 histologic variants of lung carcinoma, a gland-forming adenocarcinoma. Hence it shows thyroid transcription factor 1 TTF1 expression, as detected by immunohistochemistry. Well-differentiated squamous cell carcinoma showing keratinization error. See small cell carcinoma. There are islands of small, deeply basophilic cells and areas of necrosis. Large cell carcinoma. The tumor cells are pleomorphic and show no evidence of squamous or glandular differentiation. Chromatin salt and pepper pattern, and absent or inconspicuous nucleolae. See Fig. 15.43c. Cells are round, oval, or spindle-shaped, and nuclear molding is prominent. There is no absolute size for the tumor cells, but in general they are smaller than 3 times the diameter of a small resting lymphocyte, a size of about 25 μ. The mitotic count is high. The cells grow in clusters that exhibit neither glandular nor squamous organization. Necrosis is common and often extensive. Basophilic staining of vascular walls due to incrustation by DNA from necrotic tumor cells at supporting effect is frequently present. Combined small cell carcinoma is a variant in which typical small cell carcinoma is mixed with non-small cell histologies, such as large cell neuroendocrine carcinoma or even spindle cell morphologies resembling sarcoma. Electron microscopy shows dense core neuroscretory granules, about 100 nm in diameter, in 2/3 of cases of small cell carcinoma. The occurrence of neuroscretory granules, the expression of neuroendocrine markers such as chromogranin, synaptophysin, and CD56, and the ability of some of these tumors to secrete hormones, for example, hormone-related protein, the cause of paraneoplastic hypocalcemia suggests that this tumor originates from neuroendocrine progenitor cells, which are present in the lining bronchial epithelium. The simplistic idea is challenged, however, by the existence of tumors comprised of a mixture of small cell carcinoma and other histologies and well-documented transformations of non-small cell carcinoma to small cell carcinoma. Among the various types of lung cancer, small cell carcinoma is the one that is most commonly associated with ectopic hormone production discussed later. Large cell carcinoma is an undifferentiated malignant epithelial tumor that lacks the cytologic features of other forms of lung cancer. The cells typically have large nuclei, prominent nucleoli, and a moderate amount of cytoplasm. See Fig. 15.43d. Large cell carcinoma is a diagnosis of exclusion since it expresses none of the markers associated with adenocarcinoma TTF1, and absent or squamous cell carcinoma 40.63. One histologic variant is large cell neuroendocrine carcinoma, which has molecular features similar to those of small cell carcinoma, but is comprised of tumor cells of larger size. Combined carcinoma. Approximately 4% to 5% of all lung carcinomas have a combined histology, including 2 or more of the aforementioned types. Any type of lung carcinoma may extend to the pleural surface and then spread within the pleural cavity or into the pericardium. Metastasis to the bronchial, tracheal, and mediastinal nose can. 720 Chapter 15 The lung. A B. F. Figure 15.44 Precursor lesions of squamous cell carcinomas. Some of the earliest mild changes in smoking, damaged respiratory epithelium include goblet cell hyperplasia, basal cell or reserve cell hyperplasia B, and squamous metaplasia C. More ominous changes include the appearance of squamous dysplasia D, characterized by the presence of disordered squamous epithelium with loss of nuclear polarity, nuclear hyperchromation, pleomorphism, and mitotic figures. Squamous dysplasia may progress through the stages of mild, moderate, and severe dysplasia. Carcinoma in situ E. The stage immediately preceding invasive squamous carcinoma F, by definition, has not penetrated the basement membrane and has cytologic features similar to those in frank carcinoma. 8D. Courtesy Dr. Addie Gazdar, Department of Pathology, University of Texas, Southwestern Medical School, Dallas, Texas. F. Reproduced with permission from Travis W.D. and L. Editors, World Health Organization Histological Typing of Lung and Pleural Tumors, Heidelberg, 1999, Springer. Figure 15.45 Cytologic diagnosis of lung cancer. The sputum specimen shows an orange, staining, keratinized squamous carcinoma cell with a prominent hyperchromatic nucleus large arrow. Of the size of the tumor cells compared with normal neutrophils small arrow. Figure 15.46 Lung carcinoma. The gray, white tumor infiltrates the lung parenchyma. Histologic sections identify this tumor as a squamous cell carcinoma. Tumor 721, be found in most cases. The frequency of nodal involvement varies slightly with the histologic pattern but averages greater than 50%. Distant spread of lung carcinoma occurs through both lymphatic and hematogenous pathways. These tumors often spread early, throughout the body except for squamous cell carcinoma, which metastasizes late outside the thorax. Metastases may be the first manifestation of an underlying occult pulmonary lesion. No organ or tissue is spared, but the adrenal glands, for obscure reasons, are involved in more than half of the cases. The liver 30% to 50%, brain 20%, and bone 20% are other favorite sites of metastasis. Secondary pathology. Lung carcinomas have local effects that may cause several pathologic changes in the lung distal to the point of bronchial involvement. Partial obstruction may cause focal emphysema. Total obstruction may lead to aglycosis. The impaired drainage of the airways is a common cause for severe suppurative or ulcerative bronchitis or bronchiectasis. Pulmonary abscesses sometimes call attention to an otherwise silent carcinoma. Compression or invasion of the superior vena cava can cause venous congestion and edema. The head and arm and, ultimately, circulatory compromise. Superior vena cava syndrome, extension to the pericardial or pleural sacs may cause pericarditis chapter 12 or pleuritis. Significant effusions, apical lung cancers in the superior pulmonary sulcus tend to invade the neural structures around the trachea, including the cervical sympathetic plexus, and produce a group of clinical findings that include severe pain and the distribution of the ulnar nerve and Horner syndrome in the thalamus, ptosis, meiosis, and anhidrosis on the same side as the lesion. Such tumors are also referred to as Pancoast tumors. Staging. The uniform TMM system for staging cancer according to its anatomic extent at the time of diagnosis is useful, particularly for comparing treatment results from different centers. Table 15.10. Clinical features. Lung cancer is one of the most insidious and aggressive neoplasms in the realm of oncology. In the usual case, it is discovered in patients in their 50 seconds or older whose symptoms are of several months' duration. Major presenting complaints are cough 75%, weight loss 40%, chest pain 40%, and dyspnea 20%. Some of the more common local manifestations of lung cancer and their pathologic bases are listed in Table 15.11. Not infrequently, lung cancer is recognized on biopsy of tissues involved by metastatic disease. Symptoms of metastasis depend on the site. For example, back pain and bone metastasis and headache, hemiparesis, cranial nerve damage, and seizures and brain metastasis. Best treatment for lung cancer is smoking prevention, which has lower lung cancer incidence in the United States among men. However, 15% of adults still smoke, and even those who quit remain at elevated risk for an extended period of time. This reality has led to early detection trials in high-risk individuals using low-dose computed tomography, which is capable of detecting some early resectable non-small cell lung cancers, but at cost of a high incidence of false positive non-cancer findings. Overall, the outlook is poor for most patients, even with incremental improvements. ABLE 15.10 International Staging System for Lung Cancer TNM Staging TIS Carcinoma in situ Adenocarcinoma in situ. Adenocarcinoma with pure lipidic pattern. 3 cm squamous cell carcinoma in situ tone tumor 3 cm without pleural or mainstem bronchus. Involvement TONI. Minimally invasive adenocarcinoma. TONIA. 1 cm. TONIM. 1. 2 cm. TONIC. 2. 3 cm. T12 tumor 3. 5 cm or involvement of mainstem bronchus but not. Carina. Visceral pleural involvement or lobar atelectasis. T2A. 3. 4 cm. T-quad 4. 5 cm. T3 tumor 5. 7 cm or 1 with involvement of parietal pleural. Chest wall including superior sulcus tumors, diaphragm, phrenic nerve, mediastinal pleura, parietal pericardium, or separate tumor nodules in the same lobe. T4 tumor 7 cm or any tumor with invasion of mediastinum, heart, brain vessels, trachea, recurrent laryngeal nerve, esophagus, vertebral body, or carina, or separate tumor. Nodules in a different ipsilateral lobe. N0 no metastases to regional lymph nodes. Non-ipsilateral intraparenchymal or parabronchial or helinodal involvement. N12 metastases to ipsilateral mediastinal or subparental lymph nodes. N3 metastases to contralateral mediastinal or hilar lymph nodes. Ipsilateral or contralateral scalene or supraclavicular lymph nodes. M0 no distant metastases. Long distant metastases monia. Separate tumor nodule in contralateral lobe or pleural nodules or malignant pleura or pericardial effusion. Mono. Single extrathoracic metastasis. A single organ. Mono. Multiple extrathoracic metastasis. Stage grouping. Stage 0 TIS N0 M0. Stage IIAN. TONI or TONIA. IAPO. TONIM. N0 M0. IA3. TONIC. Stage IBT2 N0 M0. Stage IAT quad N0 M0. Non M0. Stage IBT quad N0 M0. TONIA. TONIM. TONIC T2A. T quad non M0. T3 N0 M0. Stage Eotonia, Tonin, Tonic, T2A, T quad N4 M0, T3 non M0, T4 N0, non M0. Stage Eotonia, Tonin, Tonic, T2A, T quad N3 M0, T3, T4 N4 M0. Stage A T3, T4 N3 M0. Stage IVAT any N pneumonia, mono. Stage IVBT any N pneumonia. And thoracic surgery, radiation therapy, and chemotherapy, the overall 5-year survival rate is only 18.7%. 5-year survival rate is 52% for cases detected when the disease is still localized, 22% when there is regional metastasis, and only 4% with distant metastasis. In general, adenocarcinoma and squamous cell carcinoma tend to remain localized longer and have a slightly better prognosis than small cell carcinoma, which is usually advanced by the time it is discovered. 722 Chapter 15 below. Table 15. 1 Local effects of lung-chewer spawner at clinical feature pathologic basis. Call 50%. 75% involvement of central airways. Hemoptysis 25%. 50% hemorrhage from tumor in airway. Chest pain 20% extension of tumor into mediastinum, pleura, or chest wall. Pneumonia, abscess, lobar airway obstruction by tumor collapse. Typhoid pneumonia tumor obstruction, accumulation of cellular lipid and foaming macrophages. Pleural effusion tumor spread into pleura. Hoarseness, recurrent laryngeal nerve invasion. Esophageal invasion. Diaphragm paralysis, phrenic nerve invasion. Rib destruction, chest wall invasion. SVC syndrome, SVC compression by tumor. Horner syndrome, sympathetic ganglia invasion. Pericarditis, tamponade pericardial involvement, SVC, superior vena cava, Treatment of patients with adenocarcinoma and activating mutations in EGFR present in about 15% of all cases or in other tyrosine kinases with specific kinase inhibitors prolong survival. Many tumors that recur carry new mutations that generate resistance to these inhibitors, proving that these drugs are hitting their target. In contrast, activating CRAS mutations present in approximately 30% of cases of adenocarcinoma appear to be associated with a worse prognosis, regardless of treatment, in an already grim disease. Because of the mutagenic effects of carcinogens and tobacco smoke, lung cancers have a high burden of potentially antigenic neoantigens. Accordingly, both adenocarcinoma and squamous cell carcinoma respond in subsets of cases to checkpoint inhibitor therapy, which has produced improvements in survival and is now approved for use. Small cell carcinoma is quite sensitive to radiation therapy and chemotherapy, and approximately 10% of patients with limited disease survive for 5 years and may be cured. Unfortunately, however, most patients present with advanced stage disease, for these patients, despite excellent initial responses to chemotherapy, the median survival is approximately 10 months and the cure rate is close to 0. New approaches involving use of antibody-drug conjugates that deliver chemotherapy selectively to tumor cells and immune checkpoint inhibitors are being tested. Paraneoplastic syndromes. Lung carcinoma can be associated with several paraneoplastic syndromes, Chapter 7, some of which may antedate the development of a detectable pulmonary lesion. Hormones or hormone-like factors elaborated by lung cancer cells and associated syndromes include antidiuretic hormone ADH, inducing hyponatremia due to inappropriate ADH secretion. Adrenocorticotropic hormone ACT, producing Cushing's syndrome. Parathormone, parathyroid hormone-related peptide, prostaglandin E, and some cytokines, all implicated in the hypercalcemia often seen with lung cancer. Calcitonin, causing hypocalcemia, gonadotropins, causing gynecomastia, serotonin and bradykinin, associated with the carcinoid syndrome. The incidence of clinically significant paraneoplastic syndromes related to these factors in lung cancer patients ranges from 1% to 10%, although a much higher proportion of patients show elevated serum levels of these and other peptide hormones. Any histologic type of tumor may occasionally produce any one of the hormones, but tumors that produce ACT and ADH are predominantly small cell carcinomas, whereas those that produce hypercalcemia are mostly squamous cell carcinomas. Other systemic manifestations of lung carcinoma include the Lambert-Eaton myasthenic syndrome, Chapter 27, in which muscle weakness is caused by autoantibodies possibly elicited by tumor ionic channels directed to the neuronal calcium channel, peripheral neuropathy, usually purely sensory, dermatologic abnormalities, including acanthosis nigricans, Chapter 25, hematologic abnormalities, such as leukemoid reactions, hypercoagulable states, such as Trousseau syndrome, deep vein thrombosis, and thromboembolism, and finally, a peculiar abnormality of connective tissue called hypertrophic pulmonary osteoarthropathy, associated with clubbing of the fingers. The concepts carcinomas of the lung. The three major histologic subtypes are adenocarcinoma, most common, squamous cell carcinoma, and small cell carcinoma. Each of these is clinically and genetically distinct. Small cell lung carcinomas are best treated by chemotherapy because almost all are metastatic at presentation. Other carcinomas may be curable by surgery if limited to the lung. Combination chemotherapy also is available along with tyrosine kinase inhibitors for those with EGFR, ALK, ROS, and MET mutations. Smoking is the most important risk factor for lung cancer. The most common subtype related to smoking in men and women is adenocarcinoma. Adenocarcinoma also is the most common subtype in non-smokers. Precursor lesions include atypical adenomatous hyperplasia and adenocarcinoma insidiformly bronchialveolar carcinoma. For adenocarcinomas and squamous dysplasia for squamous cell carcinoma, tumors 3 cm or less in diameter characterized by pure growth along pre-existing structures, lipidic pattern without stromal invasion, are now called adenocarcinoma in situ. Lung cancers, particularly small cell lung carcinomas, often cause paraneoplastic syndromes. Neuroendocrine proliferations in tumors. The normal lung contains neuroendocrine cells within the epithelium as single cells or as clusters, the neuroepithelial bodies. Virtually all pulmonary neuroendocrine cell hyperplasias are secondary to airway fibrosis and or inflammation. The exception is a rare disorder called diffuse idiopathic. 723. Pulmonary neuroendocrine cell hyperplasia, in which hyperplasia occurs in the absence of an inflammatory stimulus. Neoplasms of neuroendocrine cells in the lung include benign tumorless, small, inconsequential, hyperplastic nests of neuroendocrine cells seen in areas of scarring or chronic inflammation, carcinoids, and the already discussed highly aggressive small cell carcinoma and large cell neuroendocrine carcinoma of the lung. Carcinoid tumors are classified separately, since they differ significantly from carcinomas with evidence of neuroendocrine differentiation in terms of incidence and clinical, epidemiologic, histologic, and molecular characteristics. For example, in contrast to small cell and large cell neuroendocrine carcinomas, carcinoids may occur in patients with multiple endocrine neoplasia type 1. Carcinoid tumors represent 1% to 5% of all lung tumors. Most patients with these tumors are younger than 60 years of age, and the incidence is equal for both sexes. Approximately 20% to 40% of patients are non-smokers. Carcinoid tumors are low-grade malignant epithelial neoplasms that are subclassified into typical and atypical carcinoids. Morphology. Carcinoids may arise centrally or may be peripheral. On gross examination, the central tumors grow as finger-like or spherical polypoid masses that commonly project into the lumen of the bronchus and are usually covered by an intact mucosa fin. 15. 47a. They rarely exceed 3 to 4 cm in diameter. Most are confined to the mainstem bronchi. Others, however, penetrate the bronchial wall to fan out in the parabronchial tissue, producing the so-called collar button lesion. Peripheral tumors are solid and nodular. Histologically, the tumor is composed of organoid, tracheal, palisading, ribbon, or rosette-like arrangements of cells separated by delicate fibrovascular stroma. In common with the lesions of the gastrointestinal tract, the individual cells are quite regular and have uniform round nuclei and a moderate amount of eosinophilic cytoplasm. Fig. 15. 47b. Typical carcinoids have fewer than 2 mitosis per 10 high power fields and lack necrosis, while atypical carcinoids have between 2 and 10 mitosis per 10 high power fields and / or foci of necrosis. Atypical carcinoids also show increased pleomorphism, have more prominent nucleoli, and are more likely to grow in a disorganized fashion and invade lymphatics. On electron microscopy, the cells exhibit the dense core granules characteristic of other neuroendocrine tumors and, by immunohistochemistry, are found to contain serotonin, neuron-specific enolase, lomycin, calcitonin, or other peptides. Tumors. Clinical features. The clinical manifestations of bronchial carcinoids emanate from their intraluminal growth, their capacity to metastasize, and the ability of some of the lesions to elaborate vasoactive amides. Persistent cough, hemoptysis, impairment of drainage of respiratory passages with secondary infections, bronchiectasis, emphysema, and elephantiasis are all byproducts of the intraluminal growth of these lesions. Most interesting are functioning lesions capable of producing the classic carcinoid syndrome, characterized by intermittent attacks of diarrhea, flushing, and cyanosis. Approximately 10% of bronchial carcinoids give rise to this syndrome. Overall, most bronchial carcinoids do not have secretory activity and do not metastasize to distant sites but follow a relatively benign course for long periods and are therefore amenable to resection. The reported 5-year survival rates are 95% for typical carcinoids, 70% for atypical carcinoids, 30% for large cell neuroendocrine carcinoma, and 5% for small cell carcinoma, respectively. Miscellaneous tumors. Benign and malignant mesenchymal tumors, such as inflammatory myofibroblastic tumor, fibroma, fibrosarcoma, lymphangiomyomatosis, leiomyoma, leiomyosarcoma, lipoma, hemangioma, and chondroma, may occur in the lung but are rare. Hematolymphoid tumors similar to those described in other organs may also affect the lung, either as isolated lesions or, more commonly, as part of a generalized disorder. These include Langerhans cell histiocytosis, a B figure 15.47 bronchial carcinoid, a carcinoid growing as a spherical mass arrow protruding into the lumen of the bronchus. Either tumor cells have small, rounded, uniform nuclei and moderate amounts of cytoplasm. Courtesy Dr. Thomas Cross, Department of Pathology, the University of Chicago, Pritzker School of Medicine, Chicago, Ill. 724, Chapter 15, the lung. Hodgkin lymphomas, lymphomatoid granulomatosis, an unusual EBV-positive B-cell lymphoma, and low-grade extranodal marginal zone B-cell lymphoma, Chapter 13. Pulmonary hamartoma is a relatively common lesion that is usually discovered as an incidental, rounded radio-opacity coin lesion on a routine chest film. Most are solitary, less than 3 to 4 cm in diameter, and well circumscribed. Pulmonary hamartoma consists of nodules of connective tissue intersected by epithelial clefts. Cartilage is the most common connective tissue, but there may also be fibrous tissue and fat. The clefts are lined by ciliated or non-ciliated epithelium. Fig. 15.48. The traditional term hamartoma is retained for this lesion, but it is in fact a clonal neoplasm associated with chromosomal aberrations involving either 621 or 12q15. These aberrations are found in the mesenchymal component, while the epithelial component appears to represent entrapped respiratory epithelium. Lymphangioliomyomatosis is a pulmonary disorder that primarily affects young women of childbearing age. It is characterized by a proliferation of perivascular epithelioid cells that express markers of both melanocytes and smooth muscle cells. The proliferation distorts the involved lung, leading to cystic, emphysema-like dilation of terminal air spaces, thickening of the interstitium, and obstruction of lymphatic vessels. Lesional epithelioid cells frequently harbor loss-of-function mutations in the tumor suppressor TSC clone, one of the loci linked to tuberous sclerosis, Chapter 28. The protein encoded by TSC clone, tuberin, is a negative regulator of mammalian target of rapamycin mTOR, a key regulator of cellular metabolism. While TSC clone mutations point to increased mTOR activity as a pathogenic factor, the disorder remains poorly understood. A strong tendency to affect young women suggests that estrogen contributes to the proliferation of perivascular epithelioid cells, which often express estrogen receptors. Patients most commonly present with dyspnea or spontaneous pneumothorax, the latter related to emphysematous changes. The disease tends to be slowly progressive over a period of several decades. mTOR inhibitors slow or prevent the deterioration of lung function, but must be continued indefinitely. Only lung transplantation is curative, mediastinal. Table 15.12 neoplasms and other masses, anterior mediastinal thymoma, teratoma, lymphoma, thyroid lesions, parathyroid tumors, metastatic carcinoma, posterior mediastinal. Neurogenic tumors, schwannoma, neurofibroma, lymphoma, metastatic tumor, most are from the lung, bronchogenic cyst, gastroenterocaridium, middle mediastinal. Bronchogenic cyst, pericardial cyst, lymphoma. Inflammatory myofibroblastic tumor is a rare tumor that is more common in children, with an equal male to female ratio. Presenting symptoms include fever, cough, chest pain, and hemoptysis. It may also be asymptomatic. Imaging studies usually show a round, well-defined peripheral mass. Calcification is present in about a quarter of cases. Grossly, the lesion is firm, 3 to 10 cm in diameter, and grayish-white. Microscopically, there is proliferation of spindle-shaped fibroblasts and myofibroblasts, lymphocytes, plasma cells, and peripheral fibrosis. Some of these tumors have activating rearrangements of the ALK receptor tyrosine kinase gene, located on 2.3, and treatment with ALK inhibitors have produced sustained responses in such cases. Tumors in the mediastinum may arise in mediastinal structures or may be metastatic from the lung or other organs. They often invade or compress the lungs. Table 15.12 lists the most common tumors in the various compartments of the mediastinum. Specific tumor types are discussed in appropriate sections of this book. Metastatic tumors. The lung is the most common site of metastatic neoplasms. Both carcinomas and sarcomas arising anywhere in the body may spread to the lungs via the blood or lymphatics or by direct continuity. Esophageal carcinoma and mediastinal lymphoma may also invade the lung by direct extension. Morphology. The pattern of metastatic spread to the lungs is quite variable. In the usual case, multiple discrete nodules cannonball lesions are scattered throughout all lobes, particularly in the lung periphery Fig. 15.49. Other times spread takes the form of a solitary nodule, endobronchial or pleural involvement, pneumonic consolidation, and / or some combination thereof. Also have lipidic growth similar to adenocarcinoma in situ are seen occasionally with metastatic carcinomas and may be associated with any of the listed patterns. Figure 15.48 Pulmonary hamartoma. There are islands of cartilage, fat, smooth muscle, and a trapped respiratory epithelium. 725. Figure 15.49 Numerous metastases to lung from a renal cell carcinoma. Courtesy Dr. Michelle Mantle, Brigham and Women's Hospital, Boston, Mass. Pleural. Most pleural disorders stem from complications of disease arising elsewhere in the body. Secondary infections and inflammations are particularly common findings at autopsy. Important primary disorders include 1. Intrapleural bacterial infections, presumably the product of seeding from transient bacteremia, and 2. Mesothelioma, a primary pleural neoplasm discussed later. Pleural effusion. Pleural effusion is a common manifestation of both primary and secondary pleural diseases, which may be inflammatory or non-inflammatory. Normally, no more than 15 ml of serous, relatively acellular, clear fluid lubricates the pleural surface. Accumulation of pleural fluid occurs in the following settings. Increased hydrostatic pressure, as in congestive heart failure. Increased vascular permeability, as in pneumonia. Decreased osmotic pressure, as in nephrotic syndrome. Increased intrapleural negative pressure, as in aglitosis. Decreased lymphatic drainage, as in mediastinal carcinomatosis. Inflammatory pleural effusion serous, serifibrinous, and fibrinous pleuritis all have an inflammatory basis, differing only in the intensity and duration of the process. The most common causes of pleuritis are disorders associated with inflammation of the underlying lung, such as tuberculosis, pneumonia, lung infarction, lung abscess, and bronchiectasis. Rheumatoid arthritis, systemic lupus erythematosus, uremia, diffuse systemic infections, and metastatic involvement of the pleura can also cause serous or serifibrinous pleuritis. Radiotherapy for tumors in the lung or mediastinum often causes a serifibrinous pleuritis. In most of these disorders, the pleural reaction is minimal, and the fluid exudate is resorbed with either resolution or organization of the fibrinous component. However, large amounts of fluid sometimes accumulate and compress the lung, causing respiratory distress. A purulent pleural exudate impairment usually results from bacterial or mycotic seeding of the pleural space. Most commonly, this seeding occurs by contiguous spread of organisms from intrapulmonary infection, but occasionally it occurs through lymphatic or hematogenous dissemination from a more distant source. Rarely, infections below the diaphragm, such as the subdiaphragmatic or liver abscess, may extend by continuity through the diaphragm into the pleural spaces, more often on the right side. Impairment is characterized by loculated, yellow-green, creamy pus composed of masses of neutrophils that mix with other leukocytes. Although impairment may accumulate in large volumes up to 500 to 1,000 ml, usually the volume is small, and the pus becomes walled off by fibrosis. Impairment may resolve, but more often the exudate organizes into dense, tough fibrous adhesions that frequently obliterate the pleural space or envelop the lungs. Either can seriously restrict pulmonary expansion. Hemorrhagic pleuritis manifested by sanguineous inflammatory exudates is infrequent and is most often associated with hemorrhagic diatheses, rickettsial infections, and neoplastic involvement of the pleural cavity. Sanguineous exudate must be differentiated from hemothorax discussed later. When hemorrhagic pleuritis is encountered, a careful search should be made for the presence of tumorous cells. Non-inflammatory pleural effusions. Non-inflammatory collections of serous fluid within the pleural cavities are called hydrothorax. The fluid is clear and straw colored. Hydrothorax may be unilateral or bilateral, depending on the underlying cause. The most common cause of hydrothorax is heart failure, and for this reason it is usually accompanied by pulmonary congestion and edema. Hydrothorax may also be seen in any other systemic disease associated with generalized edema, such as patients with renal failure or cirrhosis of the liver. Escape of blood into the pleural cavity is known as hemothorax. It is most commonly a complication of trauma or less commonly surgery, but can also accompany rupture of an aortic aneurysm, a setting in which it is almost invariably fatal. Gyrothorax is an accumulation of milky fluid, usually of lymphatic origin, in the pleural cavity. Chyle is milky white because it contains finely emulsified fats. Gyrothorax is most often caused by thoracic duct trauma or by obstruction of a major lymphatic duct, usually by malignancy. Such cancers most commonly arise within the thoracic cavity and invade the lymphatics locally, but occasionally more distant cancers metastasize via the lymphatics and grow within the right lymphatic or thoracic duct, producing obstruction. Pneumothorax. Pneumothorax refers to air or gas in the pleural cavities and is most commonly associated with emphysema, asthma, Chapter 15, the lung, and tuberculosis. It may be spontaneous, traumatic, or therapeutic. Spontaneous pneumothorax may complicate any form of pulmonary disease that causes emphysematous changes. An abscess cavity that communicates either directly with the pleural space or with the lung interstitial tissue may also lead to the escape of air. In the latter circumstance, the air may dissect through the lung substance or back through the mediastinum interstitial emphysema, eventually entering the pleural cavity. Traumatic pneumothorax is usually caused by some perforating injury to the chest wall, but sometimes the trauma pierces the lung and thus provides two avenues for the accumulation of air within the pleural spaces. Absorption of the air in the pleural space occurs in spontaneous and traumatic pneumothorax, provided that the original communication seals itself. Of the various forms of pneumothorax, the one that attracts the most clinical attention is spontaneous idiopathic pneumothorax. This entity is encountered in relatively young people. Seems to be due to rupture of small, peripheral, usually apical subpleural bloods, and usually subsides spontaneously as the air is resorbed. Current attacks are common and can be quite disabling. Pneumothorax may cause marked respiratory distress due to collapse and agotasis of the lung. In some instances, the pleural defect acts as a flap valve and permits the entrance of air during inspiration but fails to permit its escape during expiration. The result is called a tension pneumothorax, in which progressively increasing intrapleural pressure may compress vital mediastinal structures in the contralateral lung. Pleural tumors. The pleura may be involved by primary or secondary tumors. Secondary metastatic involvement is far more common than are primary tumors. The most frequent metastatic malignancies arise from primary neoplasms of the lung and breast. In addition to these cancers, malignancy from any organ of the body may spread to the pleural spaces. Ovarian carcinomas, for example, tend to cause widespread implants in both the abdominal and thoracic cavities. Most metastatic implants produce a serous or serous rhinous effusion that often contains neoplastic cells. For this reason, careful cytologic examination of the segment is of considerable diagnostic value. Solitary fibrous tumor. Solitary fibrous tumor is a soft tissue tumor with a propensity to occur in the pleura and, less commonly, in the lung, as well as other sites. The tumor is often attached to the pleural surface by a pedicle. It may be small 1 to 2 cm in diameter or may reach an enormous size, but it tends to remain confined to the surface of the lung Fig. 15.50. Morphology grossly. Solitary fibrous tumor consists of dense fibrous tissue with occasional cysts filled with viscid fluid. Microscopically, the tumor shows whorls of reticulin and collagen fibers among which Figure 15.50 solitary fibrous tumor. Cut surface is solid with a whorled appearance. Courtesy Dr. Justine A. Barletta, Department of Pathology, Brigham and Women's Hospital, Boston, Mass. Interspersed spindle cells resembling fibroblasts. Rarely, this tumor may be malignant, marked by pleomorphism, mitotic activity, necrosis, and large size 10 cm. Tumor cells are positive for CD34 and SDH6 and negative for keratin by immunostaining, features that help to distinguish this lesion from malignant. Mesothelioma, which has the opposite phenotype, a solitary, fibrous tumor, has no relationship to asbestos exposure. 726. Solitary fibrous tumor is highly associated with a cryptic inversion of chromosome 12 involving the genes NAB12 and SDH6. This rearrangement creates the NAB12 SDH6 fusion gene that appears to be virtually unique to solitary fibrous tumor. It encodes a chimeric transcription factor that is hypothesized to be a key driver of tumor development. Malignant mesothelioma, although rare, has assumed great importance in the past few decades because of its increased incidence among people with heavy exposure to asbestos. See pneumoconiosis. Thoracic mesothelioma arises from either the visceral or the parietal pleura in coastal areas with shipping industries in the United States and Great Britain, as well as in Canadian, Australian, and South African mining areas. As many as 90% of mesotheliomas are asbestos-related. The lifetime risk of developing mesothelioma in heavily exposed individuals is as high as 7% to 10%. There is a long latent period of 25 to 45 years for the development of asbestos-related mesothelioma, and there seems to be no increased risk of mesothelioma in asbestos workers who smoke. This is in contrast to the risk of asbestos-related lung carcinoma, which is markedly magnified by smoking. Thus, asbestos workers, particularly those who smoke, are at much higher risk of dying of lung carcinoma than mesothelioma. Asbestos bodies, see Fig. 15. 20 are found in increased numbers in the lungs of patients with mesothelioma. Another marker of asbestos exposure, the asbestos plaque, has been previously discussed. See Fig. 15.21. 727. Although several cytogenetic abnormalities have been detected, the most common is homozygous deletion of chromosome 9 leading to loss of the tumor suppressor gene CDKN12A, which occurs in about 80% of mesotheliomas. Sequencing of mesothelioma genomes has shown that driver mutations are also common in the NF12 neurofibromatosis 2 gene, which encodes a cell signaling regulator, and BA-POM, which encodes a protein that interacts with the BRCA tumor suppressor and appears to function as a chromatin regulator. Note, individuals with germline mutations in BA-POM have a markedly elevated risk of mesothelioma, further implicating this tumor suppressor gene in the pathogenesis of the disease. In morphology, malignant mesothelioma is a diffuse lesion arising from either the visceral or the parietal pleura that spreads widely in the pleural space and is usually associated with extensive pleural effusion and direct invasion of thoracic structures. The affected lung becomes enshrined by a thick layer of soft, gelatinous, grayish-pink tumor tissue. Fig. 15.51. Microscopically, malignant mesothelioma may be epithelial. 60% to 80%, sarcomatoid 10% to 12%, or biphasic 10% to 15%. This is in keeping with the fact that mesothelial cells have the potential to develop as epithelium-like cells or mesenchymal. Stromal cells. The epithelioid type of mesothelioma consists of cuboidal, columnar, or flattened cells forming tubular or papillary structures, resembling adenocarcinoma. Fig. 15.52a. Immunohistochemistry. Calorie stains are very helpful in differentiating it from pulmonary adenocarcinoma. Most mesotheliomas show strong positivity for keratin proteins, calretin and Fig. 15.52b, Wilms tumor 1WT1. Cytokeratin 5/6, and podoplanin, and unlike adenocarcinomas are negative for claudin. This panel of antibodies is diagnostic in a majority of cases when interpreted in the context of morphology. In clinical presentation, the mesenchymal type of mesothelioma, sarcomatoid type, has an appearance resembling fibrosarcoma. B. Figure 15.52 histologic variants of malignant mesothelioma. Epithelioid type, B mixed type, Stain for carotene and immunoperoxidase method. The epithelial component is strongly positive dark brown, while the sarcomeroid component is less so. Courtesy Dr. Thomas Cross, Department of Pathology, the University of Chicago, Pritzker School of Medicine, Chicago, Ill. Sarcomeroid mesotheliomas tend to have lower expression of many of the markers described previously, and some may be positive only for keratin. The biphasic type of mesothelioma contains both epithelioid and sarcomeroid patterns. See Fig. 15, 52b. Figure 15.5. One malignant mesothelioma. Note the thick, firm, white pleural tumor tissue that encased the lung. Clinical features: the presenting symptoms are chest pain, dyspnea, and, as noted, recurrent pleural effusions. Concurrent pulmonary asbestosis fibrosis is present in only 20% of individuals with pleural mesothelioma. The lung is invaded directly, and there is often metastatic spread to the hilar lymph nodes and, eventually, to the liver and other distant organs. 50% of patients die within 12 months of diagnosis. If you survive longer than 2 years, aggressive therapy, extrapleural pneumonectomy, chemotherapy, radiation therapy seems to improve this poor prognosis in some patients. Mesotheliomas also rise in the peritoneum, pericardium, tunica vaginalis, and genital tract benign adenomatoid tumors. See Chapter 21. Peritoneal mesotheliomas are related to heavy asbestos exposure in 60% of male patients. The number is much lower in females. Although in about half of cases the disease remains confined to the abdominal cavity, intestinal involvement frequently leads to death from intestinal obstruction or inanition. Pleural. Chapter 15. The lung. Suggested readings: Asthma, Barnes, P.J. Cellular and molecular mechanisms of asthma and cough. Acute lung injury. Clint Sci. 13 on 1541, 2017. View comparing inflammatory and cellular math. M.A. et al. Acute respiratory distress syndrome, NAD, Reverend Dis mechanisms of asthma and chronic obstructive pulmonary disease and how